is it a clash? That issue being the issue by Dr. Ravindra Babu sir. And from here on, Dr. Ranga Gangadharan, Associate Professor, Department of Pathology, NIH Institute of Medical Sciences, is going to be your master of ceremony till the end of the program. Thank you.
Thank you so much, sir. I must say, Gurudeva Marathi Chhan ho, right? Anyway, very, very good morning to one and all. It is with great pride and pleasure that I, Dr. Vandana, on behalf of the Department of Pathology, NIMH Institute of Medical Sciences, extend a very, very warm welcome to the august audience present here, physically as well as online. We feel extremely blessed to have this plethora of experts, right from experienced thought to the young postgraduates amongst us today. Pulmonary pathology. The topic was chosen by the organizing committee with a lot of deliberation, keeping in mind the deluge of the pandemic as well as the environmental liabilities that we face today. The art of medicine, especially that of pulmonary medicine, is a tribute to teamwork, and that is why we have tried to incorporate the view of the pulmonologist and the radiologist in today's session. So, ladies and gentlemen, without wasting any more time, I think we will start our journey on the updates of pulmonary pathology for the day. It is my privilege that the first speaker today is a pulmonologist par excellence, Dr. G. Ravindra Babu, who will be speaking to us on what is expected of a pathologist. Interestingly called, tissue is the issue. And I now call upon Dr. Sri Lakshmi, Associate Professor, Department of Pathology, to introduce our speaker to us. Thank you.
Good morning, one and all. It is a great privilege and honor to introduce to you Dr. Ravindra Babu sir, who is an esteemed alumnus of Andhra Medical College. He has attained all his medical degrees, MBA, Diploma and Master in Pulmonary Pathology from Andhra Medical College. Following this, he has entered into government service and served in various capacities. He served as Superintendent of Government Hospital for Chest and Communicable Diseases for 8 years from 1995 to 2003. He retired from Andhra Pradesh Medical and Health Services as Professor and HOD of Pulmonary Medicine in August 2009. He has served as Professor and Head of the Department of Pulmonary Medicine in our institute for 9 years from 2012 to 2021 till superannuation. He continues to serve us as Emeritus Professor in our institute. During his illustrious career, he has received many awards and presentations. He received the Dr. R. Vishwanathan Prize for standing first in the university examination in the diploma examination. He won awards consecutively for best paper in state conferences in 1987 and 86. He has won the Sarojyoti Award for Best Poster in National Conference held in Hyderabad. In addition, he has received several awards for operations and lectures. And he has also, during his tenure as superintendent of Government Hospital, he has received certificates twice from the district director. His better half is Dr. N. Nagawani, who is an eminent gynecologist. And sir, it is an honor to have you here today as the first speaker on Tissue is the Issue. Welcome, sir.
Thank you, ma'am. As sir is taking the stage, I humbly request our principal, Dr. Radha Madhav Tripathi, sir, to please chair this session. Thank you, sir.
Good morning, ladies and gentlemen. At the outset, I thank and the Department of Pathology, Dr. Bhagyalakshmi Madam and dear friend Dr. Sharma for inviting me as a faculty. I am very much pleased that the Department of Pathology and Andhra Pradesh chapter of IAPM has identified the pulmonary pathology as a topic of interest and has chosen as the theme for the 60th midterm conference. The pulmonology as a specialty is advancing rapidly and increasing the scope for tissue samples. And that's why there is a need for insights, valuable insights from pathologists in this field. So I am happy the CM is conducted. And on behalf of the pulmonologists and the Department of Pulmonology, I invite the faculty from Mumbai, Dr. Pradeep Vaidishwar, Dr. Dina Desai, and also Dr. Sarada. The COVID-19 has brought the specialty of pulmonology into the limelight. But behind the scenes is the pathologist who did an incredible job of setting up, scaling up, and keeping up with the sustaining load of COVID tests and other tests like CRP, CBCs, etc. Not only for COVID patients and also for other patients. So this meditation shows the great tribute from the great physician to the pathologist. What are the approaches available for tissue sampling? The CT-guided biopsy, clinical located variations. Nowadays they do CT-guided biopsy, but whenever the Russian process in 83, 84, we did lot of biopsies for regular tumors blindly, almost 22. So then 100. After that, the cytopathology is not ready. So we have to do fluid biopsy for the petrol lesion. CTs and USCs are not available, we have to do it manually. And one of my postgrad had presented this, collected this, and presented in 1989 our national conference for the Awa session. Everybody appreciated. Maybe at that time nobody is doing biopsy in the pathology department. And one of the lecturers asked the PG to take the photographs of the bits of the sample for the auction. Actually, I wanted to show to the judge. Sir, there is no need to show the bits of the pathology. What is important is, these are enough for the pathologists to do the diagnosis. That is most important. Of course, if they didn't do the price to the paper, that is given to some paper, which is the cardiac is not very common. Anyway, that is about the issue about the tissue. Nowadays, CT-guided biopsy is not only done by the pulmonologist, but also the radiologist. And medical laparoscopy, now we have radiology as well as radiology laparoscopy, do the pleural biopsy. We used to do with advanced biopsy or cold needle or even sometimes insulin. Now the flexible bronchoscopy. Incidentally, Andhra Medical College is the first medical college which procured the flexible bronchoscopy in 95 around the command state. And we did the bronchoscopies in Andhra Pradesh. So with the flexible bronchoscopy, you can do bronchial machines, bronchial machines, bronchoalveolar larynx, endobronchial biopsy, and transbronchial lead aspiration biopsy, transbronchial lung biopsy, and transbronchial cryobiopsy. All these are not done in Andhra Pradesh, but not in Andhra Pradesh. And recent advanced investigation in endobronchial EMUS, Dr. Sunil Kumar will be deliberating on it. And now it is there in 3 centers in Visakhapatnam and Vijayawada and Guntur and also in many centers in Bangalore. Cultural and Marathi, video assisted for the happening, it is not done by surgeons. And my advice to all the physicians or the pulmonologists, don't forget to palpate the neck nerves. In many of the cases, tuberculosis or started, if you palpate the lymph node and send it for biopsy, it gives an adequate picture. So I always advise my students, the first thing you should do is palpate the lymph nodes. Most of the clinical medicine will teach you, but another is a waste. Most important is the palpation of the lymph nodes and the observation. Other procedures like electromagnetic navigation bronchoscopy, virtual bronchoscopy, autofluorescence bronchoscopy, and narrow band imaging, and nowadays robotic bronchoscopy.
No, they don't. I can.
So these are done in United States. And these are very costly. Compared to the reverse bronchoscopy, there is not much. The TBLK is from 40% of the yield. See the TBLK, the reverse, whether they are ELD and the robotic, they yield around 70%, not much difference. And see, for example, the ELD is used in the United States, and that is not used in Japan. It is a highly costly effect, but it is not much yield compared to the reverse. Now, what is important is that you must do a disease-specific sampling. See, the transplantable lung cancer special TBLK is minimally invasive, usually takes 4 to 6 weeks. And this is a procedure of choice for sarcoidosis, pneumonitis, lymphangitis, large pneumatosis, pneumonia, and alveolar proteinosis, and many other infections. And foreign endobronchial biopsy increases the yield. So this is not to be done when the large amount of tissue is needed or when the disease pattern is patched. You should not do it. So you must know what to do and when to do. And another one is the transbronchial cryobiopsy. Now it is done in Visakhapatnam as well as Guntur and Hyderabad. And until
PPT is going in.
and larger gas samples are so these are used for central peribronchial and diffuse pathologies like EAP or NSAP or for other things, particularly cardiac. What are the limiting factors in lung disease tissue sampling and diagnostic access? For tissue sampling, disease-specific procedures. As I said,
Screens only
disease-specific procedure. And expert is the interest to pulmonologist. You must know how many passes you have to do. And the evaluation of the liver, particularly for cancer, or the liver of tumor, or reduction of hormones, and further pathology. See, the expert is in pulmonary histopathology. That is important. And most important, which we don't do usually, is to provide proper history and radiological findings to the pathologist. The studies show that in 20% of the times, if we provide good history, the pathology changes the diagnosis. And these are the guidelines in 1980 from the American Thoracic Society, European Respiratory Society, Japanese Respiratory Society, and National about the idiopathic pulmonary pneumonia. They identified 4 patterns in HRCT, EAP pattern, probable EAP pattern, indeterminate per EAP pattern, and alternator. 4 patterns from HRCT. See, everyone must be familiar with these patterns. And here, you must know when to do the central tissue and not to central tissue. The UAP and probably AAP patterns usually become very fast. See, for example, both have a subpleural and basal location, but in UAP there is a honeycomb. A typical honeycomb which I recognize from the SRCP. Whereas in probably AAP, there is a reticular pattern which is subpleural and basal.
కింద సమాజంగా ఉంది కదా సమాజం ఆఫ్ చేశారు
The
ఎందుకంటే
radiologist
కదా
has to search for interaction located.
అవ్వదు సార్ లైవ్ ఆపండి
Now, issue is still issue in case of intermediate for engaged pattern or an alternate pattern where you cannot find the real diagnosis with the history or with the investigations. Here, previously, surgical biopsy used to be done. Now, the 1952 guidelines advise transcontinental terror biopsy as an alternative. But it should be done in an expert centers. It is done in Visakhapatnam in 3 centers and also in Puttur as well as Vijayawada and Hyderabad. These are all our guidelines for histopathology. Say UAP, probably internet for vision, alternative diagnosis. All pathologists, all pathologists must be aware of these guidelines. There are also guidelines for chronic
అంతే ఉంటుంది
Now, when you find a related pattern on the church, it is IPF, sometimes they report as an IPF. You should never report as TT as an IPF. You should always report it as a UAP. Now, is it IPF? So, the mnemonic is what I tell you is rescued ABCD. That is rescued A, aspergillosis, bird cancer disease. That is chronic history for the history. For the test, CTD, connective tissue diseases, this is the history and do the test. And plus, more importantly, that's the use of X-ray, microscope, and dentistry software is so all these, you remember what to ask. So you must exclude before you say it is an
ఇక్కడికి వచ్చి ఉంటాం మనోడికి
So this is important, even if it is NSIP or most of the realists, because most of the, you cannot definitely say on the histopathology what is it, corporate drugs or CKD or something else. That's why the issue is not the gold standard for identification. With the consensus opinion of multidisciplinarity, consisting of pulmonologists, radiologists and pathologists. The medium is all of them should be familiar with the features of those. And about the patient medicine, personal medicine and conjugate therapy. The molecular pathology has revolutionized the understanding and the management of adenocarcinoma with the discovery of the oncogenic mutations. Thanks to the pathologists. There are a lot of mutations. And EVC DNA is also important for diagnosis. This is the best process for level staging, diagnosis surgery. Particularly with the help of CAT scan and also growth affect evaluation with the pathologist. This is staging before surgery. And thoracic candidates for lung cancer. This is the cornerstone for management of
దీంట్లో ఓపెన్ చేయకండి ఇంకా వాట్సాప్ అది సౌండ్
led by pathologists, as pulmonologists, thoracic surgeon and oncologists, both radiation as well as chemotherapy and movers. And liquid biopsy. The failure rates from tissue biopsy based next generation sequences are 14%. This is with next generation sequences. So even with PCR it will be around 30%. 40% See, now the liquid biopsy with examination of the tumor components in the blood, like circulating tumor cells, the ctDNAs, circulating tumor DNAs, the tumor derived exosomes. Now the drugs are made in this field. And these are PCR and NGS based multi-target approaches. The FDA approved test for NSLC or the RT-PCR test for ABA mutation in the lung cancer, or the NGS based test for other mutations. And EGFR2 780 mutation in recursion cases, allowing the treatment with new drug, or selective new drug, to revolutionize the treatment of the recursion cases. This is not FDA approved, and many people still use it. And recently in March, the EU PD-L1 for the checkpoint inhibitors were also isolated from the tumor-derived exosomes. So liquid biopsy is doing a lot of advances, but still it is complementary to the tissue-based molecular pathology. And in future, I hope that this will be advanced. These are the emerging technologies for early tumors, direct intradermal chemotherapy or gene therapies, plasma placement of digital markers to guide radiation and surgery, radiotherapy and photodiagnostics. And bronchoscopy thermal microablation on lung carcinoma for lung cancer. This is now in the clinical trials phase, but in Hyderabad they are doing this for the reduction of the carcinoma. It is already there in Hyderabad. What are the take-home messages for the residents? Please aware of the updated guidelines. Do appropriate procedures for the disease accepted. Always look for neck notes, because that is important. Whether it is a pathology like sarcoid or tuberculosis or the neck notes, you may not be doing it. Send it to the doctor, send it to surgeon. You get a lot of tissues. Or the vascular biopsy or some other test like when you want to send it for PCR, send it in provide all the information, the ABCDF, etc., age, smoking history, sex, and also the history of the radiologist to the pathologist. Radiologist finding to the pathologist is important. As I told you, 30% of cases makes different diagnosis. And most important, discuss with the pathologist. The findings doesn't fit into the diagnosis. This is important. See, I don't know how many times the multidisciplinary partners are added. But in every case, you have to be able to discuss with the pathologist. Particularly, you have a lot of dilemma about the diagnosis of granuloma, whether it is sarcoid or tuberculosis or any other sensitivity after surgery. Always discuss with the pathologist. Don't take whatever medication. And if you observe all these, then issue may not be an issue. See, in medicine, it takes all the money you can do to keep safe. This is regarding the advances. In medicine, it takes all the money you can do to keep the safe. If you want to get somewhere else, you must have price as fast as possible. This is from William Boyle. See, he lived up to 1979. Had he lived today, he would have said that you must run 100 times fast. That is how rapidly it is. In our time, we used to read a textbook of pathology by William Boyle. See, this is really a pleasure to read, like the persons who play radio. See, most of the students, they not only got interest in pathology, but also in interest in medicine. Then they read this book. See, it has attached to say an introduction to medicine. This is a pathology book, but he said it is an introduction to medicine. And nobody ever questioned that. Because really, he has introduced medicine from that book. I don't know. I think everybody who is interested in pathology must read that book. took the rights for the presentation of this work, but I heard it doesn't have the flavor of the original. Thank you for that. Due to paucity of time, there will not be any question.
Thank you so very much, sir. I think the tips you've given can only come with experience and so much of expertise. Thank you very much. I request our respected chairperson, as a token of our appreciation to our speaker, Dr. G. Ravindra. So please. Very much, sir. I now request our head of department, Dr. Bhagyalakshmi ma'am, to honor our chairperson, Dr. Radha Madhav, for chairing this first session of ours. Thank you, ma'am. Thank you, sir. Our next speaker is also a very eminent pulmonologist, Dr. Sunil Kumar, sir, who will appraise us on the applications of EBUS, endobronchial ultrasound. I call upon Dr. Anand, Associate Professor, Department of Pathology, to introduce the speaker to all of us. Dr. Anand, please.
Good morning. We, from the Department of Pathology and Another Institute of Medical Sciences, we are privileged to introduce Dr. R. Sunil Garu, an eminent interventional pulmonologist who has done his MBBS in 1984 to 1991 from Andhra Medical College and completed his post-graduation from the same. And afterwards, he worked in Kamini at Elvinagar and also later in Nizam Institute of Medical Sciences as a consultant pulmonologist from 1996 to 97. Later on, he joined in government service in 1997 at Guntur Medical College and worked as an associate assistant and associate professor in prestigious Andhra Medical College, also from 1999 to 2017. He was promoted as professor in pulmonology department in 2017 and has done tremendous service in GMC Srikakulam as HOD of Department of Pulmonary Medicine. He also served as Superintendent Government General Hospital, Srikakulam. And he is also very active in academic research and conducted a live workshop on livers and thoracoscopy in 2015 with Dr. Munawar from United Kingdom and also actively conducted many CMEs. He is also a member of Indian Bronchology Association. He is now the HOD of Department of Pulmonary Medicine of Andhra Medical College and Superintendent Government Chest Hospital, which is in persistent pursuit for academic research as well as patient service. So we are honored to have your lecture here. Thank you, sir.
Thank you so much, Dr. Anand. I now request Dr. B. Bhagyaprasad, HOD, Department of Pulmonary Medicine, NRI Institute of Medical Sciences, to please chair this session, sir. Sir, please. Sir, the stage is all yours.
also thank the architect for the excellent arrangement and to transmission family of the program. I don't know how many people are watching, and it's very much honor for me to stand before you in the same stage sharing my guru, Dr. Ravindra Garu, and giving me this opportunity. In fact, this is the second time I'm sharing the platform of pathology. Last time I spoke in the Anand College. So with that, I'm going to the Department of Pulmonary Medicine. My department is the biggest department in Andhra, hosting 14 postgraduates per annum, making 42 per postgraduate at any point of time, along with 17 faculty members, and taking care of 24/7 on the exclusive pulmonary specialty hospital, having 288 beds, out of which 2 are exclusive pulmonary specialty, pulmonary patients. So this is a nutshell my department, and this is not America, and this is because of the great predecessor Dr. Ravindra Garu, who has done an excellent job while he is an 8 years of superman. In fact, I am enjoying the fruits and the office work. Thank you, sir. So, what is that we are doing in our department? So, various tools in the diagnosis of the lung pathology. So, secondly, I have lung oscillation starting from that is my thesis topic is the dissertation of post-graduation. Tutor biopsies, the bronchoscopy, rigid bronchoscopy, sulfoscopy, in both adults and pediatric patients. Of course, megasthenic scope is being done by our CTDS colleagues. We are now doing about department bronchoscopy analysis of DBNA, and the emerging trend is to endobronchial ultrasound. So that is how we are using every tool in order to serve our patients, and also not have to explore the lung from inside outside. Unlike the previous years, we are having excellent tools of investigation as well as treatment modality, where you can reach every mutant corner of the lung. So coming to this topic of previous video, also one can make aspiration to endobronchial ultrasound. So what is the endobronchial ultrasound in the outlines? Then what are the dimensions of the presenting India investigation, and what are the EVA certificates of the how to identify each node, what are the indications and how is the outcomes of the DBNA. So EVA is nothing but bronchoscopy technique that uses ultrasound to visualize the structures within the airway walls, lungs and mediastinum. So it is a very minimally invasive, safe procedure that can be performed on the OP basis with local anesthesia or water sedation. But nowadays we are using something like the general anesthesia, and we are comfortable to go and do the job only with laryngeal mask airway or the LNA, because it gives us easy access to the entire bronchial system. So EVAS is done with the help of two probes, right? One is a radius probe EVAS, second one is a convex probe, convex EVAS modifier. So this is the sector probe in the ultrasound machine what we are seeing in the radiology department. The second phase is the bronchoscopy. So EVAS is an excellent tool where it combines both these two, and even the investigation point of mediastinal pathology. You can see that there is a ultrasound probe at the tip associated with a needle coming out of the investigation. And what are the importance of the EVAS? Why we should do EVAS? So the accurate staging of the LSSPS, and it details the treatment strategies and to go to mediastinal medicine. So in a nutshell, what we have seen is we can reach everywhere of the pulmonary system lungs, except this mediastinal lymphnopathy, because it is very discrete and very specific. See, it is spreading along the tracheobronchial tree. So we have to be very conscious and very oriented in order to reach every one of the set of lymph nodes. So EVAS is a great combination of optics and ultrasound.
because whenever you are creating a property, fiber optic ground puts from in the fiber optic cable. You should not any needles blades to come in this, but this is a combination after that.
అది లేదు కదా మిక్సింగ్ అలాగే స్లైడ్
This is in the shed, available facility, leaf flow stations. One is in North Pyramid node, and the second is IoT node, Imperial Gas node, and
డబుల్ బిల్ పెట్టాను డబుల్ బిల్
so each one will come to it. So all these are accessible by intergovernmental association. These are accessible by intergovernmental association.
లేదంటే ఒక పని చేయాలి సార్ ఒక్కసారి స్పీకర్ వీడియో ఆపేయండి లేదు స్పీకర్ వీడియో ఆపండి చాలు ఏముంది సార్ స్పీకర్ వీడియో ఆపండి చాలు స్పీకర్ వీడియో ఆఫ్ చేసేయండి
because it's an airway intervention where every method, every movement, every fraction extension of scope is problem identification. So more than bronchoscopy, when you are dealing with the E-bus, you should have an overall three-dimensional structures which is exterior to the bronchus.
ఇది ఆఫ్ చేసేయండి
So that is very important. So likewise when you are going to the left main bronchus and right main bronchus, we have to be very aware of the what are the structures, and you should have always a three-dimensional imagination and assessment. At the same time, you have to make
ఈ
sure
ఆపేయండి
that you are
ఏం అవసరం
when you are going to outer to bronchus. So coming to this one, if you are able to see, there is a highest mediastinal node to superior mediastinal node. This is superior mediastinal node, and this is a 2R and 2S, and this 4R and 4S and this is 6 concentration. 5 and 6 are IoT, where we are unable to approach. The inferior nodes are subclavian and paraexotic, and condylar the other nodes are hilar and inferior, and the other nodes have been considered. So whenever you do E-bus, you have to be entire brachial bronchial free tube. So you have to be identify all the extra bronchial lymph which are visible in that particular case. The entire brachial bronchial tree ultrasound should be done. That is what we call as endobronchial ultrasound surveillance. And we have to coordinate with the CT scan, PET scan images, and with the E-bus surveillance. So before doing any biopsy procedures through the E-bus, we have to map out all the lymph node what is visible there in that case. So E-bus convex ultrasound code is accurately registered usually. So you are able to maneuver yourself right from the left anterior and to right anterior and to lateral to the anterior spaces. So you cannot see the posterior of course the trachea upward with the esophagus. So if at all you want to do a posterior abdominal lymph node, then you have to use the endoscopic ultrasound where gas background release. So this is first group of supraclavicular lymph node. You see very after passing to the vocal sigmoid area, there is a lower cervical supraclavicular and a stellar node are there. So it will be very beginning of the bronchus trachea, it will be visible. So you have to do all the visualization and then you have to access the structure. So most important is the 2R and 2S. After paratracheal lymph node, right side is 2R, left side is 2S. And there is a certain landmark which you have to follow. And 2R node extend to the left lateral border of the trachea and upper border of the mandible and lower border intersection of caudal artery denominator of the trachea with the trachea. So you have to be very careful before you consider any ruptures or nodes in this area. This is a low
scan for the another scan of the needle also. So you can see the vascular simultaneously, and you have to scan meticulously around the bronchi and the trachea. You have to do the injection. So this is the third vascular which we are not doing now. And this is very important is forearm right lower paratracheal. So right lower paratracheal is entire outward. And the intersection is upper border is intersection parallel border and not between the trachea, and the lower border is very, very important because lower border is area means forearm node section to the left lateral border is trachea. So left lower paratracheal 4L is also very important. 4L nodes is lower paratracheal nodes that are rotated to the left of the left tracheal border. So this is the left of the left tracheal border. You can horizontal line drawn tangentially to the upper part of the diaphragm and to tangent to the upper part of the left pulmonary artery. This is how much vascular area is used in order to do any biopsy procedures. It will be very cautious, and it will assess once or twice before doing any function. And aortic and thoracic we are not access to for liver. Which is very evident to the CT scan as well as PET scan. These subcurrent lymph nodes are most accessible to the even the bronchoscopy with conventional levers also. Conventional TBNA. Can use a levers, but better you can do levers also. This is right procedure in permanent ligament nodes. And this is very important because until EVAS program is in order to evaluate patients, lymph patients, and adjusted staging. So very, very important to do the job. So 10 patient diagram is the left kyla, this is left kyla. Include notes immediately adjacent to the main bronchus and kyla bronchus, including the proximal portion of the terminal veins and pulmonary artery. So this is very, very important. And whenever you do EVAS, there is a simple roadmap is there by which you have to do the EVAS. So if the patient is having a right lower lobe or right side malformation, you have to stage the patient's disease. So you will go to the lateral line first, that is left side, and then you will note out any anti-staging error, that I will talk to you about. So this is a right side superior interlobar 11 SR, RS and right inferior interlobar. There are two different stages in 11 RS and 11 RS. And this is the landmark by which you have to guide yourself in this trachea and bronchus. So EVAS is having a 6 landmarks. Even though we are enumerating all the areas in front of the patient, there are certain landmarks that are like 4 are on the right side, and the areas on the right side, and 10 are. Between these two 4 are and 10 are, so the areas between there which you have to locate before you doing the surveillance. Likewise, 4 is left side, and the subcurrent and the right side, and 10 these are the things you have to do. So as I told you very much, whenever you see a landmark on the right side, first you go to left main bronchus, rule out any canyon or 4L, contralateral lymph node, and then you rule out the NCC, and then you come to HILA, the 4R and 7, which is HILA lymph node, making the angle state, and if they are not there, then you come to Pixie and 10R. So this is how you have to stage N1 and 2 and 3 for a tumor on the right side. So coming to the basics of the ultrasound picture, so it's a ultrasound you have to be very careful about the probe and frequency, attenuation, heterogeneity, color, medium, image verification, feedback, optimization, and modification. Because we are working today a very narrow airway, and
we are putting lot of instruments there and lot of technologies also happen to be interfacing between the bronchial valve and tracheal valve as well as the exterior to the bronchial valve, the vessel, the lymph node. So you have to be very careful in understanding the technology of the instrument. So ultrasound is the pros and frequency you have to understand. It's a piezoelectric crystal, not harmful otherwise. The frequency of linear levels is 7.5 and linear high frequency convex levels is the one which is having a real time advantage during the TV. So my dear students, as I told you before, there is a convex levels as well as the radial levels. So convex levels will give you the real time guidance, whereas the radial levels will give the even approximate area where you have to do the biopsy procedure in the intrabronchial area. So either lymph is a minimally invasive and conventional sampling of the high diagnostic. It's a safe procedure that can be performed in OP cases or anesthesia, but be careful because of your insertion the patient and overload all powerful complications. So what will be the number of areas lymph nodes we are encountering and what are we are knowing about? The 4 stations, 2 are 12, 4 are 4S, and 10 are NR, and the 11 are and these are the things which we have to explore in order to come to a conclusion whether the patient is having N1 and 2 at this stage. I think I am clear on the point to my student. Lymph highest stations first is N2, NCM, and also in the order we have the so types of nodes to the reversal. Again, if you see a linear reverse, there are the types of chromosomes not in the pulmonary parenchyma, nodules with hyperactive nodes are linear of type 2, and type 3 is heterogeneous nodules are there. And type 1 nodules are mostly benign, whereas type 2, 3 are mostly malignant. And this is the image orientation of the reverse in the coronal lymph node. This is because the high vascular structures are there, both sets are around below. And this is a user scope should always visualize the adjacent vascular structures before doing any biopsy. And this is called what the image orientation of the lever. This is the respiratory node and 4R, 4M. This is the and the contrary below. So you have to be careful. This is the lymph node and this is the 2 big vascular structures. So Doppler is one of the arm which extended to the complex flow, and we can see the vasculature of the nodes and underlying structure. And based on the vascularity also you can assess the pathology and the type of vasculature whether hilar, peripheral, mixed. And it is also used whether weight you have to puncture the lymph node. Whether the highly vascular area is more prone for bleeding, so you will do less vascular area in the lymph node. Lymph node is possible. So there are so many artifacts which are here. There is an active interface between the bronchial and the PDA surface of the ultrasound as well as exterior to the bronchus. So there are so many kinds of artifacts which you have to evaluate. And the size of the shape and margins of the lymph nodes also gives the rough heterogeneity, annulus and pattern of aspects. These are all the things which you have to observe and report it in your report. So elastography is the one which is technique by which you detect the hardness of the tissue. With the reverse convex probe only you will touch the what you call bronchus as well as the adjacent node, by which the compressibility and the hardness you can see with the hard blue area we will take over also, and intermediate is the constitute more or less the benign. So wherever it is hard and there is necrosis inside, most probably it could be a malignant etiology. So what are the indications of reverse and deviation? Diagnosis staging on NSALC, TNM components of the TNM of staging can be staged during reverse,
note, 2, 4, 10 and L, which will determine the outcome of the patient. And sampling of pulmonary balance of nodules through radial results, and sampling of medial pneumothorax, and also sampling of endobronchial polybronchial and lubricant can be done. What are the contraindications? Contraindications of more profound refractory hypoxemia and severe bleeding tendencies, and a regular lack of patient cooperation, unstable angina, and controlled hypertension also. So these are the various steps by which you have to measure the nevus needed through the broncho nevus, and then there are a lot of steps locking the entire catheter, and then to take out the stereo and then locking the needle, and the various methods by which you do the locking procedure and point the procedure and all. This is how it goes on. And now there is structure details also. You can see pinpointing and take the biopsy sample from this and use motion. Very, very useful. So this is a level mm. Usually you do biopsies of more than 10 mm. Less than 10 mm is very difficult to access and difficult to do biopsy. So this is 11 mm, 4 or no because this is right side of the bronchus and use this. Dagger to be there. So you have to be very careful doing the 4 or and by this dissections there could be a superior vena cava, there could be a what you call a dagger to also. So functioning is very, very detrimental sometimes, but not very severe. But anyway, you have to be very careful doing this. So level is right side levus TBNA also. You can see a lot of work. Sketches also, and you can do it. You can access the structure, structure as well as a different pattern of the lymph before doing this thing. And this is a mini core biopsy because we are using a 19 to 25 gauge French needle along with the levus TBNA. So you can have an entire core biopsy needle, which is very useful for further dosing by your pathologist. And this is a small animation about the levus TBNA. Because this is the flexibility of the tip of the bronchoscope either, and you can see that entire needle is within, you can do a direct manipulation process. So this is a and this is the type of process we are using radially for software along with the guide wire as well. So rapid onset evaluation cytochrome of plasma procedure that allows assessment of adequate and access to within few minutes, very, very useful for the bronchoscopy. Because for each lymph node we are doing around 3 to 4 passes or more slowly, so 5 to 6 hours at times. So onset evaluation and reporting whether it is lymph node or whether it is having a malignancy or behind is very, very important. And onset evaluation is very useful to bronchoscope more than pathology. We know when to stop the procedure. So, this is a different kind of foreign body removes we are doing in our hospital, and this is very important. Whatever we are doing for the pediatric also. The having right foreign body to foreign body, then we have treatment with the help of government doctor. Let me tell you the video on the paper of the and after releasing the foreign body, we will be able to take out with the Albion basket. These are the routine procedures which we are doing on the issue. And the rigid bronchoscopy also. Last one we done scoring of the entire document bronchoscopy, central bronchial bronchoscopy. So concluding. My presentation will never be complete without mentioning the millions of thanks to the Guru of Guru, Dr. Sunam Satyasri Garu. He is the author of the
it is lucky and I'm happy to I'm happy and which is submitted, two of the co-authors are from this beautiful hospital. So in this context I want to play a small video about the book release which is happening in my hospital. And this is Dr. Balakrishna, he is the faculty of this medical college and he has narrated entirely how best we could be able to bring the book in 7 long years along with Dr. Usha Gandhi. Both are disciples of Dr. V. Ravindra Garu. Because of the excellent academic help they could be able to bring that. Along with many other Dr. Satyasri. He is a teacher of teachers, Satyasri Garu. And he wrote, at this age, he wrote an excellent book on textbook of tuberculosis. Thank you very much for your patience meeting. Thank you, Chairperson, and the faculty of Pulmonary and Pathology Department giving me my time.
So many thanks to Dr. Sunil Kumar.
Screen I now request Dr. Pratisha Rao sir to honor our chairperson, Dr. B. Bhagavath sir, for chairing the session. Sir, please. Sir, please.
వీడియో పెద్ద అవ్వట్లేదు ఎందుకంటే పెద్ద అవుతుంది కంప్లీట్ చేస్తాను పెద్ద అవ్వట్లేదు
Moving on from the clinician's point of view to the radiologist's point of view, our next speaker is Dr. T. Pradeep, who will enlighten us regarding the radiologist's point of view in his talk, Imaging in Non-Neoplastic Pulmonary Diseases. I call upon Dr. Bharati, Assistant Professor at our Institute of Medical Sciences, to introduce Dr. T. Pradeep to all of us.
Now I take the privilege of introducing Dr. Pradeep Dava, radiologist. He completed his graduation from Narayana Medical College in 2018 and he's been working since 4 years in NRM. And his areas of interest are body imaging and fetal imaging. He owns and runs the diagnostic center, Sun Imaging and Diagnostics, with his better half, Dr. Kirtika, who is also a radiologist. You welcome, sir.
I now invite our medical superintendent, Dr. Krishnamurthy sir, to please chair the session. Thank you, sir.
మీరు తీసుకొని మార్చుకోండి మీటింగ్ కండక్ట్ చేసి ఆటోలో పెట్టేశారు
rather than updates in pulmonary pathology, I would like to go to the basics. So today I will try to teach basics of HRCT lung because HRCT lung has become very common after COVID. Many of us have undergone HRCT lung after COVID. We have, many of us have suffered from COVID and we have undergone COVID. I myself has undergone CT twice. So today my aim is to teach you the basics, how to recognize what pathology you are seeing. All of you have undergone means we have come across the words like ground glass opacities, retinal opacities. Now Ravindra Babu sir has talked about honeycombing, retinal opacities, consolidations, everything. So today we see what it is. So the first basic unit is secondary pulmonary lobule. We all know that it is a basic structural unit and functional unit. It is about 1 to 2 centimeters in size and contains 5 to 15 which contains a central bronchiole or respiratory bronchiole which terminates into alveoli and a pulmonary artery, and the peripheral lymphatic system with pulmonary vein. So for following anything, first we need to know what is there. So if you follow basic protocol, means what it is there. A dominant pattern, whether it is regular pattern or nodular pattern, a high attenuation pattern or low attenuation pattern, and where it is distributed, whether it is in central or peripheral, whether it is in upper lobe or lower lobe, we will come to our diagnosis very easily. So the reticular pattern. The reticular pattern is nothing but lines, many lines, irregular lines. So these can be smooth on nodular or irregular. Smooth lines will be seen in lymphatic spread of carcinoma, interstitial pulmonary edema, alveolar proteinosis, whereas nodular or irregular thickening will be seen in lymphatic spread of carcinoma, lymphoma, sarcoidosis and silicosis. These are the few examples of reticular opacities. Reticular opacities are nothing but these lines, these irregular lines, interlocular circle thickening or these lines which are seen in both the images. These are reticular opacities. The second one, reticular opacities with ground glass opacity. Next coming to next entity is nodular pattern. After reticular pattern is nothing but lines. The nodular pattern is few nodules will be there. These nodules will be very small, can be very small in size, can be 2 millimeter also. In the nodules also there can be secondary lobular nodules, lymphatic nodules, or random nodules. In centrilobular nodules, the nodules will be in the center of the secondary pulmonary lobule which we have seen in the first slide. This will be a bit 1 to 2 mm from the pleural surface. This will not be pleural based. In perilymphatic nodules, the nodules will be along the features, along the bronchovascular bundles, along the interlobular septa, and along the pleura. In random nodules, there will be no specific pattern. They will be randomly distributed in the lung parenchyma. So, when we come across nodules, we should follow this pattern whether the nodules are centrilobular or peripheral. If there are centrilobular nodules, these will be the diagnosis. These can be hypersensitive pneumonitis, infection, bronchoalveolar carcinoma, and respiratory bronchitis. If they are randomly distributed, it can be seen in TB, fungal infections, and NATs. If they are subpleural or septal or peribronchial, perilymphatic distribution. So this is an example of perilymphatic distribution. We are seeing the nodules, multiple small nodules along the features, along the bronchovascular bundles. Then centrilobular nodules. These are located within the secondary pulmonary lobule. Very faint centrilobular nodules. Next entity is pre-invert opacities. Nothing but accumulation of pus, water, or anything in the alveoli along with the subline bronchiole. This can be seen in mycobacterium,
bacterial fungal infections, ABA disease like cystic bronchial, cystic fibrosis, bronchiectasis, ABPA, and aspiration also. So here we are able to see a small tree-like. This is seen endobronchial spread of tuberculosis. So, unlike random nodules and perilymphatic nodules, centrilobular nodules and perilymphatic nodules, these are random nodules. They don't follow any pattern. They are scattered randomly throughout the lung. This can be seen in miliary tuberculosis, fungal infections, silicosis, sarcoidosis, and LCH. So next, after reticular hepatitis, nodular hepatitis, coming to high attenuation pattern like ground glass opacities and consolidation. Ground glass opacity is nothing but opacification of the lung, but we can see the supplying bronchi and vessels through that. So only increase in opacity without loss of vascular markings. Whereas in consolidation, there will be loss of vascular markings. The lung is opacified and there will be loss of markings unlike ground glass opacity. There will be many causes. Forget about the causes for now. If we are able to identify how ground glass opacity looks and how consolidation looks, I think it will be good as far as this class is concerned. Then coming to mosaic attenuation. In mosaic attenuation, there will be increased density and decreased density, and ground glass opacity presents as mosaic attenuation. You can consider infiltration process, normal lung appearing relatively dense adjacent to the lung with air trapping or hyperprofusion. So this is mosaic attenuation. You can see both increased these ground glass opacities and the normal lung together side by side. Then this is basically in our olden days we saw marble houses. So it looks like that. This is basically which is ground glass opacities with superimposed septal technique, which can be seen in alveolar proteinosis, sarcoidosis, NSIP, organizing pneumonia, infections, neoplasms, everything. Previously it was considered only specific for alveolar proteinosis, but now it can be seen in all these conditions. Then the most commonly used term consolidation. Consolidation is nothing but increased density with the alveolar or the bronchi can be filled with pus, fluid, blood or anything. But the difference between ground glass opacity and consolidation is we will not be able to see the vascular marking. We will be able to see only the bronchi, supplying bronchi will be seen. This sign is called A bronchogram sign. The left one is cryptogenic organizing pneumonia and the right one is chronic eosinophilic pneumonia. In both the cases, we are able to see ground glass opacity. The next is low attenuation pattern. Ground glass opacity and consolidations are high attenuation pattern, means the density is increased. The low attenuation pattern is decreased density, means there will be cystic phases or the density is decreased. It can be seen in honeycombing, traction bronchiectasis, lung cysts or emphysematous changes. This is centrilobular emphysema. See here the density is decreased and it is something appearing is lucent. It is more not opaque, it's lucent. Centrilobular emphysema. The next is paraseptal emphysema. It is most commonly seen at the older or adult patients. With the emphysema changes will be near the pleura. Next is panlobular emphysema. It will be scattered throughout the lung. Lower row is more commonly predominant and alpha-1 antitrypsin deficiency is common. Then cystic lung changes. Cystic lung changes can be seen in LCH, RAM, pneumatosis, lymphocytic interstitial pneumonia, and pneumonia. These are the cystic changes. The left one is RAM and LCH. In RAM we can see fine thin volatiles and which are well defined, whereas in LCH there will be bizarre shaped sheets. The cysts will be irregular and cysts will be of irregular sizes. Next is honeycombing. Honeycombing is nothing but the cysts which are arranged one upon another or multiple layers of cysts is called Honeycomb. It is seen in UIP, IPF, rheumatoid arthritis, scleroderma, asclerosis, and stage hypersensitivity pneumonitis. This is honeycomb, typical appearance of an honeycomb, where multiple layers of cysts are stacked together, most commonly seen at lung bases and posterior lobes. After this, means we'll be seeing which pattern it is, whether it is reticular or nodular or increased density or decreased density. Then we'll see on how it is distributed, whether there is upper lobe predominance or lower lobe predominance. If it is upper lobe predominance, then inhalational diseases are common, silicosis, sarcoidosis, or Coledophilus, centrilobular, intestinal LCH, and Crohn's hypersensitivity pneumonitis will be common. In lower lobe, edema dependent, gravitational dependent diseases are common. That is central distribution or peripheral distribution, central like sarcoidosis, bronchitis, and peripheral like COPD, chronic eosinophilic pneumonia, and endogenous meds. So, and how is it associated with pulmonary pleural effusion? If it is associated with pleural effusion, we can consider pulmonary edema, lymphadentis, carcinomatosis, PB, LAM, LAM, asclerosis, or pulmonary embolus. And lymphadenopathy.
letters ఉన్నాయి.
So, just a quick recap of what we have seen. This is reticular pattern, nothing but many lines.
ప్రజెంట్ చేస్తున్నట్టు అవును.
Reticular pattern with lymphadenopathy. This is crazy craving pattern. The increased glomerular capacity, septal thickening. Reticular pattern, increased intraocular septal thickening with glomerular capacity, seen in pulmonary edema. Then the nodular pattern, sarcoidosis with nodules along the features and along the bronchoascular margins with hilar lymphadenopathy. Then the TB, typical triangular capacity and multiple nodules.
మనం చేయలేం.
Then LCH, before the cystic stage in LCH, you will be able to see the nodular stage. The nodules will be randomly distributed throughout the lung. Then the respiratory bronchiolitis with small nodules. Then next entry is high attenuation pattern. Chronic eosinophilic pneumonia. The first is here we are able to see the bronchial capacity because we are able to see the bronchial vascular markings through the opacity. Next is sarcoid. Chronic eosinophilic pneumonia and bronchoalveolar carcinoma. Here all these high attenuation patterns. The first one is bronchial capacity, next one consolidations. The low attenuation pattern, LAM, LCH, LAM, this is well defined and organized, whereas LCH, this is large and ill defined. Then honeycomb, centrilobular aplasia. So, COVID imaging, we can stage it as early stage, progressive stage, or peak stage, and observed stage. Depending on the stage, we will see glomerular capacity, basic aging, and consolidations, pleural thickening, architectural distortions. This is the common thing, most common thing, glomerular capacity. It is the early stage. These are usually multifocal, bilateral, and subpleural. The next entity is crazy craving. Means all these findings can be seen in group COVID depending on the stage of the disease we have. This is glomerular capacity with vascular dilatation, with bronchial dilatation, bronchiectasis, and this is architectural distortion with pleural glands. So we will see, commonly we see CT severity index on the reports. It will be ranging from 1 to 25. Each row is having, if it is involved less than 5%, we take it as 1. If it is 5 to 25%, we take it as 2. 26 to 49% 3, 50 to 75% 4, and if it is each row, if it is involved more than 75%, we will take it as 3. We will sum up all the things and we will aggregate it
So that we give a score out of 25 it is 110 or 25. So this is the early phase of COVID where ground glass, diffuse ground glass opacity are noted in all those. This is late stage of COVID where we can see all the things like ground glass opacity, heavy rain, pleural thickening, fibrotic bands and bronchial dilatation. A small introduction about solitary pulmonary nodule. Solitary pulmonary nodule is usually defined as a focal opacity, visible chest oxygen, which fits the following criteria. It is radially well defined, surrounded at least partially by lens. It is roughly circular shape and it is less than 3 centimeters in diameter. This is how a solitary pulmonary nodule looks in ultrasound and SCT. It is well defined and usually less than 2 centimeters. This is the size criteria how malignancy increases, the chance for malignancy increases. If it is less than 4 mm, there are very less chance for malignancy. If it is 4 to 7 mm, it is 3 to 7%, 7 to 10 mm, 15%, and 10 to, as size increases, the chance for malignancy increases. Then the age appearance, whether it is sharply marginated or spiculated. Sharply marginated is, can be seen in granuloma, hematoma, carcinoma, and mets. Speculations can be seen in adenocarcinoma, carcinoma, and granuloma or focal scanning. These are various classifications. All these type of classifications will be seen in benign. Malignancy with classification is rare. Then the growth comparison with previous images is important. Stability over a period of, if the lesion does not grow over a period of 2 years, then we can consider it as a benign lesion. And the doubling time, if the lesion doubles within 1 month, then we consider it as benign or effective causes. If it doubles between 1 to 18 months, generally it will be malignancy. If it does not double over a period of 2 years, then it is benign. Then the shape of the lesion, we should consider 3-dimensional ratio. If it is greater than 1.7 or if it is greater than 2 centimeters, the ratio is greater than 2, we consider it as malignancy. It is nothing but maximum transverse diameter divided by maximum vertical diameter. Then the margin, cardinal radiator sign, usually indicates high chance of malignancy. Calculated of scalable margins, intermediate probability, smooth margins, benign. There can be pitfalls sometimes. We can consider this as a consolidation with airborne grounds, but the speculations or the pleural tax covers malignancy. So this is how a solitary pulmonary nodule should be evaluated. First as SCT, then it is benign. It is benign. There are classifications of fatty tissue if it is intermediate with this stratification, it is greater than 8 mm, we should go for PET-CT. If it is 4 to 8 mm, there is other criteria. If it is less than 4 mm, follow up after 12 months. If it is less than 4 mm, low risk, no follow-up is required. If it is, and after follow-up, if there is change in size, we should go for surgery. If there is no change in size, no follow-up is required. Yeah, if it is less than 4 mm, no follow-up. 4 to 6 mm, follow-up, CT, 12 months, if unchanged, no follow-up. If the lesion is greater than 6 mm, 6 to 8 mm, initial follow-up at 6 to 12 months, then 18 to 24 months. If the lesion is greater than 8 mm, follow-up CT at 3 and 9 and 24 months with contrast. So in differentiating benign versus malignant solitary pulmonary nodule, we should see the presence of the area, ground glass opacity, A ground to ground, the 3-dimensional ratio, and doubling time. Thank you.
Thank you so much, Dr. Ravi, for such a clear view of the imaging. I request our chairperson to please felicitate our speaker in the momento. I just open up our Medical College. Ma'am, to please honor our chairperson for us, Dr. Krishnamurthy sir. Sir, please. Thank you so very much, sir. I think we will have 10 minutes of tea break, and after which we will start the feast of pathology. And the tea is served right outside. All delegates, speakers are requested to join us. Okay, 5 minutes extra, so we have 15 minutes for tea. We will meet here after 15 minutes. Thank you. All our dear delegates online, all our dear delegates online, please take your tea break and stay tuned in. We will be back in 15 minutes. Thank you.
దీనికి పవర్ రాలేదా? వచ్చింది కదా, వచ్చింది.
లైవ్లో ఏమైనా ప్రోగ్రామ్ పెట్టడానికి ఏమైనా అవుతుంది అందులోనే?
ఏ ప్రోగ్రామ్ పెడతాం
అంటే మా కాలేజ్ ఏమైనా డెమో పెట్టడానికి?
మీటింగ్లో రెండు వాళ్ళ ఫోన్ వెళ్తున్నా. ప్రాణాలు తోడేస్తా. ఛార్జింగ్ పెడదాం. ఇప్పుడు ఎక్కువసేపు కదా దీంట్లో పెట్టుకుంటే మళ్ళీ మధ్యలో కరెక్ట్గా ఆగిపోయింది. ఇప్పటికే లేకపోతే ఎప్పుడు చాలా ఎందుకు లేదు అప్పుడు వస్తున్నాడు కదా మొన్నటి వస్తున్నాడు కదా చెప్పి తెలిసాను అప్పుడు వస్తుంది కానీ చెప్పుకోవడం వాడు కరెక్ట్ టైంకి రాలేదని లేదు మనోడు కాబట్టి వెళ్ళాడు వచ్చేస్తాడని చెప్పి సాగిస్తాడు
అసలు ఏం బాధ
పొద్దున్నండి ఇవన్నీ జిల్లి మెలుగులు తగిలేవంటే మనోడి నుంచి టైఫాయిడ్కి ఇది సెట్ అవ్వాలి మళ్ళీ అది పెట్టాడు అలాగలాగా
ఎలా ఉండాలి అంటే అప్పటికప్పుడు 1 hour కుదరదండి లైఫ్ వచ్చి సెటప్ అయిపోవాలి
ట్రైల్ 2 రోజులు వేసామా మేము ఎక్కడ వేసినా ఏం చేస్తాం తెలుసా ఫస్ట్ డే ట్రైల్ వేస్తామండి సెకండ్ డేకి అలాగా సామాన్లు ఉంచేస్తాం
అవ్వలేదు వద్దండి
కాదు
వదిలేదు
మేము యాక్చువల్గా ఏం చేస్తామంటే ఎక్కడైనా ఇలాంటి ప్రోగ్రామ్ చేస్తే కార్పెట్ ఈవెంట్సే చేస్తాం ఫస్ట్ చేస్తాం కదా ఏ సామాన్లు వంటి మనం మొత్తాన్ని తెచ్చి వదిలేసి ఎక్స్ట్రా సామాన్లు ఏం పడ్డాయో ఉంచేసుకొని నైట్ డే ప్రోగ్రామ్ చేస్తాం ఏదైనా ఊడిపోయినా ఇంకోటి ఉంటాయి కదా డైలో చూసారా మిక్సర్ ఎక్స్ట్రా అన్నీ ఎక్స్ట్రా అంటే దాని తాలూకి ఏం వాడామో అవి ఎక్స్ట్రా ఉంటాయి ఇప్పుడు ఇప్పుడేమో వెళ్ళి నమ్మలేము ఈ ఆడియో అన్నీ తేవడంతో మర్చిపోయాం రేపు వచ్చాం కాబట్టి మన వడిలు తెచ్చాడు
అప్పుడు అట్లీస్ట్ ఎవరన్నా వచ్చేమన్నారు అప్పుడు టైం కలిసి
కదా ఆల్రెడీ పీపీటీ చేయడానికే కదా ఇవన్నీ ఆల్రెడీ మనం వచ్చాం కాబట్టి జాబులు సెలెక్ట్ ఇచ్చేసి చేస్తాం
ఫస్ట్ ఒకసారి బాగానే ఉంది అప్పుడు అన్నారు కొనేసుకోమన్నారు పట్టించుకోలేదు లేదన్నారు లేదంటే
And my father did his primary schooling in this very place. And finally, my daughter-in-law also is from Vizag and is a Telugu. So life has come to a circle. So once again, I thank the organizing committee for inviting me to this session. Can there be one light in one corner? Oh, that's better. Thanks. Okay. So let me start with a few familiar facts. Now, as you know, non-communicable diseases are diseases which are chronic and slow in progression. And these include cardiovascular diseases, cancer, chronic respiratory diseases, and diabetes mellitus. And collectively, they are responsible for a global mortality to the extent of 65%. A similar scenario exists in India, where chronic respiratory diseases constitute 12%, and most of this is represented by chronic obstructive lung disease, particularly centrilobular emphysema. Nevertheless, we have to remember that toxic substances and various inhalants and pollutants are going to be in contact with an extensively alveolated lung parenchyma, along with infectious diseases both old and new, and immunological disorders, and all of these can lead to a variety of diseases, which to a sooner or lesser extent will involve both the lungs and affect it in a diffuse fashion, and such diffuse lung diseases may be of known or unknown causes. So hence, apart from pulmonary neoplasms, we also do biopsies for the diagnosis of such diffuse lung diseases, of which interstitial lung disease is an important part. And as you must have seen in your morning lectures, that these biopsies may be a transbronchial biopsy, cryobiopsy, or open or thoracoscopic lung biopsies. Another important point to note is that lung, like several other organs, responds to various injurious agents in a very limited pattern, and hence it becomes important for us to follow a conceptual framework whereby we record all the changes taking place in that particular pulmonary disease. Which brings me to the theme of this lecture, that is identification of different patterns of lung injury. Now let us assume that the lung parenchyma looks very much like this colosseum, and as we can see in this diagrammatic representation, it is important to look at all different areas of the lung, which may be the interstitium, the airways, the air spaces, and the vessels. In the interstitium, we have to look at the axial, parenchymal, and subpleural connective tissue. The airways are the bronchi, membranous bronchi, and terminal bronchioles. The air spaces, please remember, includes the respiratory bronchioles, along with the alveolar ducts, the alveolar sacs, and finally the alveoli. And the vessels would be the elastic and the muscular arteries, the arterioles, capillaries, venules, veins, and the lymphatics. So in diffuse lung disorder, we may have to identify the most common or the most predominant pattern, but also look at these ancillary changes that take place in all these areas of the lung. So hence the role of the pathologist is to assess all these changes, and finally we come to the dominant pattern that can be identified at biopsy, open lung biopsy, or even at autopsy. So which are the major patterns of lung injury? There are basically 6 types as devised by Dr. Leslie from Mayo Clinic, and that is acute lung injury, fibrosis, cellular infiltrates, alveolar filling, nodules, and finally we have certain diseases which apparently produce minimal changes in the parenchyma. Now this is an optical illusion where we see that many of the circles are actually intersecting, but if you follow one circle, we can see that each circle is distinct. But the same is not true for these different patterns. You can definitely have overlap of certain patterns in many of the diseases. So let us now go to these different patterns. I have slightly changed the order of the pattern which was devised by Leslie for the convenience of this particular lecture. So this is the first photograph, and what is very noticeable is that the alveolar septa are thin, but they are lined by very thick acellular hypereosinophilic ribbon-like material which is closely adherent to the alveolar septa. There is no space between the septa and these deposits. Now this is a very common finding which we saw actually in COVID and several other viral disorders. So these are nothing but hyaline membranes which characterize the first pattern, that is acute lung injury, which is called clinically as acute respiratory distress syndrome, and pathologically it is denoted as diffuse alveolar damage. So hence, when you identify the predominant pattern, we also have to look at the type of fluid exudation in the alveolar spaces, the type of inflammatory cells either in the space or the interstitial connective tissue, pneumocyte alterations, necrosis, and airway or vascular involvement, if any. So always remember that this always has to be at the back of your mind whenever you have assessed and identified the predominant pattern. So in the previous photograph, we saw the hyaline membranes with relatively clear alveolar spaces. But in contrast to that, when you see this picture, along with these hyaline membranes involving all the alveolar septa, we can also see the alveolar spaces are filled with edema fluid. In this, the hyaline membranes are associated with marked widening of the alveolar septa. This widening of the alveolar septa is a result of not only an interstitial edema, but along with that, there is also mononuclear cell infiltration. So this hyaline membrane is associated with interstitial inflammation as well. So this becomes hyaline membranes admixed in a situation of interstitial pneumonitis. So once again, there are hyaline membranes with edema fluid, and if you look closely at the hyaline membranes, it shows the presence of these pale basophilic refractile structures, which was nothing but pulmonary oxalate crystals which have got deposited. This was a case of pulmonary oxalosis in a setting of invasive aspergillosis. So this pulmonary oxalate crystals was responsible for a toxic injury, and as a reaction, there was hyaline membrane formation. Now, this is a very typical undergraduate photograph which shows consolidation of the lung parenchyma. So the entire lung is affected, and you see small and large multifocal red-brown areas of consolidation. And in contrast to that, here you have the left lower lobe, which is entirely consolidated. So these were images of bronchopneumonia and lobar pneumonia, both of which are examples of alveolar filling lesions. And here the alveoli are filled with neutrophils. So once again, with this particular pattern, we have to note what is filling the alveolar space. Are they cells, fluid, tissue, or organized material? And is it accompanied by pneumocyte alterations, presence of necrosis, and is there airway or vascular involvement? So here we see again an undergraduate side of pulmonary edema, where all the alveolar spaces are filled with this pale eosinophilic acellular material. Now here there is a change in the appearance of that pale eosinophilic material. It looks extremely bubbly, or it looks foamy. Along with that, there is thickening of the septa with a mild lymphoplasmacytic infiltrate. And when we did a special stain of GMS, we could demonstrate the Pneumocystis organisms. So this was Pneumocystis pneumonia. So please remember that we have to have a judicious use of special stains whenever we are assessing the pattern in lung biopsies. From pale pink, here it looks definitely deeply eosinophilic, it looks granular. So this is nothing but a fibrinous exudate which is present within the alveolar spaces, and this was a case of a lupus pneumonitis occurring in a young 27-year-old patient. And sometimes, as we saw previously, the tree in bud appearance because of endobronchial tuberculosis. In this, all the alveolar spaces are filled with neutrophils, but in between we also see giant cells. So this was an example of a poorly reactive tuberculosis taking place in an immunocompromised patient. Now these are cells, these are not neutrophils, these are not lymphocytes, but these are alveolar macrophages. They have got abundant cytoplasm and they have a peculiar foamy appearance of the cytoplasm. Similarly, here you have another case which shows you similar appearance of foamy macrophages, but when we did immunohistochemistry, we saw that the first case was positive for respiratory syncytial virus, and the second case was positive for the mycobacterial antigen. So the first case was respiratory syncytial pneumonia in a child, and the second was pulmonary tuberculosis with foamy macrophages in a maternal mortality. So along with special stains, we can also make use of immunohistochemistry wherever available and wherever necessary. Now here is another alveolar macrophage, and it has got presence of very coarse brown pigment. Another case showing again those macrophages, and here the cytoplasm is eosinophilic with a faint brown discoloration. So here we have, here we have the same hemosiderin pigment which has got a different appearance. In one case it was coarse, as we get with brown induration of the lung, and whenever we have a fine deposition, it indicates a reaction to smoking. So the last case was a case of respiratory bronchiolitis, which also has macrophages with hemosiderin occurring in smokers. Now these are examples of non-cellular tissue within the lung. This is corpora amylicia, which is seen as an age-related phenomenon. And this is vegetable matter, which again gives you the tree in bud appearance because it leads to aspiration pneumonitis. From acellular, we go to tissues which are present within the alveolar space. So here we have something looking like granulation tissue, which is nothing but organizing pneumonia, which gives rise to ground glass opacities. And sometimes you can even have tumor which simulates or which fills up the alveolar spaces. And this was a metastatic squamous cell carcinoma filling up the alveolar spaces. We then go to the next pattern, and there are two images here. The first image shows a diffuse involvement of the interstitium by inflammatory cells, and the second image shows focal areas which are infiltrated by these mononuclear cells. Some of the alveolar septa are thin. So this is an example of a cellular infiltrate pattern, and here too you have to look at the type of cells, whether it is a granulomatous or non-granulomatous pattern, pneumocide alterations, airway or vascular involvement, and the presence or absence of pleural inflammation. So this again shows you a cellular infiltrative pattern with lots of inflammatory cells in the septum. And when we look closely, we can see a very thin hyaline membranes, and we can also see that the pneumocytes have become cuboidal and they have formed syncytial giant cells. This was an autopsy finding in a fatal case of COVID-19 infection. Once again, you have cells within the interstitium. These are mononuclear, but these are not lymphocytes or plasma cells. All of these are macrophages which have had a good lunch or dinner, because all their cytoplasm is filled with this pale yellow crystalline material, which can be very well seen with partial poralization. So this was a case of talcosis in a woman who was very fond of using talcum powder over the face and body after a regular bath. Now here again you see lot of inflammatory cells within the alveolar space, but look at the interstitium. There is marked widening of the interstitium, and this widening is not because of cells, but it is because of collagen, which is an end result of fibrosis. So this brings me to the fourth pattern, that is the fibrosis pattern. You look whether this pattern is fibrocellular and or collagenic. What is the location? Is it subpleural, parenchymal, airway centered? And look at its configuration. Look at the temporal appearance, whether it is temporally homogeneous or whether it is heterogeneous. That means all the alveolar septa are involved at the same time or not, and is there a differential involvement of the septa? And look at the other associations, which is true for all patterns that you get. Now look at the fibrosis here. All this fibrosis is stuck to the alveolar septa. So this becomes an example of a healed phase of diffuse alveolar damage, which of course you get in cases of resolution of COVID-19 infection. In contrast to that, there is widening of the alveolar septa because of collagen. It has produced mild to moderate widening, and it has affected all the alveolar septa at the same time in this biopsy. So this is said to be a feature of a non-specific interstitial pneumonia, and this helps us to differentiate between the more aggressive variant, which is called as usual interstitial pneumonitis, where there is a heterogeneous appearance. Some of the alveolar septa are normal, whereas rest of them show mononuclear cell infiltrate. The other details we will see in the slide seminar. Sometimes the fibrosis is also accompanied by smooth muscle metaplasia, and then these are also accompanied, any end-stage lung disease is accompanied what was formerly alluded to by Dr. Pradeep as a honeycombing of the lung parenchyma, which is characteristically subpleural. Now what do we see here? We see multiple nodules in the lung parenchyma, and the nodules here are surrounded by a more congested appearance of the surrounding parenchyma. So the first case was actually multiple non-caseating granuloma, which is characteristic of sarcoidosis, and the second pattern, which produces the localized miliary, was endobronchial tuberculosis with obvious caseation surrounded by a granulomatous response, which brings me to the nodular pattern, which may show granulomas, lymphoid tissue, non-granulomatous inflammatory cell aggregates, and sometimes even non-inflammatory cell aggregates, and plus you can also have other ancillary features. Now here you feel that the granulomas are slightly ill-formed. They do not form a regular, there is no regular arrangement of these giant cells, and many of these giant cells show cytoplasmic cholesterol clefts. So these are ill-formed granulomatous response seen in one of the commonest interstitial lung disease in India, and that is hypersensitivity pneumonitis. Sometimes you can also have lymphoid follicles in the bronchioles producing a nodular pattern, and of course sometimes it can be a lipidic adenocarcinoma producing nodules within the lung, which may be discrete or it can also be confluent. Now here we have a lung parenchyma, a biopsy, which looks as if we are dealing with a normal lung. But look closely at both the bronchioles, and when we did a meson staining, both these bronchioles showed the presence of fibrosis in the walls. So this was an example of constrictive bronchiolitis, and to us this is like a minimal change pattern, which hence represents either a small airway disease as we saw, it can be vascular or it can be cystic diseases, and of course sometimes it is a sampling problem which we dare not tell the clinician. Now here again we have a bronchiole, and this looks as if it has got a multi-layered approach. This is a close-up of the same, and when we did immunohistochemistry for chromogranin, they were brightly positive. So all that was nothing but neuroendocrine cell hyperplasia. So you should have an eye to pick up all the covert as well as the overt abnormalities in a lung biopsy for a good diagnosis. Now look at the lung parenchyma. It looks almost totally normal till you eyeball on to the pulmonary arteries, and we can see that there is obliteration and something like an irregular glomeruloid body formation, all of which are changes of pulmonary hypertension. Now here we see deposits of tumor in the pulmonary arteries and in the lymphatics, which are nothing but pulmonary tumor embolism and lymphangitis carcinomatosis, which can produce a reticular pattern, and both these are responsible for acute to subacute cor pulmonale in a patient, and they can be the first indications of a primary malignant process. Now this is a venule which shows you obliterative disease. This was a pediatric biopsy of a veno-occlusive disease. Another child coming with respiratory distress, and what we see is a lobular septa with multiple cystic spaces resembling dilated lymphatics. So this patient had lymphangiectasis of the primary type. So please remember that in all diffuse lung diseases, you need not have infiltration of the interstitium. So what we call as ILD may not represent some of these circled areas. And for a patient to become symptomatic because of non-neoplastic lung disease, it may also not be important to have involvement of the entire lung parenchyma, as we see in this particular patient who had localized apical fibrosis, which is included under the umbrella of interstitial lung disease. Now, is it important for us to leave the colorful world and come to a world which is full of black and white images? Yes, it is very important, like for X-rays for bone tumors, MRI for brain tumors. We also have to have a good correlation with imaging, which was very well brought out by my namesake in the clinical lecture. Why it is important? Because opacities down to 0.2 centimeter size can be visualized to the extent of 2000 microns by CT, and it also helps us to look at the differential patterns of involvement of that particular lung disease. We should not forget also our pulmonologist to give a good clinical history, especially related to the home environment, occupation, travel history, presence of systemic diseases, which is very important, especially for pulmonary involvement in connective tissue disorders, drug ingestion or inhalation, and of course the immune status, and also telling us whether the symptoms were acute, subacute, or chronic. And let us also not forget our colleagues who are there in the clinical laboratory who will give us useful information related to routine hematological investigations, as well as certain serological information and also certain enzymes like angiotensin converting enzyme, particularly useful for a diagnosis of sarcoidosis. So in the current era, we cannot be like the senile monkeys. We always have to look, document, and communicate, so that finally when the clinician asks us, what is your diagnosis, we should be able to give an optimal diagnosis or at least a good differential diagnosis correlating with the clinical findings as well as the imaging. So finally, we have to know that there are 6 basic morphologic patterns for DLD, and within these 6 patterns, we have to look at the other sub-features, and knowing these 6 patterns provides a roadmap for navigating successfully into a complex world of DLDs. Thank you very much.
Thank you so very much, sir, for that fantastic and very, very lucid presentation. I'm sure all of us enjoyed it very much. I now request our esteemed chairperson to please felicitate our guest speaker, Dr. Pradeep Vaideshwar, with a memento.
So I would like to say, I heard him several times in the IAPM and other conferences, and he maintained the same composure. It is always extensive in information, so deep in the information, and so lucid, so slow in expression, which helps in very clear understanding of the entire subject. So what I don't know, if there is already an existing book on pulmonary pathology related to, with the help of pictures, if it is not there, I request him to please write a book along with pictures, give us an atlas of pulmonary pathology that will be very helpful for the coming generations. Because now you have added so many other diseases, apart from the age-old asbestosis, all other things, infective or other things. Now you have COVID-related changes also. So I suggest you to write a book, an atlas of pulmonary pathology with extensive picture demonstration. Thank you, sir. Thanks for kindly accepting invitation and enlightened our audience and on video and personal. Thanks a lot for Madam Bhagyalakshmi, Madam.
So will you take a question, please? Here, after the... So would you take a question? Sir has a question.
Sir, in your place, which is common fibrotic lung disease? Because the history says hypersensitivity pneumonitis is the commonest, but in South India we don't see that. We see many cases of IPF rather than this.
Okay. No, in Western region it is hypersensitivity pneumonitis.
In Mumbai and
in Mumbai, in Maharashtra, as well as in Gujarat. So in the western coast, we are getting lot of hypersensitivity pneumonitis.
What they say, it is because of extensive use of the air coolers.
Extensive use of?
Air coolers, sir.
Right, yeah. Possible.
Because in South India we don't see that, sir.
No, in fact, there was a write-up which had come from the Chandigarh group, and they had sort of analyzed their biopsies for interstitial lung disease, and they also said it was HP.
But in Chandigarh, they said the sarcoidosis is the commonest one.
No, but
next IPF and next HP.
No, but it has come as HP. There was an article which had come, I think, in 2015, which was published in Indian Journal of Chest Medicine and Allied Sciences.
Rishi was conducted.
Yes, yes.
But I think there should be a separate study in South India.
Correct.
Most of us, we don't see hypersensitivity.
Unfortunately, what happens, we don't seem to be collaborating with each other. So that is one sad part of whatever Indian studies are there. It is either based on some institution or some region, but we don't have studies which collate all the information from the four corners of the country and present, that we'll get actually a better idea.
Okay. Thank you.
Thank you so much.
Thank you so much, sir. I request Dr. Ram Lakshmi ma'am, HOD of Medicine, to please honor our chairperson. I think sir has Dr. Mahadev Shastri sir with a token for having chaired this session. Thank you, ma'am. Thank you, sir. Lung biopsy is a widely accepted procedure for obtaining samples to diagnose a wide array of pathological diseases. We now have a very interesting talk on lung biopsies in non-neoplastic pulmonary diseases by another of our guest speakers, Dr. Sharda Nagoti. It is my proud privilege to introduce Dr. Sharda Nagoti to all of you. Ma'am has done her MBBS from our very own Andhra Medical College, Visakhapatnam, and her MD in Pathology from Osmania Medical College, Hyderabad, and Senior Residency from Medanta MedCity, Gurgaon. She has done an observership in hematopathology and surgical oncopathology from the prestigious Tata Memorial Hospital, Mumbai, and a fellowship in pulmonary pathology from Mayo Clinic, USA. She has special expertise in pulmonary pathology, pediatric pathology, and oncopathology. She has delivered many faculty lectures and panel expert discussions across the country, a few of them being Broncos 2021 in the Yashoda Hospital, Secunderabad, 4th Masterclass in Lung Cancer under the aegis of Cancer Research and Statistics Foundation, and many, many more across the country. She has authored publications in national and international journals and presented papers in various conferences. She is a member of the United States and Canadian Academy of Pathologists and a permanent member of the Indian Medical Association, Navi Mumbai. I must mention here, she has an ongoing academic project which is very interesting, formulating a consensus statement on management of non-IPF progressive fibrosing interstitial lung diseases in India. Presently, she is the founder director of Pulmonary Pathology Teaching Club, which aims to disseminate knowledge in the less explored subspecialty of pulmonary pathology. But besides that, she has also worked in prestigious institutes like the Vijay Wadia Hospital, Mumbai, Medanta MedCity Hospital, Gurgaon, Central Reference Lab, SRL, and medical colleges like Kalinga Institute and Dr. D.Y. Patil Medical College in Navi Mumbai. Ma'am, it is an honor to have you here with us. Please take the stage. To chair this session, I would like to call upon Dr. Sri Ramulu Naidu, sir. So please take the chair. He is a senior pathologist and head of department, Department of Pathology in Konnasima Institute of Medical Sciences, Amalapuram. Ma'am, please.
Can you switch off the lights? Very good morning to all of you, and thank you for the warm introduction. And at the outset, I would like to thank NRI Institute of Medical Sciences for giving me this opportunity, to all the organizers. Yeah. So at the outset, I would like to thank NRI Institute of Medical Sciences for giving me this opportunity. It's indeed an honor and a pleasure to be here. I would like to thank Dr. Bhagyalakshmi Madam, Dr. Sharma, and my special thanks to my mentor in this field, Dr. Pradeep Vaideshwar. So going back to my talk, it is a lung biopsy in non-neoplastic pulmonary pathology. So before I start off with my talk, so why do we need to know the different types of lung biopsies and their microscopic appearance? Why should we know about this? So when we know the microscopic appearance of the lung biopsy, we can identify what type of biopsy it is. So this is a routine, commonly encountered situation in our day-to-day practice. We get incomplete and mislabeled forms. So when you know the microscopic appearance, you can identify what type of biopsy it is, and you can also guess the indication of doing that type of biopsy. So different biopsies have different indications. So when you know the microscopic appearance and the type of biopsy, you can guess the indication for doing that biopsy, and also you can know the distribution pattern of that particular disease. So these are the objectives of my today's talk. I'll be talking about the types of lung biopsies, the indications of these biopsies, the pros and cons of each biopsy, the processing protocols, and the common artifacts that we encounter while dealing with these lung biopsies. So coming to the different types of lung biopsies, we have 3 different types of lung biopsies: the bronchoscopic biopsies, the transthoracic fine needle biopsies, and the surgical lung biopsies. So bronchoscopic biopsies are done by the bronchoscopist or the pulmonologist. There are 3 different types of lung biopsies which we routinely get. These are the endobronchial biopsy, the transbronchial biopsy, and the transbronchial cryobiopsies. So these are the bronchoscopic biopsies that we commonly encountered in our day-to-day practice. Next is the transthoracic fine needle core biopsy, which is done by the radiologist. And then we have the surgical lung biopsy. Surgical lung biopsy is done by the thoracic surgeon, and this surgical lung biopsy again can be an open lung biopsy, or it can be a video assisted thoracic surgery or the VATS biopsy. So these are the different types of lung biopsies which we commonly encounter. So coming to the first, that is the endobronchial biopsy. The endobronchial biopsy is done by the bronchoscopist or the pulmonologist. So what he does is, he introduces the bronchoscope into the bronchus, then visualizes the lesions, and then with the help of the Cubs forceps or the alligator forceps, he removes the tissue from that particular lesion. Then he removes the probe and then puts the tissue in the container containing fixative. So this is the procedure of endobronchial biopsy. So this is how it appears under the microscope. This is round in shape. It measures around 2 to 3 millimeters. And endobronchial biopsy shows bronchial mucosa with mucosal epithelium, lamina propria, muscularis mucosa, submucosa with mucous glands, and fragments of bronchial cartilage. So this is the mucosal epithelium. Under this we have the lamina propria, the muscularis mucosa, and here we can identify that there is a bronchial cartilage. So what we have to note here is that the alveolar parenchyma is not present in the endobronchial biopsy, because in this procedure the bronchoscopist, it doesn't go beyond the bronchial wall. So these are the only structures which we find in an endobronchial biopsy, and alveolar parenchyma is not present in an endobronchial biopsy. So what are the indications of this endobronchial biopsy? Endobronchial biopsy is done when the proximal lesions are targeted, that is the lesions which are present within the bronchus or in the wall of the bronchus. These could be endobronchial tumors like squamous cell carcinoma or small cell carcinoma or carcinoid tumors, which are usually proximally located, and endobronchial infections, which could be either viral or an endobronchial tuberculosis or allergic bronchopulmonary aspergillosis, or it could be any other endobronchial diseases. So endobronchial lesions, which are the proximal lesions, are targeted in this type of biopsy. So going to the next, that is the transbronchial lung biopsy. So this transbronchial lung biopsy is also done by the interventional pulmonologist, but in this procedure, the pulmonologist goes beyond the bronchial wall and he tries to target the lesion which is present in the alveolar parenchyma. So that is the reason why we see alveolar parenchyma in a transbronchial lung biopsy, unlike that in endobronchial biopsy. So again, the microscopic appearance, it is round, it is finely ragged, it measures around 2 to 3 millimeters, and alveolar parenchyma is seen in this biopsy. So this is the alveolar parenchyma. Yeah, this is the alveolar parenchyma, which is seen in this transbronchial lung biopsy. So when he tries to go beyond, when the bronchoscopist tries to target the peripheral lesion, sometimes we can also encounter pieces of pleura and very rarely chest wall structures like muscle fibers and adipose tissue. So what are the advantages of this transbronchial lung biopsy? So every biopsy has its own advantages, has its own disadvantage. So coming to the advantage of transbronchial lung biopsy, the complication rate in this type of biopsy is very less. The complications include pneumothorax, bleeding, and death is very, very minimal. It is less than 0.05%. And this biopsy, this procedure can be performed under local anesthesia. And there are certain conditions in which the transbronchial lung biopsy is definitely diagnostic. And in such conditions, this procedure, this lung biopsy, it alleviates the need to go for a surgical lung biopsy for diagnosis. So these are all the advantages of a transbronchial lung biopsy. So coming to the limitations of this transbronchial lung biopsy, this biopsy has very low diagnostic yield, around 27 to 83%. This is because, as I've already told, the sample size of this transbronchial lung biopsy is very small. The tissue is very small. It is 2 to 3 millimeters. So the diagnostic yield is very less. So compared, the other reasons for this low diagnostic yield is crush artifact is very much common in this type of biopsy because the pulmonologist uses a Cup's forceps or a alligator forceps to procure the biopsy. So the crushing artifact is much more in this type of biopsy. And another reason is procedural induced hemorrhage is very much common in this biopsy. So these are the reasons why the diagnostic yield of this type of biopsy is very less. And this is a blind procedure in most of the centers, so hence chance of missing the lesion is very common. And the other point which I would like to highlight regarding this transbronchial lung biopsy is it is not recommended for the diagnosis of interstitial lung disease. So always refrain from diagnosing interstitial lung disease when you get a transbronchial lung biopsy. Only in situations where the features are very specific, the specific features are present in the biopsy, and you have a radiological and a clinical correlation, you can diagnose. Otherwise, always it is better to refrain from diagnosing interstitial lung disease in a transbronchial lung biopsy. So what are the indications of this biopsy? The lesions or the diseases which can be definitely diagnosed in this transbronchial lung biopsy are malignancies, sarcoidosis, opportunistic infections, and the lesions which are sometimes diagnostic but not always. So only when the specific features of that particular entity are present, you can diagnose that disease in a transbronchial lung biopsy. These are Langerhans cell histiocytosis, pulmonary alveolar proteinosis, lymphangioliomyomatosis, chronic eosinophilic pneumonia, and as I've already mentioned, transbronchial lung biopsy is least diagnostic in interstitial lung diseases. So going to the next, that is the transthoracic fine needle core biopsy. As I've already said, this biopsy is done by the radiologist under the radiologic guidance. So this is how it appears. And this transthoracic fine needle core biopsy is typically needle shaped as we see in this picture. The sample core size is 1 to 2 centimeter in length, and besides the lesion, sometimes even the sample may show alveolar parenchyma, and also sometimes it can show even the pleura. So coming to the indications of transthoracic fine needle biopsy, this biopsy is mainly done when there is a peripheral nodule or a mass.
Online people are asking to use a cursor or the pointer.
Okay. Can I point it here?
Microphone.
Okay.
You can use it on the screen.
On the screen?
Yeah.
Okay.
Center screen. Use it on the center screen. Whenever you have a microphone.
Okay. Okay. This mouse pointer. Okay. Yeah, got it. So transthoracic fine needle core biopsy is usually done whenever there is a peripheral mass lesion or a nodule. So usually the mass lesion or a nodule is a malignancy. It may or may not be malignancy. So the clinician wants to know whether that nodule or a mass is a cancer or not. That is when he goes for a transthoracic fine needle core biopsy. So transthoracic fine needle core biopsy is usually not done for interstitial lung diseases with a confident clinical diagnosis. So whenever the clinician is able to diagnose the ILD on a clinical, based on clinical features or radiology, he will not go for a transthoracic fine needle biopsy because most of these ILDs are not peripherally located as well. So going to the next biopsy, that is the surgical lung biopsy. This surgical lung biopsy is again of two types, as I've already said. It may be an open lung biopsy where the chest is opened by a thoracotomy and the biopsy is procured. And the second is the video assisted thoracic surgery biopsy or the Watts biopsy. So in this biopsy, what the thoracic surgeon does is, he makes a 2 centimeter incision in between the 6th and the 7th intercostal spaces. He puts the thoracoscope and then he procures the biopsy. Watts biopsy is preferred, and in most of the centers, Watts biopsy is performed rather than an open lung biopsy, because here the complication rate is lesser when compared to the open lung biopsy. So this is how the surgical lung biopsy appears. It is typical wedge or triangular shape, as we see in this photograph. This is the typical wedge shaped, or it is triangular shape, and this is it is usually stapled. So this is how the surgical lung biopsy grossly appears. It is, when compared to the other biopsies, you can see that the size of this surgical lung biopsy is the surgical lung biopsy is bigger when compared to the other types of lung biopsies. And this surgical lung biopsy, it samples the peripheral lung parenchyma, including the pleura. So this is the microscopic picture of surgical lung biopsy. This is this is triangular in shape. This periphery, there is a pleura, and the center, this is all the alveolar parenchyma. So this is how a surgical lung biopsy appears microscopically. So coming to the indications of surgical lung biopsy, this surgical lung biopsy is done whenever there is a suspicion of interstitial lung disease. So when the clinician fails to arrive at a confident diagnosis, or fails to classify the subtype of the interstitial lung disease, despite going through detailed history, the physical examination, other invasive, non-invasive lab investigations and radiological investigations, after doing all this workup, if he is not able to diagnose the interstitial lung disease or not able to classify it, only then he will go for a surgical lung biopsy, because it is an invasive procedure. So coming to the advantages of surgical lung biopsy, the diagnostic yield is much higher because the sample size is more, so definitely the diagnostic yield is much higher. So that is the reason why the surgical lung biopsy is considered to be gold standard for the diagnosis of interstitial lung disease. So coming to the limitations of this, the complication rate is much higher for the surgical lung biopsy, and the complications include pneumothorax, bleeding, acute exacerbation of underlying interstitial lung disease, sometimes requiring even mechanical ventilation. The other complications include infection, and death is around 2 to 17%. So surgical lung biopsy carries the higher complication rate when compared to all the other biopsies. So expertise is very much required to do this biopsy, and this expertise might not be available in all setups. So these are the limitations of a surgical lung biopsy. So coming to the next, that is the transbronchial lung cryobiopsy. This is a very novel bronchoscopic technique which is currently practiced in highly specialized centers. So, in this biopsy, the bronchoscopist puts the bronchoscope into the bronchus, then he inserts a cryoprobe through the bronchoscope, and he freezes the tip of the cryoprobe with the help of nitrous oxide, and then the tissue which is present in contact with the cryoprobe, with the tip of the cryoprobe, is then frozen into a big ball of ice, and then the cryoprobe is removed and the tissue is dislodged into a container containing the fixative. So this is how the transbronchial cryobiopsy is done. And this picture shows the microscopic appearance of the transbronchial cryobiopsy. So again, it is round in shape. The size is around 20 millimeters square, and the sample shows the alveolar parenchyma, and it may or may not show the pleura. So this blue arrow points to the bronchiole. This yellow arrow here is the blood vessel. So this is the bronchovascular bundle, and this black arrow, this is all the alveolar parenchyma. So this is how the transbronchial cryobiopsy appears under the microscope. So coming to the indications, as I have already said, it is a novel bronchoscopic technique, and currently this is used as a substitute for the surgical lung biopsy to reduce the complication rate and to classify the subtype of interstitial lung disease, because it has a lesser complication rate when compared to the surgical lung biopsy. So coming to the advantages, the sample is the sample yield is larger when compared to the transbronchial biopsy, and crushing artifacts is less because forceps is not used to procure the biopsy. So the crushing artifact is very much less when compared to the endobronchial and the transbronchial biopsy. And lung parenchyma is seen in its native physiological state because it is frozen and it is removed. It is seen in a native and physiological state, unlike in the other biopsies where the alveolar parenchyma gets deflated. And as I've already said, the diagnostic yield is higher in the lung cryobiopsy. And the safety profile is better, and the hospitalization stay is also shorter when compared to the surgical lung biopsy. And all interstitial lung diseases can be diagnosed with accuracy similar to surgical lung biopsy in case of a cryobiopsy. So these are all the advantages of cryobiopsy. In most of the higher centers, this cryobiopsy is recently being practiced. So coming to the limitations, there is lack of standardization of this technique, and also expertise is very much required to procure the biopsy. And the diagnostic yield is definitely less when compared to the surgical lung biopsy because the tissue that is procured here is smaller when compared to the surgical lung biopsy sample. And there are definitely procedure related complications. So this picture shows all the 4 types of biopsies, the comparison between all the biopsies, the transbronchial lung biopsy, transbronchial cryobiopsy, transbronchial core needle biopsy, and the surgical lung biopsy. The transbronchial lung biopsy, this is the transbronchial lung biopsy, it's smaller in size. The cryobiopsy here, it is comparatively bigger, and transbronchial core needle biopsy where the cores are needle shaped, and this is the surgical lung biopsy where the sample size is much more when compared to the other techniques. This is typically wedge shaped and triangular, and even the pleura also can be visualized along with the alveolar lung parenchyma. So after knowing the types of lung biopsies and their microscopic appearance, the advantages and disadvantages, we should always know how to handle the lung biopsy, because optimal specimen handling is the key for accurate interpretation. So when the specimen is not handled properly, definitely we get a lot of artifacts, and it is very difficult to interpret the biopsy under the microscope. So how should we handle this? So as soon as the sample is procured, it should be fixed, put in the fixative immediately. This prevents air drying artifacts. So whether it is the radiologist or the pulmonologist doing the procedure, they should put the sample immediately in the container containing the fixative. So this prevents the air drying artifacts. Then after putting into the container, the sample has to be agitated. So when we do this, this agitation has to be done to re-expand any crush artifact which is induced by the procedure. Next, it has to be left for fixation for some time. After fixation, the gross features are to be noted, the number of the samples, the size of the sample, and the gross appearance has to be noted down, and then it is sent for further processing. For benign lesions, always ask for serial sectioning. So this will prevent you from missing out important features like a multinucleated giant cell or a granuloma, loosely formed granuloma, which are very much important to identify hypersensitivity pneumonitis. So benign lesions always ask for serial sectioning. And then make at least 4 to 6 unstained slides for special stains for organisms, for connective tissue stains, and immunohistochemistry if required. Coming to the handling of the surgical lung biopsy, the procedure is a bit different to handle a surgical lung biopsy. So in surgical lung biopsy, the specimen is received fresh in deflated state and it is stapled. So first we have to remove the staples, then the sample is put in a container with the fixative, and after putting in the fixative, again the container has to be shaken vigorously. This is again to inflate the crush artifacts, to prevent crush artifacts. Then after that, or either you can agitate the sample, or what you can do is you can gently inflate the sample with a fixative through the pleural surface with a syringe and a small needle. So take the formalin into the syringe and then gently inject it into the sample. Then leave them in a fixative for a minimum of 1 hour to reduce specimen atelectasis. And then the cutting should be given so that it gives the largest block surface to identify the architectural pattern under the low power, which is very much important in identifying what type of interstitial lung disease. Avoid mincing the tissue into small fragments. Do not mince the tissue into the small fragments. Always cut it in the largest plane so that we get the largest block surface. Then if the malignancy is there in the clinical differential diagnosis, it is always, make it a practice to always ink the pleura. So this is about the handling and processing protocols. Then we go to the next topic, that is artifacts and pitfalls which we commonly encounter while interpreting these lung biopsies. So the first one is atelectasis. Atelectasis is nothing but the collapse of the alveolar spaces. So here you can see this is a bronchiole. This one is a bronchiole, and here there is no alveolar spaces. The entire alveolar parenchyma is collapsed. So this is a atelectasis, and this is commonly encountered in the transbronchial lung biopsy and endobronchial biopsy, because as I have already said, forceps is used in procuring it. So the crush artifact of the atelectasis is very much common in these two types of biopsies, and this atelectasis can mimic diffuse interstitial fibrosis. So this atelectasis can be minimized by the agitation of the sample once it is put in formalin. Or in order to differentiate, you can always use a trichrome stain to highlight this thin alveolar septa. Going to the next artifact, the artifactual intraalveolar hemorrhage, which we very commonly encountered in transbronchial lung biopsies. So this mimics a pathological hemorrhage. This procedure-induced hemorrhage, it mimics a pathological hemorrhage. So how do you differentiate between these two? So procedural hemorrhage always demonstrates fresh blood with intact RBCs. Whereas pathological hemorrhage also shows hemosiderin-laden macrophages and fibrin. So when you see only the fresh blood, there is no hemosiderin-laden macrophages or fibrin. Definitely a procedure-induced hemorrhage. It is not a pathological hemorrhage. But if there is also hemosiderin-laden macrophages along with fibrin, then it is a pathological hemorrhage. And pathological hemorrhage is seen in which syndromes? Diffuse alveolar hemorrhage syndromes. So the next artifact is vascular tunneling. This is how it appears microscopically. So this is nothing but procedural telescoping of normal arteries. That is, one artery gets into the lumen of the other artery, and this mimics intimal thickening. Next is the crush artifact. This is how the crush artifact appears, and in this picture you can see that these are all the lymphocytes, and these lymphocytes, because of the crushing, procedure-induced crushing, this is mimicking a small cell carcinoma. And then we have the bubble artifact. This is how it appears, these bubbles here in the center. This is how the bubble artifact appears. So these are nothing but irregular shaped round to oval spaces due to crushed or the collapsed air spaces, and this bubble artifact, it mimics lipoid pneumonia. So how do you differentiate this bubble artifact from lipoid pneumonia? In case of lipoid pneumonia, these adipocytes, these mimics the adipocytes. So these adipocytes, they are, the fat globules are surrounded by inflammatory cells and foreign body giant cells. Whereas in bubble artifact, there is no inflammation, there is no giant cell reaction. So this completes my talk, and thank you so much for your patient hearing.
Thank you so much for that exceptional talk, ma'am. I request our chairperson to please felicitate our speaker, sir, please, for such a wonderful talk. Thank you, sir. Thank you, ma'am. I request Dr. Sharma, sir, Professor, Department of Pathology, NRI Institute of Medical Sciences, to honor our chairperson, Dr. Naidu, sir. Now let us proceed with the most awaited session for today, exciting for all pathologists here, the case-based slide seminars, where we have a whole array of non-inflammatory, inflammatory, neoplastic, non-neoplastic lesions, both from biopsy as well as autopsy of the lung. The sessions will be conducted by all three guest speakers together, and so I invite all of them. We have already been introduced to two of them, and I call upon Dr. Bharti to introduce our third speaker to us, Dr. Hina Malik Desai.
Having introduced the others, I'm delighted to introduce Dr. Hina Desai ma'am, Associate Professor from Topilal National Medical College and BYL Nair Charitable Hospital, Mumbai. She is a recipient of Geraldine Gieler Scholarship in Pulmonary Pathology and has undergone training in Pulmonary Pathology and Cytology at Mayo Clinic at Arizona. She's also a member of Association for European Cardiovascular Pathology. She's received many prizes, some of which are best prize for the poster title, Cardiac Pathology in Maternal Mortality, an autopsy study at the Association for European Cardiovascular Pathologists conference held at Lucerne, Switzerland, and also a poster presentation at Pulmonary Pathology Conference at PGI Chandigarh. She already has 32 national and international journals in her bag. Very delighted to introduce you, ma'am. We welcome you onto the stage.
Thank you so much. And for this case-based session, I request Dr. Kiran Kumar, Secretary IAPM AP Chapter and Head of Department, Department of Pathology, GVP Medical College, to please take the chair, sir. And I invite, sir, that's it. And I invite all our guest speakers to take the stage and enthrall us. Thank you. Okay. Can I make one small announcement, please? Yeah, sure. Ladies and gentlemen, we still have to have the inaugural ceremony, and we will take as many cases as we can. And yes, okay, ma'am. So 2 cases we will do, and then we will proceed with the inaugural ceremony. So, ma'am, please.
So can I start the case-based slide seminar? Lights off. Switch off the lights. So before I go ahead with the case-based slide seminar. So I'm going to give the final take-home message for my talk, for my cases. So you know that the clinical radiologic and pathologic correlation or the multidisciplinary discussion is the gold standard for the diagnosis of all non-neoplastic lung disease, especially the interstitial lung diseases. So this is nothing but the correlation between the clinician, the radiologist and the pathologist. So this is the gold standard for the diagnosis of all these interstitial lung diseases. So your job as a pathologist is incomplete if you sign out the report with a descriptive or a pattern diagnosis. So your job is always to try to explore the underlying etiology, to correlate with the clinical and radiology features and sign out the report giving the most appropriate diagnosis. And if you're not able to give the most appropriate diagnosis, at least sign out the report giving the list of the most apt differential diagnosis. So this is my final take-home message. So always, as a pathologist, we should not sign out the biopsy as just a descriptive diagnosis or a pattern diagnosis. We should always try to explore the underlying etiology. We should correlate with the clinical and the radiological correlation along with the biopsy findings. And finally, we should sign out the report giving the most appropriate or a list of the differential diagnosis. So this is the take-home message of all my cases. And this is the format in which I'm going to present the case. First, I'm going to give the case details and the images which are already shared with all of you. And so you'll be identifying the pattern. I want this session to be interactive. So please, all the pathologists, all the postgraduate students, please try to identify the pattern and try to give your diagnosis. Then we'll give the biopsy diagnosis, then the clinico-radiologic pathological correlation, how it has to be done. I'll be talking about that. And then finally, I'll be talking about how to sign out the final clinico-pathologic diagnosis and the key points of that particular disease. So this is the format in which I'm going to do my 8 cases in this case-based slide seminar. So hope I'm clear. So can I go ahead? Thank you. So I'm going to start off with the case number 4. So we are doing these cases in the pattern-based approach that Dr. Pradeep Vaideshwar sir has already talked. So according to the patterns, we will be discussing. It's not in the sequence that we have shared the cases. It will be in the according to the patterns. So I'm going to present case number 4 as my first case today. So this is the history that is given to you. The patient is a 51-year-old male with history of hospital admission 3 weeks back for acute respiratory failure. His COVID-19 test was positive, and he has since developed sepsis and has been in the ICU. His imaging showed bilateral ground glass infiltrates compatible with multifocal atypical pneumonia related to infection. And these were the pictures that were shared with you. So based on this first picture, what is the pattern? Can you identify the pattern? What is the pattern here out of the 6 patterns? You can see that this is a pink biopsy, and this biopsy is completely filled with this pink material. So this is a acute lung injury pattern. So this is these are the further images. The pink biopsy, it looks pink on scanner view, and the second picture shows that there is this interstitial as well as alveolar edema. So this pink material over here, this is the alveolar edema, then this is the hemorrhage. Can I use the pointer? It's difficult to use the mouse. So this is the alveolar parenchyma. You can see that these alveoli are filled with this light pink eosinophilic material, which is the intraalveolar edema. And then you also have this hemorrhage and some amount of fibrin. Then this is the next picture. In this picture, you find there is intraalveolar fibrin, this pink eosinophilic material over here. Hope you all can see this. This pink eosinophilic material. Oh my God, I'm not able to see that. Yeah. I'm not able to see that. If I point here, are they able to see here? Yeah, that's fine, yeah. But how will I, okay, I can change the slides with that. Okay. So, this is the next picture, and can you identify this pink, dense pink eosinophilic material over here? This is what? This is the fibrin. So there is intraalveolar fibrin. There is inflammation. This is all the blue inflammatory infiltrate cells. Along with that, there are also reactive pneumocytes in this picture. Next, going to the next, the fibrin is more clear in this. This pink eosinophilic material in the center, this is all the fibrin. Then these blue ones, they are all the inflammatory cells. And along with that, in the middle, you can see that there are also some spindle-shaped cells here in the middle. So there is some fibroblastic proliferation which has started, which is seen in this picture. Next, these are the other images. And what is this structure over here? This branching structure. These blue ones, they are all inflammatory cells. This is the hemorrhage. This is the blood vessel. And what is this branching structure over here? And here it is more clearer. This is nothing but the organizing pneumonia polyp. This is the proliferation of the fibroblasts, the myofibroblastic proliferation, which is seen in the form of this branching structure in a myxoid. And this fibroblastic proliferation happens in a myxoid background. So this is the classical OP polyp, which is seen in the proliferating or organizing phase of diffuse alveolar damage. Next, these are the other pictures, which is showing the classical prototype feature of this particular entity. So what are these? These pink hyaline structures, which are present approximating this alveolar septal wall. Yeah, exactly. These are hyaline membranes. So these hyaline membranes are these these pink eosinophilic structures. These are nothing but the organized fibrin, the cellular debris, and the proteinaceous exudates which get organized, and then they get deposited in the form of these hyaline membranes. So these hyaline membranes are the histologic hallmark of this disease. And in this picture, you see that there is, apart from these inflammatory cells, there is type 2 pneumocyte hyperplasia as well. And this is the closer magnification of that. You see that these are all the pneumocytes. These are all the type 2 pneumocytes which are appearing atypical and bizarre. You can see that there is also some multinucleation. These are the reactive pneumocytes. And this picture, what does this picture show? What is this structure? Apart from hemorrhage here, this structure is a blood vessel. This is the pulmonary artery, and in the pulmonary artery, in the lumen, what do you see? This is the organized thrombus. And these are all the small microthrombi. These are all the small microthrombi which are present in these small alveolar, capillaries. So coming to the summary of the biopsy findings, we found that it is a pink biopsy showing intraalveolar edema and hemorrhage. There is intraalveolar fibrin, numerous hyaline membranes approximating the outlines of the alveolar spaces, organizing pneumonia-like areas with the myofibroblastic proliferation, that is the OP polyps, inflammatory cells in the interstitium, predominantly lymphocytes. There is type 2 pneumocyte hyperplasia. There is organizing thrombus in the pulmonary arteries, and there are also microthrombi in the small pulmonary vessels. So coming to the clinico-radiopathological correlation, a 3 weeks history, acute respiratory failure, COVID test is positive, imaging is showing bilateral ground glass infiltrates, and culture stains and bug stains, culture studies and bug stains were negative. So what is the final diagnosis in this? How do you sign out this case? Acute and organizing diffuse alveolar damage consistent with COVID-19 pneumonia. So what is COVID-19? You all know that it is an infectious respiratory disease caused by novel coronavirus SARS-CoV-2. Acute respiratory distress syndrome, this is the severe clinical manifestation of COVID-19, and this is the significant contributor of death in this disease. So in this ARDS, the onset of symptoms is typically within hours, days and weeks before the biopsy. The symptoms include severe dyspnea, hypoxemia and rapid progressive respiratory failure. And the morphological prototype of this acute lung injury pattern associated with diffuse alveolar damage is associated with the ARDS is diffuse alveolar damage. So this is how the radiology appears. This is the AP chest radiograph. And this is the axial CE-CT showing diffuse, bilateral, symmetric, heterogeneous ground glass opacity. So this is how the COVID-19 ARDS lungs look like. And there are different etiologies for diffuse alveolar damage pattern, which includes infections, adverse drug reactions, connective tissue diseases, alveolar hemorrhage syndromes, sepsis, noxious inhalants like e-cigarette, the E-Valley. E-Valley is electronic vaping associated lung injury, which is very much common in USA, and shock. And when the cause is not identified, it is idiopathic, which is also called as acute interstitial pneumonia or Hammond-Rich syndrome. So out of all these, infection is the most common cause of this diffuse alveolar damage pattern. So always bug stains have to be done to rule out infection. So coming to the microscopy of COVID-19, so as I said, the severe COVID-19 pneumonia, it shows features of diffuse alveolar damage. So diffuse alveolar damage is in three phases: the exudative phase, the organizing phase, and the fibrotic phase. The exudative phase shows interstitial and intraalveolar edema. Hemorrhage and fibrin, hyaline membrane formation, fibrinoid necrosis of small vessels, fibrin thrombi, type 2 pneumocyte hyperplasia just begins in the exudative phase. So all these features we have seen in our case. And this is the infarct lung. This picture shows this infarcted lung. This is all the lung infarct, and on the lung infarct there is the superimposed fungal colony which is growing on this. And this is aspergillus, so pulmonary artery with a fungal colony. And apart from these, there may, in the biopsy we can see the features of the underlying disease. So these are all the diseases, the malignancy. The underlying disease could be malignancy, autoimmune disease which got flared up due to this COVID-19, sarcoidosis, and smoking-related interstitial lung disease. So these are all the findings, microscopic findings, which are encountered in a COVID-19 biopsy. So coming to the key points, in acute lung injury, always try to identify an etiology, search for helpful histologic features, then correlate with clinical history, cultures, and serology. Infection is the most common cause, as I've already said, so always do bug stains, always correlate with cultures, do viral IHCs and PCR wherever applicable. And yeah, as I've already said, the microscopic of severe COVID-19 infection shows features of diffuse alveolar damage. Thromboemboli are not unique only to COVID-19. They can be seen in any severe case of diffuse alveolar damage. So this is the Mayo Clinic. This is the Mayo Clinic Hospital in Phoenix. Mayo Clinic building in the Scottsdale campus. And thank you. Okay, sir. Okay, yeah.
Is a lifelong pursuit. Sometimes we learn something new, and sometimes we relearn something we already know. But the day we stop learning, we stop living. And that is the endeavor of all these CMEs that are conducted all over the country. I think I'll wait for the light for a second. I would invite the dignitaries to join us on stage. Firstly, Dr. Radha Madhav Tripathi, our very honorable principal, NRI Institute of Medical Sciences. Thank you, sir. Dr. Krishnamurthy sir, our medical superintendent. Our very honorable professor and head of department, Dr. A. Bhagyalakshmi ma'am. Thank you, ma'am. Secretary IAPM AP Chapter, Dr. Kiran Kumar sir. Our observer, Dr. K. Shilpa, who is also Assistant Professor, Department of Medical Oncology at Andhra Medical College and KGH. Our senior guest speaker, Dr. Pradeep Vaideshwar. And finally, our organizing secretary, Dr. Sharma sir. Thank you, sirs and ma'am. Tamasoma Jyotirgamaya. I now request the dignitaries on stage to light the auspicious lamp to dispel the darkness of ignorance and move in the path of light and knowledge. Please. No program can be a success without invoking the blessings of the Almighty. I request all to rise for the prayer song.
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि गानचतुराय गानप्राणाय गानान्तरात्मने गानोत्सुकाय गानमत्ताय गानोत्सुकमनसे गुरुपूजिताय गुरुदैवताय गुरुकुलस्थायिने गुरुविक्रमाय गुह्यप्रवराय गुणवे गुणगुरवे गुरुदैत्यगलक्षेत्रे गुरुधर्मसदाराध्याय गुरुपुत्रपरित्रात्रे गुरुपाखण्डखण्डकाय गीतसाराय गीततत्त्वाय गीतगोत्राय धीमहि गूढगुल्फाय गन्धमत्ताय गोजयप्रदाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि
Thank you, Tejasvi, for that soulful rendition, and a very, very thank you to all the dignitaries. I request our organizing chairperson, Dr. A. Bhagyalakshmi, Professor and Head of Department, NRI Institute of Medical Sciences, to address the gathering. Ma'am, please.
Respected Principal Sir, Dr. Radha Madhav Tripathi, and beloved Superintendent Sir, Krishnamurthy Shastri, and Observer, Dr. Shilpa, Organizing Secretary, AP State Organizing Secretary, Dr. Kiran Kumar, and the Secretary of the CME, Dr. Sharma, and eminent pathologists, Dr. Pradeep, Dr. Sharada, and Dr. Hina. I extend a hearty and warm welcome to one and all for this CME. Though our pathology department has been quite eager to conduct a CME like this since long, today only we could make it happen for the first time, largely because of a strong resolve, exciting encouragement, and non-stop support provided by our beloved management. So at the outset, I would like to convey my heartfelt thanks to NRI Institute of Medical Sciences Management, the CEO, Sri DJ Bharat Reddy sir, Medical Director, Dr. Venkatratnam sir, and Principal Dr. Radha Madhav Tripathi for giving me and my team the historic opportunity to conduct this CME. Special thanks to IAPM AP State Chapter for giving their concurrence for conducting this 6th midterm CME in the state by us after a gap of almost 3 years. The contemporary crisis times of COVID-19 pandemic and the emerging environmental changes has prompted us to choose the inescapable topic of updates in pulmonary pathology as the theme of this CME. It is our good fortune that some of the best possible pathologists, radiologists, and pathologists, pulmonologists in the country have gracefully accepted to enlighten the participants in this CME with their expertise, experiences, exposure, understanding, views, and insights on various facets of given topic by adopting a well-knit multidisciplinary approach. Special thought is given to ensure that the content of the CME is of immediate relevance, practical utility, and of thought-provoking nature for the participants. It is heartening to know that the number of participants who registered for this CME has crossed the 500 mark. So we are overwhelmed by the huge response, and we express our sincere thanks to the fraternity of the concerned medical specialties for reposing immense confidence on us. We request all of you to take active part in the CME and make the CME a grand success and an event, memorable event. Thank you, one and all. Thank you.
Thank you very much, ma'am, for putting all our thoughts together. I now invite our medical superintendent, Dr. Krishnamurthy sir, to please come up and share his thoughts with us. Sir.
Respected Chief Guest, Dr. Radha Madhav Tripathi, Principal NRIMS, and Dr. Bhagyalakshmi Garu, and observer from the APMC, and the IAPM Secretary, and Dr. Sharma, Organizing Secretary of the event, and all the respected professors, and very honorable speakers, guest speakers. A very good morning to all of you. I am very happy to be associated with this midterm CME of pathology and pulmonology. which is very much essential in the backdrop of this recent COVID pandemic. I am very happy that we are organizing this midterm CME in our college under the able guidance of our management, Director Garu and CEO Garu. I am very thankful to them for providing all the infrastructure and facilities required. Hope all of you are enjoying the academic feast, and I wish the function all success. Thank you.
Thank you, sir. I now invite Dr. K. Shilpa, observer from APMC, to please say a few words to us.
Respected dignitaries on the dais and off the dais, a very good morning to one and all. I'm really happy to be a part of this program today, and really delighted to know that more than 500 participants are participating both offline and online. It's really a huge gathering. Since the past 6-8 months, I've been attending as observer to several conferences, but this is really a huge number. So congratulations to the team, sir. That speaks the efforts of the organizing secretary as well as the principal and the superintendent, sir. Hope you keep on continuing. I know Bhagyalakshmi madam very well because I was a student of Andhra Medical College, and she is academically oriented, and as vice principal, she has done a lot of academic achievements to Andhra Medical College. And I think the Department of Pathology, NHS, is really fortunate to have her as HOD. Ma'am, hope you continue the same, ma'am, as you have done in Andhra Medical College. And I once again congratulate the entire team for this conference, and all the best to you. And thank you, Principal Sir and Superintendent Sir. I think Principal Sir was constantly calling me, and also Sharma Sir was constantly calling me, updating me everything. So thank you so much, and wish you all the best.
Thank you, ma'am. We indeed feel fortunate. I now invite Secretary IAPM AP Chapter, Dr. Kiran Kumar Sir, to please share his thoughts with us.
Good afternoon to all. Respected dignitaries on the dais, guests, delegates, and all the postgraduates. So it's indeed a very heartwarming session because we are able to have this physical IAPM meeting, this academic program, after a gap of almost 3 years. Anyhow, last year we had a complete online midterm CME hosted by Kuppam, PES Medical College Kuppam, and they could successfully do it. It was completely online. But this session, because it was in the peak of COVID times, they could not have a physical meeting. It was completely online. But now, fortunately, with all the efforts and enthusiasm of the dynamic team of Department of Pathology of NRI Medical College, under the leadership of Bhagyalakshmi Madam and the dynamic organizing secretary, our Sharma Sir. So this is possible, where very significant number of delegates are available here, and they have attended physically also, apart from the large number of online delegates. So I heartfully congratulate and thank the entire dynamic team of Department of Pathology and the management of this prestigious institute of NRI Medical College for accepting our request and voluntarily coming forward to conduct this wonderful session, and with so many eminent speakers in clinical pulmonology and radiology, and also the pulmonary pathologists from Mumbai. We have the very eminent and expert speakers we have seen. So for this wonderful academic feast, so I thank everyone, and I thank the management and Department of Pathology and the team for this wonderful event. Thank you very much. On behalf of IAPM AP chapter, thank you very much.
Thank you very much for your support and encouragement, sir. Now, we would all like to hear our chief guest, Principal Dr. Radha Madhav Tripathi, sir, to please address the gathering.
Thank you, Dr. Bandana.
good morning to everyone. Actually, this is good noon. And we are very, very happy here as the principal of this NRI Medical College, as we are holding a physical conference. Both offline and online delegates are also participating here. So again, I congratulate and welcome you. The dignitary and the dais, my friend, our medical superintendent, Professor Krishnamurthy Garu, your beloved head of the department, organizing chairman, Professor Bhagyalakshmi ma'am, my dear younger brother, you can say dear Sarma Garu, our beloved observer, Dr. K. Silpa Garu, Dr. Kiran Kumarji, Dr. Pradeep, Dr. Hina, Dr. Sarada, all the professors, heads of the department, of all the department, our delegates both offline and online, the Department of Pulmonary Medicine, Radiology, and the associated branches of medicine, all my dear colleagues, my dear PG students, media people, ladies and gentlemen. This gives me an immense pleasure to accord a very warm and cordial welcome to all of you to this auspicious day of celebration of 6th midterm CME of IAPM AP branch 2022 with the Association of Pulmonary Medicine and Pathology. This type of academic fest should be organized periodically, and there was no scope for us during these 2 years of this, we are in the midst of COVID. So today we are fortunate to organize these things. So thank you all for your active participation. And also we give special thanks to Dr. Kiran Kumar, who has also given us permission to conduct this CME here. And also the Association of IAPM and all the organizers. I thank you all, and I give special thanks to Dr. K. Silpa, our observer of to observe the things what is happening. Actually, this is required periodically because the quality of the CME or any conference must be monitored centrally. So nothing to say because time is less. This is time for lunch. Again, I invite you, I congratulate you for your participation. Thank you all again.
Thank you so much, sir, for your words, for your support, and for your leadership. With that, we conclude the inaugural ceremony. I thank all the dignitaries who have given us their blessings and support. Thank you to all the delegates on both sides of the screen, physical as well as virtual. A special thanks to the IT team, the BD team, the management, and all the support staff. Very, very thank you, and Jai Hind. I think everyone is feeling quite hungry, so we will break for lunch, and we will meet back at 2:10. Exactly at 2:10, we will restart our case-based scenarios. And followed by the slide quiz. So all the postgraduates, be ready for the slide quiz. The lunch is served. Our postgraduates will help you to the venue of the lunch, so you can follow them. Thank you.
Vandana. Okay.
is one case by Dr. Sharda. Just minimize this. Yeah, there is one case. Sharda, which case? Yeah.
Shall I close this? This is Dr. Heena's. Oh, this one. No, any feedback from the participants on Yes. So how they wanted me to, like, which one they are comfortable with? So shall I go in the middle and then talk?
Yes,
You want me to go?
I think that is because they are not able to see what you're pointing at.
So this is the
Point. This is the point. Yes.
voice is resounding. No, the mic, I didn't get to, yeah. This is not visible. The screen is not showing.
Yes, ma'am.
Thank you. Yeah. So we are now continuing with our case-based slide seminars. So this is the second case, and I'll be discussing the second case, and this is case number 12, which I am discussing as the second case. So this is the history that is given to you. It is 60-year-old female with 9-month history of waxing and waning, bilateral pulmonary infiltrates, occasionally steroid responsive. So this is the history that was provided. Further history is the patient presented with 1-week history of moderate chest pain and dry cough and intermittent fever since 1 week. She has a recent history of hospital admission for pneumonia and was treated with antibiotics. She was also a known case of severe persistent asthma. Her CBC was markedly increased with a TLC of 29,000 cells per cubic millimeter with 51% eosinophils. The infectious disease workup, including cultures, were negative. Her COVID test was negative, and bronchoalveolar lavage fluid showed 40% eosinophils. The gene expert was negative. Her ANCA studies were negative, and HRCT showed waxing and waning bilateral pulmonary infiltrate since 9 months. So these were the pictures that were provided to you. And so any guesses, what is the pattern? What is the pattern? So here you can see these are all the alveoli, and these alveoli are filled with these inflammatory cells. So what is the pattern? Alveolar filling pattern. Okay? So then going to the next images. So this picture shows that these are all the alveolar spaces. These are all the alveolar spaces, and this is the interstitium. And we find that there are tons and tons of eosinophils in these alveoli. The alveolar spaces are completely filled with dense eosinophilic collections, and some of these eosinophils you find in these interstitium as well. Going to the next picture. So this picture shows that there is this dense eosinophilic microabscess in the center. Along with that, there are these macrophages, and you can also find that there are few multinucleated giant cells. Next, going to the next picture. So along with eosinophils, you find these macrophages which are present in this entity are characteristically, they show a eosinophilic appearance. And apart from this, there are also few organizing polyps. So these are the organizing polyps, these branching structures where the fibroblasts are proliferating in a myxoid matrix. This is a typical appearance of an organizing polyp. So this is the next picture, and this picture shows that there is also intra-alveoli fibrin. So there is focal fibrin as well in the alveolar spaces, and along with that there is these reactive type 2 pneumocytes. So these are the alveoli which are lined by these reactive type 2 pneumocytes. And this picture shows that there is some mild to moderate interstitial fibrosis. This is the alveolar interstitium, and you find that the alveolar interstitium is widened by some amount of fibrosis. So summary of the biopsy findings, we have seen that there is intraalveolar accumulation of eosinophils along with eosinophilic microabscesses, plump eosinophilic macrophages, multinucleated giant cells, some interstitial eosinophils, there's mild interstitial pneumonia, type 2 pneumocyte hyperplasia, focal areas of fibrin in the air spaces, patchy airspace and alveolar duct organization in the form of OP polyps, variable interstitial fibrosis, but we didn't find any granulomas or features of vasculitis or capillaritis or diffuse alveolar hemorrhage. We didn't find any RS cells, we didn't find any evidence of malignancy. The special stains, that is AFB and GMS, are negative. So coming to the clinico-radiopathocorrelation, so female with 9-month history of waxing and waning, bilateral pulmonary infiltrates, occasionally steroid responsive with 51% eosinophils in the CBC count and 40% eosinophils in the bowel fluid. So with this all, and with the specific biopsy findings. So what is the diagnosis? Any guesses? Fibrosing, what's that? No. So do you find eosinophils in hypersensitivity pneumonitis? Yeah. So it is chronic eosinophilic pneumonia. So eosinophilic lung diseases, they have a varied etiology. So this is all the etiology of eosinophilic lung diseases, where there is idiopathic eosinophilic pneumonias and secondary eosinophilic pneumonias. Secondary eosinophilic pneumonias could be due to infections like parasites and fungal infections, then could be due to some drugs or immunological and systemic diseases like allergic bronchopulmonary fungal disease, asthma, collagen vascular disease, and Churg-Strauss syndrome, some malignancies like Hodgkin's, hypoeosinophilic syndrome, and smoking induced. So out of all this, the idiopathic eosinophilic pneumonias are more common, and these idiopathic eosinophilic pneumonias could be acute or chronic, simple eosinophilic pneumonia, and incidental pneumonias. So coming to idiopathic eosinophilic pneumonia, acute eosinophilic pneumonia presents with a short course, less than a month, and the biopsy features are again that of acute lung injury pattern, that is diffuse alveolar damage, and usually this is diagnosed on bowel fluid eosinophil counts. Whereas chronic eosinophilic pneumonia typically has a longer period of low-grade symptoms with white loss, but both acute as well as chronic eosinophilic pneumonias, they have a favorable response to corticosteroids. So recognition of this type of eosinophilic pneumonias, this type of eosinophilic pneumonias by the pathologist is very critical because they can respond with steroids. So coming to the clinical features, frequently they are middle-aged women with asthma in 1/4 of the cases, and the symptoms include fever, sweats, weight loss, cough, and dyspnea. The peripheral blood eosinophilia can often be identified. These patients can have peripheral blood eosinophilia, but again, this could be transient, and sometimes it can be entirely absent. So coming to the radiology, the chronic eosinophilic pneumonia, these eosinophilic pneumonia, they have a typical appearance of bilateral, non-segmental symmetric consolidation. So these are the consolidation, these whitish areas which are present. This is the areas of consolidation. They are bilateral, they are symmetric, and they have peripheral and upper lung zone predominance. So these consolidations are peripheral. So this is the classic appearance of the radiology of the HRCT of chronic eosinophilic pneumonia. And these infiltrates are typically, they are termed as migratory infiltrates because they disappear spontaneously or again recur in the same place or somewhere else. So they have a tendency to spontaneously disappear and then recur again. So that is the reason they are called as migratory infiltrates. So microscopy I have already discussed. Coming to the differential diagnosis, when the organizing polyps, usually the organizing polyps are very focal in chronic eosinophilic pneumonias, but if there is prominence of these organizing polyps, then organizing pneumonia will enter the differential diagnosis. When the fibrin which is present is prominent, then all the other conditions leading to diffuse alveolar damage comes into differential diagnosis. And when the fibrosis, usually the fibrosis is mild to moderate in eosinophilic pneumonias, but if the fibrosis is more, all the chronic fibrosing lung diseases enter the differential diagnosis. And when the histiocytes and giant cells are prominent, then all the granulomatous diseases, they enter into the differential diagnosis of chronic eosinophilic pneumonia. So how do you rule out? First, you have to rule out the other entities like infections by doing bug stains. Then always see for vasculitis, features of vasculitis, capillaritis, and Churg-Strauss. Do the Cianca-Pianca studies to rule out Churg-Strauss syndrome. Then ask for the history of drugs or any collagen vascular diseases or any history of pneumothorax. Pneumothorax can also show the presence of eosinophils, but radiology in this context may help to differentiate these two entities. So the key points of this case, always rule out infection before diagnosing eosinophilic pneumonias, because eosinophilic pneumonias, the treatment is steroids, but again, if the infection is not ruled out, steroids will definitely has a bad outcome. So always rule out infections by puffing special stains and correlating with culture studies. Prior treatment with steroids can greatly reduce the number of eosinophils. So if the clinician has already put the patient on steroid, then the number of eosinophils might reduce. But again, if the radiology and the clinical features are of chronic eosinophilic pneumonia, even if you find even few eosinophils, you can make a diagnosis of chronic eosinophilic pneumonia. And it is important not to miss this diagnosis because it has good corticosteroid response. So these are the giant cacti which I clicked in Sedona, which is in Arizona. So thank you for your patient hearing.
Switch on this. Yeah, hearty good hello. Yeah, hearty good afternoon to everyone. I'm Dr. Hina Desai here from Mumbai, and it gives me immense pleasure. And this is my first visit to Visakhapatnam, and I'm really having a great time here. It's a beautiful place, and I'm very glad to be a part of the faculty at NRI Medical College. And at the outset, I would like to thank the organizers, Bhagyalakshmi ma'am, Sharma sir, the entire organizing team, and my mentors, Dr. Gayatri and Dr. Pradeep, for giving me an opportunity to present in this forum. Okay, so I move on to case number 18. Okay, so since we are following the pattern, the cases would be a little not in order, but you all can refer to the history given in case number 18. Okay, so this was a 31-year-old male patient who came with fever with breathlessness since 5 days and had a hospital admission of only 1 hour, following which a complete autopsy was asked for. So at autopsy, the main findings, the predominant findings were seen in the lungs. So as we see over here, the lung weighed around 500 grams, so it was enlarged, both the lungs, and the pleura was thickened, it was hazy. And what we are seeing over here on this aspect are multiple tiny nodules which are yellowish white in color. which are also seen on the cut surface. So if you see, the entire cut surface is showing all these yellow-white tiny nodules, almost giving a a miliary kind of appearance. So on microscopy, seeing the increasing number of tuberculosis cases, our first impression on gross was tuberculosis. And on microscopy, what we saw was these large areas of necrosis. They were like caseous necrosis. Lot of inflammatory infiltrate. So there were neutrophils, there were granulomas. Yeah, so here we are seeing a caseating granuloma. We are seeing a lot of necrosis. We are seeing Langhans type of giant cells. And it was surrounded by a lot of epithelioid cells and lymphocytes. Okay, so it looked to be a case of tuberculosis, and we were going to sign off the report, but the more sections showed something little different. So what we're seeing over here is in the area surrounding the area of tuberculosis, what we could identify were these spaces which were lined by cuboidal epithelial cells. Also seen were these tiny glandular elements which were lined by cuboidal cells, and they were predominantly surrounding these areas of necrosis. So some more areas of necrosis, inflammation, and the similar kind of tubular or glandular elements. This is the higher power view of the same. So you can see they look relatively bland, although there were areas where we could see some amount of nuclear atypia. So that was more alarming. What are we dealing with? Are we dealing with tuberculosis? But what are these glandular elements doing there? So we did special stains, and we did special stains like AFB, we did a GMS, we did PAS. GMS and PAS were negative. However, AFB was strongly positive in this case. So yeah, so TB was not a problem at all, but what were those glandular elements? So was it like a bronchialization of the alveoli, although you get more columnar cells in those? Was it a type 2 pneumocyte hyperplasia, although we've not encountered so much of florid type 2 pneumocyte hyperplasia with tuberculosis? Were we dealing with an atypical adenomatous alveolar hyperplasia, because we did see some bizarre cells? And last to complete the list was, were we dealing with an adenocarcinoma, underlying adenocarcinoma with tuberculosis? But since majority of these like glandular elements, and they were all surrounding the areas of necrosis, we thought of these two possibilities. So either it was bronchialization or it was type 2 pneumocyte hyperplasia. So the common reactive processes in the lung which can mimic lung carcinomas can be a type 2 pneumocyte hyperplasia, bronchialization of the alveoli called as lambertosis. It can be squamous metaplasia around the bronchioles, post-radiation or chemotherapy, and it could be a squamous metaplasia in tracheobronchial ulceration within the cavitatory abscesses. So bronchialization, what exactly is bronchialization? So before we come to the final diagnosis, a little about what is bronchialization. It's a distinct type of metaplasia composed of cells which resemble the airway epithelium in the alveolar component, usually seen in association with carcinomas, pulmonary fibrosis, inflammation, chemical irritation, and exposure to certain carcinogens. They have been graded from grade 1 to grade 4, with grade 1 having a single alveolus lined by cuboidal epithelium, to as high as grade 4, where you can see a multi-layered papillary formation within the alveolar spaces. So when we looked up a bronchialization of alveoli along with tuberculosis. In literature in PubMed, we could find only one case. Okay, so it was that rare. And then we thought, okay, could it, it's not so common, so could it be a florid type 2 pneumocyte hyperplasia, which can be seen with many conditions like DAD, organizing pneumonia, NSIP, and the list is long. And we searched type 2 pneumocyte hyperplasia with tuberculosis, and yeah, there are more articles than bronchialization. So we went back, we've seen a lot of cases of tuberculosis, whichever we had, we went back to see whether we missed out on any type 2 pneumocyte hyperplasia, and we actually, like I spoke to Pradeep sir also, so at their institute also they've not seen cases like these. So this actually was an exuberant type 2, since they were overlying the areas of necrosis and the granulomas. This was exuberant type 2 pneumocyte hyperplasia associated with tuberculosis. It was a secondary reactive change which mimicked an adenocarcinoma. So amongst the 6 patterns of interstitial lung disease, where do you think we can put this up? In which pattern does it fit into? Okay, so because we had a lot of necrosis, we had alveolar spaces having necrotic material, neutrophils, so this would fall into the category of alveolar filling. So per se, because it was an autopsy case, we could go back, take more sections and identify it and call it a type 2 pneumocyte hyperplasia. But mind you, if this was a biopsy, then it would be really difficult where you're seeing all of these, those glandular elements with reactive atypia, and then you don't know where to put it up. So the take-home message is, keep in mind that tuberculosis can have florid type 2 pneumocyte hyperplasia adjacent to the areas of necrosis. Okay, thank you for that case. So going on to the next case, again this is case 8 according to the histories which were provided to you. So this was a 55-year-old female who came with breathlessness, chest pain since 6 months, and a CT scan done showed bilateral diffuse infiltrates and left lung upper lobe abscess. So this is what was seen. This was an open lung biopsy, and what was seen was predominantly the alveoli were filled with some kind of material. Okay, it looked very foamy at this part. Okay, we go higher, and what we are seeing is the lymphocytes scattered. There are a lot of lipid-laden macrophages. Okay, in addition to all these lipid-laden macrophages, neutrophils, what we also saw were areas of necrosis, and there were these large lipid vacuoles as well. In addition to this, we also saw areas where there were granulomas along with Langhans and foreign body type of giant cells. This is another area showing necrosis in the vicinity, and it also had these large lipid vacuoles. So any clues to the diagnosis? So we had necrotizing granulomas, we had these larger vacuoles, and we also had vacuolated macrophages. So any clues to the diagnosis? So when we have a lot of lipid-laden macrophages along with these large lipid vacuoles, yeah, lipoid pneumonia. So we need to categorize whether it's an exogenous or an endogenous lipoid pneumonia. Now this patient we called it exogenous lipoid pneumonia because this patient had a history of aspirating mineral oil-based laxatives. Here was a case of chronic constipation. So that could be probably the reason why he had a exogenous lipoid pneumonia. So the granulomatous inflammation, what we saw was you need to do special stains which were negative in this case, but granulomatous inflammation, what was there in this case was the reaction to the lipid material. Possible associations can be seen with atypical mycobacterial infection, and because it is known to occur with aspirated lipids. The causes are plenty, and the most common cause is chronic aspiration of mineral oil or related substances. In fact, the common things what we use, like Vicks inhaler, like Vicks what we use, then Vaseline jelly and lip balms, they can also give rise to aspiration. So that was a little worrisome because they are very rampantly used. And the predisposing conditions are seen with esophageal structural disease, neurological conditions, and in infants it can be seen with feeding difficulties. So the other sources can also be industrial inhalation of burning fats, and especially those, the ones who have those fire eaters. So it's prone to occur in them as well. So they usually have an acute exogenous pneumonia. So it could be an acute or a chronic. So acute, which I told you, it's like a very acute event. And chronic, it is usually seen with a long-standing aspiration of the material, like seen with mineral oil. So radiologically, it shows the presence of basilar infiltrates, or sometimes it can mimic a mass where the difficulty becomes very difficult on a CT scan. And why does it present like a mass? It's called as a paraphenoma, where you have lipid-laden macrophages and they are surrounded by areas of fibrosis. So large areas of lipid-laden macrophages surrounded by fibrosis, which can mimic it can mimic a malignancy on imaging. That's called as a paraphenoma. So that's very rare, though that should be also kept in mind. The clinical course is benign, and with discontinuation of the use of the offending agent, usually the disease reverts back to normal. A very close differential diagnosis, which I spoke to you all initially, would be an endogenous lipoid pneumonia, which is also called as post-obstructive, golden, or cholesterol pneumonia. So the subtle points which helps you differentiate. is one is there are vacuoles which are present. They are usually a very fine vacuoles, and you can see a lot of cholesterol clefts. So we did not see any cholesterol clefts in this case, and they were large lipid-laden vacuoles. The other things is also those large lipid droplets, what we saw, those are also, those large lipid vacuoles are also not seen with an endogenous lipoid pneumonia. So usually, so this is how an endogenous lipoid pneumonia looks, and usually it is post-obstructive. So that's the cause of an endogenous lipoid pneumonia. Lesions which can have histiocytic proliferations in the lung, the lesion is endless. So we need to rule out based on the history and the CT findings. And in the 6 patterns of Leslie, where do you all think this would fit into? Yeah, so this would also fit into the alveolar filling pattern. So we did like 4 cases, and all of them were cases which had, we did 4 cases, 3 out of which were cases of alveolar filling. Thank you very much.
Okay, we go to case number 7. The history which was provided was a 36 years male with progressive dyspnea for the past 2 years with cough and loss of weight and repeated hospitalizations. He also developed facial puffiness, pedal edema and high-grade fever for the past 4 days. The CT had been suggestive of lymphangitis carcinomatosis and put on mechanical ventilation, but he succumbed within 3 days. So this is the gross appearance of the left lung, and what we can see, the entire pleura shows opacification. There is flaky, grayish white, fibrinous exudate all over, and this lung was extremely firm to feel. That means even before cutting the lung, we realized that this is entirely consolidated. And the cut surface showed the presence of these multifocal geographic yellowish white area punctuated by these red-brown areas of consolidation as well. And you can very well see both the colors here, pale yellowish white and a darker red-brown foci of consolidation. So it looked as if there were 2 areas or 2 reasons for producing this type of different appearances of consolidation. So let us go on to what the red-brown area showed. So here you can see that all the alveolar spaces are filled with inflammatory cells. So it is very obvious that we are dealing with which pattern? So we continue with alveolar filling pattern. So here all the alveolar spaces are filled with inflammatory cells, and when you look at the higher power, all these cells are nothing but neutrophils. So this is one more picture showing you the low power and high power of the alveolar filling lesions occupied entirely by neutrophils. Now, if you look closely at this particular high power, you can see that the neutrophils have their lobulated nuclei pushed a little into the periphery, which is very well seen in this particular photograph. So you can see that the arrow points to some cytoplasmic inclusion which is present within the cytoplasm. So multiple or many of these neutrophils are showing peripheral localization of their nuclei along with a nuclear inclusion. And what does this look like? If I use an example of SLE, sorry? Yes, it looks like as if we are dealing with a LE cell phenomenon. So you're seeing a deep, nice spherical eosinophilic inclusion within the cytoplasm of the neutrophil. Now, if you look at this particular corner, along with these neutrophils which are showing similar cytoplasmic changes, we also see presence of cholesterol clefts. And when we took more sections, these cholesterol clefts became more apparent. For example, here you see large numbers of cholesterol clefts. So there is some lipid or lipidogenic material also present within this, within the alveolar spaces. So there are inflammatory cells, there are cholesterol clefts, and in addition, you have this deeply eosinophilic acellular material which is looking like mashed potatoes. So any diagnosis you'd like to offer? Presence of alveolar spaces containing lipid and proteinaceous material. If you put the two things together, any diagnosis? And this was strongly PAS positive and diastase resistant. Yes? Exactly. So this is an example of alveolar phospholipoproteinosis which had remained undiagnosed for the past 2 years in this young patient. So this is actually included under orphan lung diseases. So it's a rare disease which is characterized by alveolar or distal airway accumulation of phospholipids and proteinaceous material, and it is consequent to defective surfactant clearance by the alveolar macrophages, and it has a slight male preponderance, and the peak frequency is at 25 to 40 years. And this is how alveolar proteinosis is classified into primary, secondary, and congenital. And in primary, you can have autoimmune and hereditary, whereas congenital is always or its related proteins. And you have a variety of causes for secondary alveolar proteinosis. So looking at this particular patient who did not have any other secondary cause, and he presented quite recently, so the diagnosis becomes a primary alveolar phospholipoproteinosis. Please note, it can be asymptomatic despite involvement of a large area of the lung, or it can be symptomatic and patients present with dyspnea, cough, or symptoms related to complication. When you go back to the history, terminally the patient did develop fever. Okay, now this is a classic pattern which was shown by Dr. Pradeep, the classic crazy pavement appearance where you have reticular shadows combined with a ground glass opacity. So what was the cause of that fever? It was because there was superadded infection. So can you see anything here? Is it bacteria or non-bacterial infection? If you see here, yeah, these look like fungal hyphae. So these are septate fungal hyphae belonging to species like Aspergillus. We have not done a culture, so we are calling it as a Aspergillus-like species. Some patients may have spontaneous remission, while few other cases have progressive fibrosis. In this case also, there were multiple areas which were showing interstitial fibrosis. So any long-standing case of alveolar lipoproteinosis can go into end-stage lung disease. Now, active intervention is not always required, and the best treatment that can be given to the patient is like a whole lung bronchoalveolar lavage. This was one other patient we had where the alveolar proteinosis was detected when the patient had gone for a health checkup before going to the Middle East, and we were surprised to find large areas of opacities in the lung. Biopsy was done. It showed alveolar proteinosis, and the patient very beautifully responded to whole lung lavage. Thank you. Yeah, yes.
Why it is called orphan lung disease, sir? You told category.
Because it is less frequent.
Less frequent.
Less frequent, yes.
Going to the next case. So, the case number 9. So this is the history that was given to you. 60-year-old with a pet cockatoo, presented with 3 months history of increasing shortness of breath accompanied by non-productive cough. Her imaging showed bilateral reticulation and groundless obesities. So this is what is this is how a cockatoo looks like. It is nothing but a parrot species. So these were the pictures that were provided to you. So based on the first picture, where does it fit into? Which pattern? So you see that these are all the alveolar spaces. This is the interstitium in between the alveolar spaces, and this interstitium is widened by inflammatory cells. So what is the pattern? It is? Yes, cellular infiltrates pattern. So these are the other images. So this is the first image, the same. This is the second image. A closer view of this first image shows that the interstitium, these are the alveolar spaces, and this is the interstitium in between, and this interstitium is widened by inflammatory cells, and these inflammatory cells are predominantly lymphocytes. This is the next image, and what do you find here? What are these? What is this? What is this? These are? What are these? Yes, these are granulomas. So you find these are granulomas with the multinucleated giant cells. And these granulomas, how do they appear? So whenever you find a granuloma, always you have to take into consideration some features to help in differentiating between the different granulomatous diseases. These are whether there is necrosis or not, whether there is that granuloma is a well distinct granuloma, or whether it is a loosely formed vague granuloma, and what is the position of the granuloma? Is it in the interstitial space or is it in the alveolar spaces? So where is the granuloma located here? Exactly. It is in the interstitium. And how does the granuloma, is it necrotizing or non-necrotizing? It is non-necrotizing. And is it a well-formed granuloma, or is it a vague, loosely formed granuloma? It is a vague, loosely formed granuloma. So here, these are all the clues for this entity. So these are vague, non-necrotizing granulomas present in the alveolar interstitium. So going to the next picture. So what is this structure here? This is the bronchiole lined by the respiratory epithelium. And here again you find these granulomas. This is again a granuloma with the multinucleated giant cells. This is another bronchiole over here. So the distribution of these granulomas is bronchiolocentric. And this is the next picture showing what are these? These These are fibroblastic proliferations in the myxoid background, and these are nothing but the foci of organizing pneumonia. So this next picture, what does this show? This feature is called as peribronchial metaplasia. This is nothing but the extension of the respiratory epithelium from the bronchiole to the surrounding alveolar spaces, into the surrounding alveoli. So this is the extension of this is the bronchiole. So this one is the bronchiole with the mucin which is present in the lumen, and from the respiratory epithelium from the bronchiole is extending into the surrounding alveoli. And this feature is called as peribronchial metaplasia. And what is this? This is a bronchiole, and this is the bronchiole with the respiratory epithelium, the lumen filled with mucin, and these are all the inflammatory cells, predominantly lymphocytes, which are present around this bronchiole, and this feature is called as chronic bronchiolitis. So coming to the summary of all the findings that we have seen that there is cellular interstitial pneumonia, there is cellular chronic bronchiolitis, loosely formed non-necrotizing granulomas and multinucleated giant cells located in the alveolar interstitium, alveolar spaces, and in the peribronchial interstitium. There is bronchiolocentric distribution of these features, and there is peribronchial metaplasia, which is also called as small airway remodeling or lambertosis, but we did not find any necrosis, we did not find any foreign material. So coming to the clinico-radiopathocorrelation, the patient has a PET CoCat2, she has a 3 months history of shortness of breath, that is subacute presentation. The radiology showed bilateral reticulation with ground glass opacities. The bug stains and cultures are negative. The autoimmune workup is negative. There is no history of drug intake, and there is no history of gastroesophageal reflux disease. So what is the final diagnosis? Sarcoidosis? Yeah. So this is non-fibrotic or cellular hypersensitivity pneumonia. So hypersensitivity pneumonia is also called as extrinsic allergic alveolitis. This is basically an alveolitis. Alveolitis means there is inflammation in the alveolar septum. So the cellular interstitial pneumonia is the predominant finding of hypersensitivity pneumonia. It is not the granulomas. Granulomas are present, but they are very few granulomas, and you literally have to search for the granulomas. They are not well defined or distinct granulomas. So it is basically the biopsy usually appears blue in hypersensitivity pneumonia because of the presence of this cellular interstitial pneumonia, which is actually the predominant finding. Lymphocyte, this is So this is a lymphocyte-mediated hypersensitivity reaction of lung parenchyma in response to inhalation of a large variety of antigens. So this is lymphocyte-mediated hypersensitivity. It is not eosinophil-mediated. So we do not find eosinophils in hypersensitivity pneumonia. And the most common exposure source is pet birds like pigeons, and the others are common antigens are thermophilic bacteria, molds, and fungal spores. So there are 3 forms: acute, subacute, and chronic forms. Subacute is the most commonly biopsies phase, and we see HP most often in this subacute phase. Acute HP is usually not biopsies, and the features are fever, dyspnea, and cough. And recently, there are all these 3 phases are categorized into only 2 categories based on the amount of fibrosis, which is very important to mention in the report. And these 2 categories are non-fibrotic or cellular HP and fibrotic HP. So this is the classical radiological appearance of hypersensitivity pneumonitis. It is upper and middle lobe predominance. This feature is very much important, upper and middle lobe predominance of diffuse bilateral ground glass opacities. So these are the white arrow is pointing, these small white dots. The white arrow is pointing to these small white dots. These are the ground glass opacities which are bilateral and which are diffuse. And along with that, there are these ill-defined cellular centrilobular nodules. Since it is a bronchiocentric process, there are centrinodular nodules. And the other important feature of this HP is mosaic attenuation. Mosaic attenuation, Dr. Pradeep has already mentioned in his radiology talk. Mosaic attenuation is nothing but areas of increased attenuation, which appears ground glass opacities, with areas of decreased attenuation, which appear as dark areas. So alternate white and dark areas, which is called as mosaic attenuation, and the classic, it is called as head cheese sign in HRCT. Along with that, there is interlobular septal thickening, there is peribronchovascular and subpleural reticulation, and chronic and advanced cases may or may not show this honeycombing. So this microscopic features I have already discussed, and this is the picture of acute HP. Acute hypersensitivity pneumonitis, usually not diagnosed, and you find this, in this biopsy, you find features of diffuse alveolar damage along with this granulomas. So what are these arrows pointing to? Yes, these are the hyaline membranes. Along with that, this annotated area here, this is the ill-defined granuloma. So granulomas with this hyaline membranes you find in acute HP, and chronic HP, there is fibrosis, and this fibrosis is typically airway-centered fibrosis. So coming to the other supportive lab tests which help in diagnosis, serum IgG antibodies may or may not be increased. So not always the IgG antibodies get increased. And another thing is, like 50% of these hypersensitivity pneumonitis do not have a history of known exposure. So if the history doesn't say that there is an exposure, doesn't mean that hypersensitivity pneumonitis can be ruled out if the biopsy findings are typical of HP. And bronchoalveolar lavage, there greater than 30 shows more than 30% lymphocytes. It is supportive, but again it lacks standardization. And CD4 CD8 ratio is usually decreased, but again this is also a not specific feature. So coming to the differential diagnosis, all the conditions showing granulomas like early sarcoidosis, but again sarcoidosis, the granulomas are non-necrotizing, but they are well-formed, distinct granulomas, and they have typically a perilymphatic distribution. This is a sarcoid granuloma. And aspiration, you find granulomatous disease, but again, you find this food particles. This is all this pink eosinophilic material over here. This is the aspirated food particles. Then drug reactions may show granulomas. Lymphoid interstitial pneumonia may show granulomas. But again, the interstitial inflammatory infiltrate is very dense in lymphoid interstitial pneumonia. Cellular NSIP is again a differential diagnosis where again you find these inflammatory infiltrate in the interstitium, but again cellular NSIP doesn't show these granulomas. Next, infection is always a cause for granulomas, and always you have to do bug stains whether the granulomas are necrotizing or non-necrotizing. Okay? Even if the granulomas are non-necrotizing, you should always do bug stains, AFib, AFB and GMS. And chronic HP, all chronic fibrosing lung diseases come under the differential diagnosis of chronic HP. And acute HP, again, all causes of diffuse alveolar damage. So what is this granuloma? This is a granuloma of tuberculosis. This is the necrotizing granuloma. In the center, there is caseous necrosis. You find these Langhans giant cells and foreign body giant cells. This is the appearance of the tuberculous granuloma. Next, most of these cases of hypersensitivity pneumonitis have favorable prognosis, unlike the other interstitial lung diseases, and they improve with appropriate treatment. And interstitial fibrosis, if present, that is associated with worse prognosis, and avoidance of the key of the antigen. This is the key for the HP management. Suppose if the antigen is from the bird exposure, so you have to avoid getting exposed to the birds, and oral corticosteroid or systemic steroids are considered for severe cases. So coming to the key points, HP can often go undiagnosed as the offending antigen is not always recognized. It is therefore very helpful for the pathologist to suggest the diagnosis of hypersensitivity when the typical features are present on biopsy. And another point is, it is always important to take deeper sections when there is strong clinical suspicion. Suppose if the clinician is strongly suspecting a diagnosis of hypersensitivity, but you did not find any granulomas or giant cells, always make it a habit that you go and take deeper sections. You will definitely find a granuloma, at least a vague collection of giant cells. And another thing is, chronic HP is often misdiagnosed as UIP of IPF. IPF is idiopathic pulmonary fibrosis. So, when this chronic HP, when the fibrosis shows the UIP pattern of fibrosis, it can be misdiagnosed as IPF. So it is important. So it's very important to make the distinction between chronic HP and UIP of IPF, because the treatment modalities are very different for both. So biopsy clues like bridging fibrosis and peribronchial metaplasia and history of exposure to the antigen and radiology correlation always helps. Like in chronic HP, the radiological features are more prominent in the upper and middle lobes, whereas in IPF, the features are more common in the lower lobes. And features like honeycombing also will be present in UIP of IPF. So it's very important to make the distinction between these two entities. So this is the recent classification of HP, which is given in the American Journal of Respiratory and Critical Care Medicine. So I'm not going through all these things. So you can find this. This is a free article. It can be downloaded. So these are the Red Rock Mountains in Sedona, which I clicked in Arizona. And thank you for your patient hearing. And I'll go to the next case. So this is case number 14. This is the history that was provided. A 30-year female presented with shortness of breath, cough, malaise. HRCT showed diffuse bilateral ground glass opacities with scattered small thin-walled cysts and few small discrete nodules. The follow-up investigation showed positive autoimmune serology. These were the pictures that were provided. So based on the first picture, what is the pattern? Cellular infiltrates, because the interstitium is widened by dense collections of these lymphoid cells. So it is a cellular infiltrates pattern. So this is how it looked on the scanner, the biopsy looked under scanner. So these are cysts which was given in your history. The radiology showed this presence of this. These blue arrows showed the cyst. And this annotated area, when it is seen under hyper, this is how it appears. So these are the alveolar spaces, this is the interstitium, and this interstitium is very much widened by dense collection of lymphoid cells. So this is another hyper view of the same, showing dense lymphocytic infiltrate in the interstitium. And what is this? What do you find here? This is another granuloma, a very vague, ill-defined granuloma with these histiocytes here. So vague non-necrotizing granulomas, these are the cysts which were present. This is the cyst, thin-walled cyst, which is lined by this thin-walled epithelium and fibrosis. And what is this? This is the bronchiole. And what do you find in this bronchiole? Around this bronchiole, there is dense lymphoid aggregates, and this is called as follicular bronchiolitis. So this first picture, so whenever you find this dense lymphoid inflammatory infiltrate, dense lymphoid aggregates in the interstitium, always you should rule out what should you rule out? Lymphoma, lymphoproliferative disease. So immunohistochemistry has to be performed, and so this is the HE stain, and this IHC shows that there is predominantly this inflammatory infiltrate which is present is predominantly CD5 positive lymphocytes, very few collections of CD20 B lymphocytes, and kappa and lambda showed polyclonality. So summary of the biopsy findings: marked expansion of the interstitium by diffuse, dense, polymorphous lymphocytes and plasma cells. So these terms are important: diffuse, dense, and they are polymorphous. Along with that, there are loose, ill-defined epithelioid granulomas. There are thin wall cysts, and immunohistochemistry showed a T-cell-rich process with minor B-cell component and a polytypic plasma cell population. Coming to the clinico-radio correlation, young female, 30-year-old female, HRCT showing diffuse bilateral ground glass opacities, small thin wall cysts with small solid nodules, and positive autoimmune serology. So what is the final diagnosis? CTD, connective tissue disease with what pattern? Lymphocytic interstitial pneumonia pattern in a known case of Sjogren's syndrome. So the patient is a known case of Sjogren's syndrome. Yes, connective tissue disease with this LIP pattern. So coming to lymphoid interstitial pneumonia, it is a rare interstitial pneumonia of pattern, again of varied etiology. So there's a small history for this term. In 1969, Lebo and Carrington first described lymphoid interstitial pneumonia as interstitial lung disease. But later, most of them, they turned out to be a low-grade lymphoproliferative disease, most especially the mild lymphomas. So whatever they have diagnosed as LIP, they later turned out to be mild lymphomas. But so the term, the LIP was excluded from the classification. But later again, currently, the American Thoracic Society and European Respiratory Society classification again included this idiopathic LIP as a rare idiopathic interstitial pneumonia. So now idiopathic LIP is there in the classification, current ATS classification, but it is included as a rare type of idiopathic interstitial pneumonia. So there is again varied etiology, of collagen vascular disease, especially Sjogren's, autoimmune diseases, common variable immunodeficiency, infection with HIV, chronic viral hepatitis, Crohn's, bone marrow transplantation, drugs, and idiopathic LIP, out of which the most common cause is a collagen vascular disease, especially Sjogren's syndrome. This is the most common cause of LIP. So most of the cases of secondary LIP are in middle-aged women, and the symptoms include slowly progressive dyspnea, dry cough, and systemic symptoms like malaise, fever, and weight loss. And along with that, there are symptoms of associated systemic conditions like pleural pain, arthralgias, immunoglobulin abnormalities in serum. So this is the radiological appearance in the HRCT. There are bilateral ground glass opacities along with that with lower lobe predominance and thin wall cysts. So you can find this cysts, multiple cysts which are present bilaterally, these dark areas here which are present bilaterally. So these are the thin wall cysts. Along with that, there is mild interlobular septal thickening. So microscopy I have already discussed. So the main differential diagnosis of LIP is NSIP, hypersensitivity pneumonitis, IG4 disease, and lymphoma. So in NSIP also, the interstitial inflammatory infiltrate is present, but it is not as dense like that in LIP. It's only a few cells thick. And in HP, the cellular infiltrates are present, but again they are, as I've already said, they are bronchiolocentric in distribution. And in IgG4 disease, there is large numbers of IgG4 positive plasma cells, which are more predominant. And in lymphoma, these lymphoid infiltrates are dense, but again these lymphoid infiltrates are monomorphous. Next, vascular infiltration is common in lymphoma, and granulomas are present in LIP, HP, and lymphomas, but you do not find granulomas in NSIP and IgG4 disease. And these, all the first four entities are polyclonal, but lymphoma is monoclonal. So this is how you differentiate the other four entities from LIP. So coming to the key points, in every case showing LIP pattern or whenever there is an exuberant lymphoid reaction, always rule out a hematolymphoid malignancy. Always do IHC, always do the other molecular investigations and rule out hematolymphoid malignancy. And features which favor going in favor of lymphoma are pleural effusion and presence of lymphadenopathy. And LIP as an idiopathic interstitial pneumonia is very rare, so always you have to take pains to rule out LIP as a secondary process. So you always have to investigate what is the underlying etiology of that LIP pattern, and most commonly it is due to Sjogren's syndrome. So this is Dr. Ganesh Raghu. He is the director of Interstitial Lung Disease Center in University of Washington. You find his name in most of the American Thoracic Society and European Respiratory Society guidelines, and he is the person who has set up the first ILD registry in India. And thank you for your patient hearing.
This is case 16, and this was the image which was provided with the history, which was 37 years male, known case of multi-drug resistant treatment. He was currently culture negative, but he continued to be symptomatic with the development of persistent dry cough and ground glass opacities seen on CT, along with some scattered nodules. And a diagnostic bronchoalveolar lavage was performed in this case, along with a transbronchial biopsy. And always the biopsy is done after the end of a lavage procedure in case both of them have to be done simultaneously. So when we sort of centrifuge the bile fluid, we got this brick red sort of a precipitate, brick red to blackish red precipitate, and this was what was seen on Newbar's chamber. So before we cytospin the bile fluid, we always have to do a Newbar's chamber count so as to adjust the cellularity and then do cytospun smears of the bile fluid. And to our great surprise, we found large number of macrophages, all of which contained those needle-shaped crystals. These are the cytospun slides stained by Leishman stain, and we can see the macrophages here, and these arrows point out to the negative imprints which are left by these crystals. So Leishman stain, that means there is some element of alcohol, so it looks as if that alcohol has dissolved those crystals which we had so vividly seen in the Newbar's chamber. Then what we decided to do is we made a wet preparation and observed them under polarized light. And this was the appearance of those crystals. Very beautiful, shocking orange-red color crystals were present. So do you all want to add anything looking at the history? Multi-drug resistant tuberculosis? Do we use any specific drug in those cases? Anything which is producing red color? Sorry? Suppose that drug is used in leprosy also, producing pigmentation of the skin. Suppose a person has lepra reaction, erythema nodosum leprosum, what drug is used? Okay, so what we finally called this was crystal storing histiocytosis. And in this particular clay, it was clofazimine, which is used in multi-drug resistant TB. Okay? So please remember that the drug is clofazimine, which produces these crystals. Now this phenazine derivative has bactericidal effects as well as anti-inflammatory effects. For the bactericidal effect, it was used in leprosy. It is now also used in MDR-TB because it binds to the mycobacterial DNA and inhibits growth. And it also exhibits anti-inflammatory effects, and hence it is used to treat conditions like erythema nodosum leprosum, and in the beginning it was also used to treat COVID-19 patients to prevent the cytokine storm. So finally this becomes like a clofazimine crystal storing histiocytosis. Clofazimine by itself is highly lipophilic, and that is why it is deposited predominantly in the fatty tissues as well as in the macrophages, and this is dissolved in tissue processing. So your cytological preparations using alcohol-based reagents is always going to dissolve the crystals. It is distributed in lymph nodes, subcutaneous fat, liver, spleen, small intestine, especially jejunum, and the skin, of course, and it has a prolonged half-life of nearly 70 days. So when we went back to the history, we found that the patient had stopped using clofazimine 3 months ago, and maybe after 20 days of stoppage of treatment, he started developing this persistent cough. Now, these are the adverse effects caused by the drug. Some of them are tolerated well by the patients. Some adverse effects require symptomatic therapy, and some require stoppage of drugs, and in some instances, the clinician has to resort to intervention or resections, and this is very true for intestinal obstruction, which is often caused by clofazimine. So in fact, if you look at the literature for clofazimine-related crystal storing histiocytosis, the first hit will be on the intestine. Now this was what was received as a transbronchial biopsy. And what we see here, apart from fibrosis, apart from cuboidal metaplasia, we see the widening of these alveolar septa by large number of these macrophages. Now most of the macrophage we saw as a rounded contour, but here what we see is that all the macrophages are little angulated. So, and in that angulated cytoplasm, you can see negative imprints produced by the crystals. So please remember that when you see macrophages looking almost as if you're dealing with a gouty tophus, especially in the lung, you always have to think of clofazimine, especially if the patient has had a multi-drug resistant TB. Now this is very rarely reported in the lung. We got only one case where the patient was treated with this drug for 27 years. And in our patient, the patient stopped clofazimine 1 month ago, but crystals were seen because of a long half-life. And currently the patient unfortunately is being treated with steroids, and we have a follow-up where there is a decrease in those ground glass opacities. So this was a very unusual case, and I hope next time when you get a bowel fluid, always do a wet preparation. Try and look at the macrophages, because normally alveolar macrophages are the predominant component of any bowel. And if there is any alteration in the ratio of macrophages to other inflammatory cells, it is considered distinctly abnormal. And if you find macrophages, please look at the morphology carefully so that all this diagnosis can be easily made. Okay, thank you.
And a CT scan showed bilateral patchy subpleural reticular opacities with honeycombing. So what we saw was, this is the low power view. One second. Okay, on low power. Okay, so on low power view, what we are seeing is, there is predominantly what we are seeing is a lot of fibrosis, especially in the peripheral location, within the interlobular septae, and what we are seeing is there are areas of relative sparing as well. So it's a very patchy distribution, with predominance being in the periphery and in the interlobular septae. Okay, so here again, so here again, if we see, what we are seeing is the centrilobular part of the lobule looks relatively spared, looks normal looking alveoli, and there is a lot of fibrosis seen at the periphery. Okay, this is the junction between the abnormal looking lung and the normal looking lung. And we also saw were areas where these alveolar spaces were lined by bronchiolar epithelial cells, and this is something which we called as microscopic honeycombing. Now at the junction, this is the high power view between the normal lung and the abnormal areas of fibrosis. What we are seeing is a crescent shaped bulge, which on low power appears a little bluish in color. This is because of these immature fibroblastic proliferation. but it distinctly protrudes within the alveolar space. So any clues to what could this be? Yeah, ma'am, we'll come to the diagnosis, but what could this be like? Yeah, so these are something which is called as fibroblastic foci, and fibroblastic foci are usually present at the junction of the normal lung with the abnormal looking lung. So which pattern do you all think? There's it's not difficult at all. So it's a fibrosis pattern which we've seen, and with predominant involvement of the periphery. So it was more like a subpleural fibrosis and involving the interlobular spaces as well. There was a very patchy distribution where you saw normal looking lung in the centrilobular areas and a lot of fibrosis in the periphery. So, and along with fibroblastic foci. So what we would call this will be a usual interstitial pneumonia, which is usually diagnosed on a surgical or an open lung biopsy. It's very difficult to pick up on a transbronch lung biopsy. So the role of transbronchial biopsy, like I said, is limited in this condition. Now, there are various ways, like the 2018 ATS ERS classification says, you call it, it's either UIP, it's a probable UIP, a possible UIP, and not UIP. So UIP is when you have a good clinical and a radiological, radiological point of view. They are sure it looks something like UIP, and on histology is something what you saw with all the features. So you're seeing fibrosing interstitial pneumonia, you're seeing more peripheral fibrosis, sparing of the lung, microscopic honeycombing, you're seeing fibroblastic foci. Okay, so so that's when you can call it probable. You can call it UIP. Probable UIP will be when you're seeing a lot of interstitial fibrosis, okay, but you may or may not see the microscopic honeycombing. So you might see a few of the features and few would be absent. A possible UIP would be when you see only interstitial fibrosis, so it's better not to label directly as a UIP. And not UIP would be something where you're seeing few of these features, but in addition, you're also seeing something like granulomas, and you don't want to call it as UIP. So you're seeing fibrosis, but you're also seeing granulomas in the biopsy, so that is definitely not UIP. And it becomes very important to find whether you're dealing with a case of UIP or you're dealing with a probable, possible, or not UIP pattern. So there is, with this recurrent microscopic injury, recurrent injury which is occurring over many years, you have this focal fibroblastic proliferation, and extensive collagen deposition eventually leads to respiratory failure. One very important thing which I showed you all, which you all have to look at the junction of the normal and abnormal appearing lung, is the presence of these crescent-shaped fibroblasts which protrude into the normal lung. So a careful search, even on low power, will help you identify these fibroblastic foci. And the more the number of fibroblastic foci, the worse is the prognosis. So this is a gross picture. If you ever look at the lung, this is what we call as honeycombing of the lung. Okay, so the various histological features which I told you. So the most important power of identifying UIP will be the lowest power. So if you have a 2x, especially like in Mayo and all, they see it at 1.5x, and that's where they get an actual picture of where exactly is the fibrosis seen in the biopsy. So a low power view before going on to the high power, the low power gives you half the diagnosis. So you see fibroblastic foci, and you're seeing something where, like I told you, you have peripheral fibrosis and the central area looks spared. This is what Dr. Henry Tazelar calls it as a donut sign, where you have peripheral fibrosis and central sparing. And it has a very, it's very temporally heterogeneous, varying patterns seen within a biopsy. So Dr. Leslie prefers calling it the patchy quilt appearance. So we had already told that this falls into the fibrosis prototype. So when you get such a kind of biopsy, how do you give a diagnosis? So you don't directly call it as UIP. What you need to call it as, your diagnosis would be a fibrosing interstitial pneumonia, and you say what all things you have seen. So it's a fibrosing interstitial pneumonia along with microscopic honeycombing. What is the activity of fibroblastic foci, whether it is high, it's intermediate, or it is low, and then you give a comment. So in view of the above histological findings, this matches with the clinical IPF, However, a good clinical and radiological correlation is necessary for the diagnosis. So that's how you will frame your report in this case rather than directly calling it as a UIP. Thank you.
So going to the next case, that is case number 10. So this is the history provided to you. A 37-year-old woman with Raynaud phenomenon presented with slowly progressive shortness of breath. She had no known exposures and she was on no drugs. The imaging showed bilateral, lower lobe predominant, reticulation and ground glass infiltrates with some subpleural sparing, and she underwent a Watts biopsy. So this is the picture that is provided to you. So based on this picture, what is the pattern? It is? So this is the pleura, this is the underlying lung parenchyma, these are the alveolar spaces, the interstitium. The interstitium is uniformly expanded by fibrosis and inflammatory cells. So what is the pattern? This is fibrosis pattern. And what type of fibrosis pattern? So fibrosis pattern, you have this UIP pattern which is just discussed by Dr. Hina. This is the NSIP pattern and this is the airway-centered fibrosis. So out of all these three, exactly, it is NSIP pattern. So this is the picture showing the scanner view demonstrating a homogeneous thickening. So this feature is very much important. There is homogeneous thickening of the alveolar septa with fibrosis and chronic inflammation, and along with that there is these many small lymphoid aggregates in this. These are the small blue, these blue ones, the small blue ones, these are the lymphoid aggregates. And this is the second picture, the closer view of the same. Again you find this interstitium which is very much expanded by variable amount of fibrosis and inflammatory cells, mostly lymphocytes and plasma cells. So this is the closer view of the lymphoid aggregate. What do you find in the center of this lymphoid aggregate? What is this in the center? There is germinal center. So lymphoid aggregate with germinal center. And what is this finding over here in this picture? This is, what is this? This is pleura. And how is the pleura? Is it normal? It is very much thickened by, how is it thickened by? It is thickened by fibrosis and also few scattered inflammatory cells. So this is the summary of the biopsy findings. We saw that there is NSIP pattern with homogeneous thickening of interstitium by fibrosis and chronic inflammation. Apart from that, we found lymphoid aggregates with germinal center formation, and we also found that there is chronic fibrosing pleuritis. So coming to the clinico-radiopathic correlation, 37-year-old young woman with Raynaud phenomenon, no known exposures, no drugs. Imaging showed bilateral, lower lobe predominant reticulation, ground glass infiltrates with specific biopsy findings. So what is the diagnosis? Young woman with Raynaud phenomenon, connective tissue disease. So final diagnosis is non-specific interstitial pneumonia pattern, NSIP pattern favoring connective tissue disease as the underlying etiology. So coming to NSIP, NSIP is the name of the histologic pattern due to again a variety of etiologies, and when there is no specific cause, no etiological agent identified, then it is termed as idiopathic NSIP, and idiopathic NSIP is the second most common idiopathic interstitial pneumonias following idiopathic pulmonary fibrosis. So IPF is the most common idiopathic interstitial pneumonia, and this is followed by idiopathic NSIP. And multidisciplinary discussion is important to make the diagnosis and decide the treatment direction, because I said NSIP has a varied etiology. So non-specific interstitial pneumonia is categorized into cellular, fibrotic and mixed cellular and fibrotic types. So these are the potential etiologies with NSIP pattern. The connective tissue disease, which is the most common, chronic hypersensitivity pneumonitis can show NSIP pattern, adverse drug reactions, infections, immunodeficiency diseases healed acute lung injury, smoking-related interstitial fibrosis, interstitial pneumonia with autoimmune features, which is also called as IPAF, and this is still under research. This can show NSIP pattern, and again, idiopathic fibrotic NSIP. So all these entities can show this NSIP pattern, out of which connective tissue disease is the most common. So coming to the radiology, the NSIP pattern is lower lobe predominant, and it shows bilateral, symmetrical, ground glass, and reticular opacities with subpleural predominance. So this is the bilateral ground glass infiltrates opacities on which are bilateral. Apart from that, there is traction bronchiectasis. So this is the traction bronchiectasis which is seen here, and there is absent or sparse honeycombing which differentiates this from IPF. So coming to the diagnostic criteria for fibrotic NSIP, diffuse and uniform interstitial fibrosis. So this is very important, diffuse and uniform interstitial fibrosis. Unlike the usual interstitial pneumonia, where the fibrosis is what? Heterogeneous, and it is patchy. But here it is diffuse and it is uniform. It involves mainly the alveolar walls and variably also the interstitium of the bronchovascular sheaths and the pleura. And the distribution of fibrosis is even and homogeneous, and there is preservation of underlying lung architecture. This is another feature which differentiates this from UIP. In UIP, there is patchwork fibrosis and there is distortion of the underlying architecture, whereas but in NSIP, there is preservation of this underlying architecture. This may or may not be associated, fibrotic NSIP may or may not be associated with inflammatory cell infiltrate, and the pattern is temporally homogeneous, temporally uniform. Again, this is in contrast with the temporal heterogeneity of UIP, where in UIP you find fibroblastic foci, active fibroplasia, dense fibrosis, and adjacent to that there is normal lung parenchyma. But here there is no normal lung parenchyma. It is completely involved by this, uniformly involved by fibrosis, and there is absence of microscopic honeycombing and fibroblast foci more often than not. More often than not indicates that microscopic honeycombing and fibroblast foci may occasionally be present in NSIP, but it is not as frequent as in UIP. So coming to the histological features of CTD, lymphoid aggregates with germinal centers, extensive pleuritis, prominent plasmacytic infiltration, and dense perivascular collagen and positive autoimmune serology. So all these are features of the underlying connective tissue disease which is seen associated with this NSIP pattern. So coming to the pathological differential diagnosis for cellular NSIP, hypersensitivity pneumonitis is the first differential for cellular NSIP. You can see that here also, this is a picture of NSIP, of HP. But apart from this cellular infiltrates, you can also find these vague granulomas in HP. Next, lymphoid interstitial pneumonia is differential for NSIP, but again, these interstitial inflammation is very much dense when compared to NSIP. Next, organizing pneumonia is also differential, but in organizing pneumonia you find these organizing pneumonia polyps. These branching structures which are present, these are the OP polyps. So for fibrotic NSIP, the differentials include UIP and chronic HP. This is the UIP pattern where I said that there is patchy presentation of this fibrosis, whereas in NSIP it is uniform, and other fibrotic lung disease also enter into the differential diagnosis of NSIP, fibrotic NSIP. The clinical course prognosis is variable, but it is better than IPF, and the clinical course depends upon the extent of fibrosis. So the key points here: do not sign out the report simply saying that it is NSIP. Always search for the clues for the underlying etiology. Connective tissue disease is the most common underlying etiology of NSIP pattern. Hence, extensive serological workup has to be done. Extensive serological pattern indicates that, it is an extended panel, not the basic serology. Sometimes when the underlying CTD is not detected, you have to go for extended serology. Next, idiopathic NSIP will be ultimately a clinical decision and should never be a top-line pathological diagnosis. So this is a paper by Dr. Maxwell Smith, update on pulmonary fibrosis. Not all fibrosis is created equally, and this is a freely downloadable article, and you find that he has given, very nicely, he has given the diagnostic features of all the fibrosis patterns.
And this is me with Dr. in Mayo Clinic with Dr. Henry Taslar. He is the course director. This is Dr. Maxwell Smith. This is another fellow from Germany, Dr. Christoph. And this is the lady sitting right here in the front seat, Dr. Harika, my fellow, Zila fellow. And this is me. And thank you for your patient hearing.
Yeah, one thing before starting this case is just that the pathologist who is able to recognize a UIP well on an open lung biopsy has definitely mastered the art of pulmonary pathology. Okay, so with that, we move on to the next case. That's case 13. Yeah, I'll just slide show. Yeah, this was a 42-year-old male who presented with breathlessness since 6 months, and CT scan showed bilateral reticulonodular shadows with enlarged hilar lymph nodes. So this is what we got, and if you observe that there's a particular, it's like a well-defined nodule. It has a particular pattern, and most of the lung parenchyma here is appearing normal. Okay, so you're seeing a lot of well-defined nodules. Let's go to the high part to see what they are. Okay, so here we can see that they are well-defined discrete nodules. They have giant cells, they have granulomas, okay, and it's enmeshed within a collagen matrix. So, any clues to the diagnosis? So it was along the along the lymphatics, within the intralobular septae, and they were well-defined nodules and they were non-necrotizing. Okay, very good. So this was a case of pulmonary sarcoidosis where you have a granulomatous inflammation. It's usually having a good lymphangitic spread. They are well-formed granulomas. Isolated giant cells are rare. And interstitial pneumonia or organizing pneumonia is also rare. Under which pattern do you think this pathology will fall into? Yeah, very good. So it would fall into the nodule category. And we have to, whenever you see granulomas on a biopsy, you have to rule out the other causes of granulomatous inflammation. The topmost in our country being tuberculosis. We did not see any necrosis. However, whenever you see granulomas, it becomes mandatory to do special stains to rule out the presence of tuberculosis and other infective lesions like fungal and parasitic. Then sarcoidosis was already described here. You can also have granulomas in granulomatosis polyangiitis. Hypersensitivity pneumonitis can have granulomas, although like how Dr. Sharda explained, they're usually very vague. You don't have such well-formed granulomas. And Talg granulomas and berylliosis is lower down on the list, but berylliosis has similar kind of granulomas to sarcoidosis, and it really sometimes becomes very difficult to differentiate one from the other. So when you have granulomas, you need to see the morphology of granulomas. Are they coalescing? Do they have necrosis? Where are they located? Are they located along the lymphatic routes? So that's how you can narrow down your diagnosis. So the morphology of granulomas, the distribution of granulomas, and the presence or absence of necrosis definitely helps in reaching a diagnosis. So in sarcoidosis, they are small, discrete or confluent granulomas. They are of uniform size, give a very nice nodular appearance, and they have hyalinization. The alveolar walls, interstitium around the airways and all may be normal. And you can have inclusions. You may be lucky to find inclusions at times, but most of the times you might not find them. So the inclusions can be Schumann bodies, asteroid bodies, Hamazagi-Weissenberg bodies, and slit-like crystals. And sometimes you can have a fibrinoid kind of necrosis. So this is how an asteroid body looks like. And this is how a Schumann body with calcification looks like. So if you find them along with this pattern of distribution, you're really lucky and to get a diagnosis of sarcoidosis. ACE levels becomes very important, so don't report it without ACE, although in some cases you can have sarcoidosis with normal ACE levels as well. So in 50 to 80% of cases, the ACE levels are increased, and it tends to rise and fall with activity, and sometimes when the patients are in remission also, the ACE levels are high. Okay, so it's useful in monitoring the disease, but mind you, like I said, in remission also sometimes the ACE levels are high. And a normal ACE level does not rule out sarcoidosis. So it becomes a difficult diagnosis, but yes, you have to look at the pattern, distribution, and the presence or absence of necrosis. So that's about sarcoidosis. And going on to the next case. So this was a 50-year-old male patient who presented with cough and hemoptysis since 4 months. And a CT scan showed right lower lobe consolidation with areas of necrosis, and an open lung biopsy was done. So this is what we saw in the open lung biopsy. So it's a large vessel. Here you have the bronchus. So this is the bronchovascular area. And what you are seeing over here, so even at this part you can make out that there is some inflammation within the vessels. So we're dealing with some kind of vasculitis. Okay, so a higher par view of the same, showing evidence of inflammation. What we also saw was this kind of basophilic necrosis, okay, and we saw a few giant cells scattered. So again, what we're seeing is like a vasculitis with this kind of basophilic necrosis, and you have a palisading of histiocytes. Same. The other vessels showing similar features and evidence of giant cells. So what do you think is the diagnosis? Very good. So it's granulomatous polyangiitis. So this is what we saw, areas of necrosis, basophilic necrosis, vasculitis. There was a granulomatous inflammation, necrotizing vasculitis, giant cells, and with palisaded histiocytes. So yes, like you rightly said, it is granulomatosis with polyangiitis, previously called as Wegener's granulomatosis. So where do you think this category of the granulomatosis with polyangiitis falls into? Which category? So again, it's in the nodule stage. Okay, so it's a rare systemic inflammatory disease of unknown etiology where the major histological manifestation is vasculitis, usually involving the respiratory tract, both the upper and the lower respiratory tract, and kidneys. And the mean age group is 50 years, and a C ANCA, that is cytoplasmic or classical ANCA, is usually positive, and that helps in the diagnosis. So radiologically, what you see is presence of these numerous nodules, and you usually have waxing and waning of these nodules. So that is one clue where you can see waxing and waning of nodules, and sometimes you can have a central area of cavitation. This is the gross picture. So at autopsy, what you'll be able to make out is there'll be presence of multiple nodules with central area of cavitation. And this is what we see on microscopy, where the necrosis is usually basophilic, and you have a palisading of histiocytes. So there are various differential diagnoses before we come to a diagnosis of granulomatosis with polyangiitis. So first is ruling out a granulomatous infection, Churg-Strauss syndrome, lymphomatoid granulomatosis, bronchocentric granulomatosis, and a necrotizing sarcoid granulomatosis. So let's rule out one with the other. Let's see the main key features which will help you differentiate one from the other. So differentiating a GPA versus the infective lesions, the lesions in the infective etiology are usually solitary, though they may not be, and then it becomes a little difficult. Necrosis is usually an infarctoid necrosis in infective lesions, whereas it's a collagenous necrosis in cases of GPA. To differentiate it from Churg-Strauss syndrome, asthma is a prerequisite to call it a Churg-Strauss syndrome, and eosinophils are characteristic finding which you did not see with GPA. And ANCA is, it's C ANCA with GPA, whereas Churg-Strauss usually has the perinuclear ANCA positive. To differentiate it from lymphomatoid granulomatosis, what you see is the pale shadows with large necrotic lymphoma cells will be seen with lymphomatoid granulomatosis, and a granulomatous inflammation is rare in a lymphomatoid granulomatosis. So bronchocentric granulomatosis and GPA also becomes a very close differential diagnosis, where in a bronchocentric GPA, you need to see other features of GPA. The renal sinus involvement and a positive ANCA serology will help you coming to a diagnosis. And the last is differentiating it from sarcoid granulomas, where the ANCA is always negative in sarcoid, and that will be positive with a GPA. and extrapulmonary involvement is seen in less than 10% of cases with sarcoidosis. So that's how, in a nutshell, to be able to explain how you can differentiate sarcoid. And in the second case, we've discussed how we can differentiate granulomatosis with polyangiitis from the rest of the list. Thank you very much.
So going to the next case, that is case number 11. Why this is not? Yeah, a 47-year-old woman had a motor vehicle accident. Due to the presence of rib pain, she underwent imaging. So accidentally, so she had met with an accident and underwent imaging, and this showed 2 rib fractures and hazy upper lobe infiltrates. So because of the presence of this upper lobe infiltrates, she underwent a CT scan which showed upper lobe predominant nodules and few small cysts. She underwent biopsy, and apart from that, she also has a history of smoking for many years. So this was the picture that is provided to you. So based on the first picture, what is the pattern? This is the vessel, and you can find this big nodule over here. So what is the pattern? Out of the 6 patterns? Nodular pattern. So these are the other images. So this picture shows that this is, so what is the appearance of this nodule? Okay, pink. It's pink. It is a stellate nodule. It is a stellate nodule. It is not a round nodule, isn't it? The borders are not round. The borders are just infiltrating into the surrounding lung parenchyma. It is a stellate nodule. And this nodule is surrounded by these emphysematous changes. Here, the alveolar spaces are dilated. So this is the nodule in the center, nodule here, and this nodule is surrounded by these emphysematous changes. Then this is the next picture. Again, the nodule has this stellate appearance, and this time, this is a pink nodule. And this is the older fibrotic stellate scar. And you see that these tendrils, this is just like the octopus, the tendrils of the octopus, this lesion is extending into the surrounding alveolar lung parenchyma, giving the Medusa head appearance. And this is the other picture, and high power view of the nodule. And so you find that these nodules are composed of many cells which are of varying composition. And again, the high power view of the same, of the nodule, you find that there are a lot of inflammatory cells. So these inflammatory cells there are eosinophils, few eosinophils scattered here and there. Then these numerous pigmented macrophages. This brown pigment which is present in the cytoplasm, these are the pigmented macrophages. Here you find these pigmented macrophages. Apart from that, you find these cells. And these cells, what are these cells? Yes, what are these cells? They are Langerhans cells. So these cells, how do you describe these cells? They have this pink indistinct cytoplasm and this characteristic nucleus, which has a characteristic which is highly irregular and it is convoluted. And apart from that, you find that there are small grooves also inside the nucleus. So this is the typical appearance of the Langerhans cell. So we have done a CD1A immunohistochemistry stain, and this CD1A highlights these Langerhans cells. So these are all the Langerhans cells which are seen in the form of clusters. So mind you, these Langerhans cells in this Langerhans, so what is the diagnosis first? Langerhans cell histiocytosis. So to call it as Langerhans cell histiocytosis, these Langerhans cells, they have to be present as clusters and not as singly scattered, because Even in normal lung parenchyma also you find Langerhans cells, especially around the airways. But to diagnose this as LCH, you have to find these Langerhans cells in the clusters. And these are the other associated findings in this lesion. So what is this? What are all these? What is this structure? This is the respiratory bronchiole. And in the center, what are these? These are the smokers macrophages. These are smokers macrophages. And this interstitium, there is this dense eosinophilic ropey collagen, which is called as smoking related, which is present in the smoking related interstitial fibrosis. So this is respiratory bronchiolitis along with smoking related interstitial fibrosis in this picture. And this is how the smokers macrophages look like under hyper. So you find this brown colored pigment in the cytoplasm. Apart from that, you can also see some black specks. Are you able to identify the black specks in the macrophages? So this is a typical appearance of a smoker's macrophage, and this you have to differentiate from a hemocitrin-laden macrophage. So how does this hemocitrin-laden macrophages appear? Even they have also the brown pigment, but those brown pigment, that is goes and it is granular in hemocitrin-laden macrophages. And in smokers macrophages, this brown pigment is fine, relatively fine, and apart from that, we find these black specks in the cytoplasm. So these are smokers macrophages. So this is a summary of biopsy findings. We found that there are scattered, variably sized stellate nodules with cystic spaces at the periphery, and they have a typical bronchiole-centric distribution. And the nodules are present. Nodules are composed of classical Langerhans cells with varying numbers of lymphocytes, plasma cells, eosinophils, and smokers macrophages. And the older fibrotic lesions, they have few Langerhans cells and few eosinophils, but there is more fibrosis. And surrounding lung showed smoking-related changes like respiratory bronchiolitis, emphysema, and smoking-related interstitial fibrosis. So coming to the clinico-radiopathocorrelation, upper lobe predominant nodules with few small cysts in the imaging and history of smoking. So the diagnosis is Langerhans cell histiocytosis. So this is Paul Langerhans. He is the German pathologist on whose name this entity is named. So Langerhans cell history, coming to pulmonary Langerhans cell histiocytosis is also called as eosinophilic granuloma, Langerhans cell granulomatosis or histiocytosis X. This is a proliferating disease of Langerhans cells, and about more than 90% cases are associated with smoking, history of smoking, and hence it is considered to be a smoking-related disease. Pulmonary Langerhans cell histiocytosis is distinct from systemic Langerhans cell histiocytosis. It is thought to be a reactive process initially, but a subset of them show clonality. Coming to the clinical features, most of the patients are asymptomatic, like in our patient, the other symptoms are chronic cough and exertional dyspnea, and around 15 to 25% may present with spontaneous pneumothorax. So, and in advanced cases, pulmonary hypertension and also vasculopathy can be found. So this is a typical radiological appearance of LCH. This is also upper and middle lung predominant disease, and in the early disease you find multiple bilateral centrilobular cellate nodules with surrounding ground glass opacity. So these arrows, they point to these ground glass, these white dots, these are the ground glass opacities. And in advanced disease you find these cysts. So these arrowheads, these point to these cysts. So these cysts are bizarre shaped cysts. These are not like the thin wall cysts of LIP, but they are thick walled and they are bizarre. And in advanced disease, you also find emphysema, reticular opacities, and honeycombing. So coming to the microscopy, it has two forms, stellate and fibrotic. I have already shown all these features, so I'm not going into the details. And it also can show features of pulmonary hypertension. Next, coming to the electron microscopy, we all know that under electron microscope, we find Bieberg's granules. And as I said, a subset of this PLCH cases, they show BRAF V600E mutation. So in Mayo Clinic, all the cases of LCH, they do a BRAF mutation studies. And there are other mutations in MAPK genes as well, which have been identified. Coming to the differential diagnosis of cellular LCH, nodular infections, neoplasms and other nodular lung diseases like GPA and Hodgkin disease, they enter into the differential diagnosis in cellular phase of LCH. And when the cysts are prominent, then lymphangioliomatosis, which I'll be talking about next. So that will come into the differential diagnosis in fibrotic LCH. All cases of fibrotic lung diseases can be a differential diagnosis of fibrotic LCH. So it has an unpredictable course, even with smoking cessation. Some spontaneously resolve while others remain stable, and some progress to honeycomb fibrosis. In cases where there is pulmonary hypertension and advanced fibrosis, the prognosis is worse, and the treatment modalities include smoking cessation, immunosuppression with corticosteroids, cytotoxic agents, and lung transplantation in advanced cases. So coming to the key points, always in Langerhans cell histiocytosis, it is the smokers macrophages and the eosinophils which actually catch the eye. So whenever you find these pigmented smokers macrophages and eosinophils, always search for the Langerhans cells. And in older fibrotic lesions, they only have a few Langerhans cells. So in those cases, stellate scars with a background of smoking-related changes like respiratory bronchiolitis, emphysema, these are sufficient for a diagnosis of features consistent with healed Langerhans cell histiocytosis. So this is the snow-capped mountains, the Cascades in Seattle. Thank you. This is the carbon pigment. Yes. In smokers macrophages. It is hemosiderin. So going to the final case of today's session, the rest of the cases we are not discussing the cases, we'll just give the diagnosis due to the constraint in time. So, so this is case number 18. So a 48-year-old woman with imaging showing bilateral randomly distributed cysts. This was the history that was given to you, and these were the pictures provided. So based on the first image, so what is the pattern? The final pattern. Minimal change pattern. Do you see any abnormalities here? Under this bar? So this is a minimal change pattern. And so, yeah, under scanner you do not find any, it looks absolutely normal. But when you really see carefully, you find these small nodules. These small nodules. And also these cysts. So under high power, this is the high power of the same, of these areas. So under high power you find, when these areas under high power, you find that the walls of these cysts, they are expanded by these nodules. And these nodules are composed of these spindle-shaped cells. So this is how it looks, the spindle-shaped cells. The nodules are composed of these spindle-shaped cells, which are nothing but the characteristic myelomonocytic LAM cells. These cells are spindle, they are fusiform, plump, and the nucleus is large and it has a high NC ratio. So this is the HMB45. This is the nodule, and this HMB45 highlights these LAM cells. So summary of the biopsy findings: numerous thin wall cysts scattered throughout the lung parenchyma. The walls of the cysts are expanded by clusters of abnormal myeloid LAM cells, and these cells are positive for HMB45. So coming to clinico-radiopathocorrelation, woman, imaging showing bilateral randomly distributed cysts. So what is the diagnosis? Lymphangioliomatosis. So LAM is a rare cystic lung disease. It occurs exclusively in women of childbearing age. This is a member of the Pecoma family of neoplasms under the recent WHO classification. It occurs spontaneously, less commonly as part of a tuberous sclerosis complex. The patient may be asymptomatic, or she may present with cough, dyspnea, chest pain, pneumothorax, hemoptysis, and sometimes the chyloptysis. So this is the typical radiological HRCT picture of LAM. We find there are a lot of numerous, what are these? The arrows are pointing to what? Cysts. So thin wall, these cysts are thin wall cysts and they do not have any upper lobe or lower lobe predominance. Whereas in LCH also cysts were there, but they have which lobe predominance? Upper lobe predominance. But this cysts in LAM, they do not have any upper lobe or lower lobe predominance. So coming to the microscopy, I have already discussed, and apart from that, these LAM cell clusters can also be found in lymphatics, pulmonary vasculature, and can even infiltrate the parenchymal lymph nodes. These cells, they have an unusual myelomonocytic phenotype. They are positive for SMA, Desmin, HMB45, MART1, and MITF. They are also positive for estrogen and progesterone receptors, but they are negative for cytokeratin antibodies. So ruling out the other entities, the other cystic lung diseases like pulmonary Langerhans cell histiocytosis. As I have already shown you, this LCH have nodules composed of these smokers macrophages, eosinophils and Langerhans cells. Then lymphoid interstitial pneumonia of Sjogren's, which I have already discussed. Then emphysema. In emphysema, there is only enlargement of air spaces. We do not find any smooth muscle nodules. Birt-Hogg-Dubé syndrome. Low-grade spindle cell proliferation such as benign metastasizing leiomyoma, endometrial sarcoma, stromal sarcoma. So cytological features along which IHC helps in ruling out these possibilities. So coming to the treatment, anti-hormonal treatment is given in some cases, and in advanced cases it is lung transplantation. Currently a lot of clinical trials are going using agents such as mTOR inhibitors and angiogenesis inhibitors and all. Then the other point I want to say is the diagnosis of LAM can also be made by measuring these levels of vascular endothelial growth factor D in the patient's serum. So coming to the key points, the biopsy findings can be focal and subtle. So whenever you find a minimal change biopsy, always you have make it a point to go to the high power and observe for findings such as these nodules and or blood vessels. So in LAM, it is the smooth muscle nodules which you find in the cyst. So biopsy findings can be focal and subtle and may appear absolutely normal at low pass. Hence, a careful examination high power is essential. Clinical and radiological correlation is very much important. So whenever you find women of cystic lung disease in a woman of childbearing age, always this should raise a suspicion for lymphangioliomyomatosis. So this is Pulmonary Pathology Teaching Club. We are presenting this diagnostic pulmonary pathology web series. This is started by me with continuous guidance and mentoring by Dr. Pradeep Vaidishwar sir. And we are doing this online webinar series to promote pulmonary pathology, which is a less explored subspecialty. So we have completed with season 1 and season 2, and we have eminent speakers from Mayo Clinic, Cleveland Clinic, University of Texas, and University of Virginia Commonwealth, and from AIMS and PGI. We have successfully completed season 1 and season 2, and we'll now start, either in August or September, we are going to start season 3. And this is the team, Pulmonary Pathology Club team, Dr. Pradeep Vaidishwar, Dr. Gayatri, Dr. Deepa, and this is me. And this is our Facebook page where we post cases every fortnight, lung cases every fortnight. So thank you for your patient hearing. Yeah. I don't have much experience on this serum monitoring levels of VEGF. I just wanted to mention that as a point. That is Dr.
We really don't know because like if TTF will not help. TTF will definitely not help. Right, right. They might, ma'am. Like they might come positive with type 2 with florid type 2 pneumocyte hyperplasia.
So the other cases, we are just announcing the diagnosis of the rest of the cases which we have not discussed due to time constraint. So this is case number 17. Yeah, this is case number 17, and This was the image that was provided to you, that was circulated, and this is a case of diffuse pulmonary nodular ossification. Diffuse pulmonary nodular ossification associated with hemosiderosis secondary to cardiac disease. So this is the diagnosis of case number 17.
Yeah, just to complete the list, few other cases which we could not discuss because of lack of time. One was asbestosis. So I'll quickly just move through the slides. So this was one case, like where we had this beaded appearance. So this was the case of asbestosis. Also, we could not discuss amyloid. So I'll just show you how it presented with, so that, so this is granulomatosis with polyangiitis. And so this was the presentation with multiple pulmonary nodules. And this is what we saw on microscopy. And it was positive for Congo red. Like it showed bright apple green birefringence with Congo red stain. And and one more interesting case was where we saw, this was an autopsy case, and we saw it was a minimal change pattern, and the predominant involvement was in the blood vessels. And there was also malignancy so there were tumor emboli, and this was a case of something which is called as pulmonary tumor thrombotic microangiopathy. So this is how there is a lot of fibrocellular proliferation within the blood vessels. So it becomes important to differentiate it from primary pulmonary hypertension. And so this is what we saw, a lot of like fibrin thrombi, and in addition we also saw carcinomatous lymphangitis. Right? So this was a case of PTTM, that is this pulmonary tumor thrombotic microangiopathy, also called as PTTM. So these were the cases which we could not discuss because of lack of time. Thank you very much for your patience. Thank you. You can continue.
Thank you so very, very much to all our guest speakers for all these very, very interesting cases. I think we all have learned quite a bit, seen quite a bit of what we have never seen before. I now request our chairperson to applaud our speakers and also give a memento to Dr. Hina. The other two we did give once before, so. Dr. Hina Desai. Ma'am, please. I request our respected medical superintendent to please honor our longest serving chairperson. So please. Thank you very much. So,
So I thank all the three presenters for this very excellent and very elaborate and thorough presentation of so many variety of cases. So it's definitely an academic feast of pulmonary pathology for all of us. And we are so lucky to be here on this wonderful presentation. Thank you. And also thank you for giving me such long tenure as a chairperson.
Next, we'll move on to another interesting part, especially for the postgraduate students here. We have the slide quiz. All the postgraduates can come on one side so that you can look at the slides. And I request our professor and head of department to conduct the session. Ma'am. Yes. Ma'am. Yeah. Yes, yes. All the postgraduates can please come on this side, in the center, and take your papers. So as the slides are flashed, you can write down, please mention your name, the year you are in. Are you a first year postgraduate, second year, or a final year postgraduate? And the name of your institute. And against each case, you can write your diagnosis. So sit on a side where you can see the slides properly, so you can sit in the front. I'm sure a lot of you are carrying pens. Are there people who don't have pens? I hope everyone has is everyone settled? Okay. Okay, we have we have a dictum from this side. The postgraduates should sit a little far from each other. At least alternately you have to sit.
In alternative seats.
Yeah. And it's you have a certificate and prize for this, so make sure you get the diagnosis right, not your friend next door. Okay, we trust you. It's okay. You please be comfortable. Yes, we do. Don't worry. I hand over the mic to my HOD. Ma'am.
It's not
Display.
So, good afternoon, everyone. And we have 15 cases. So, these are the instructions to the participants. So, total number of cases are 15. And write one or few salient features and then write the diagnosis. And in case of a doubt, give one or two differential diagnosis. And where the diagnosis is obvious, the exact histological type is mandatory to get full marks. Okay, so total number of cases are 15. For few cases, I will focus the gross photo, microscopy, and for few cases, I will give the IHC results also, and for few cases, only one slide. So depending upon the case, it is variable. Okay, so shall I start now? Are you ready? Have you written your names and everything, college name? Yes? Okay. So this is case 1. 55 years female with 8 centimeter nodule on the scalp. So this is the clinical history. And this is a gross picture of that case. And one is the gross findings, and second one is the cut section of that gross specimen. Okay. So these are some of the histological findings. Is it okay? Are you able to see? Lights off. One. So this is the histological finding. Okay. And now another area is showing these type of cells, and focal area showing 2 types of cells here, and another focus showing this is the picture, and one more picture. So again I will repeat, or else, Okay. So this is one, second picture, third, and this is one. What's the diagnosis? So write your diagnosis and write 1 or 2 points, important points, and write the diagnosis. So that is case number 1. So now we'll move on to case number 2. 20 years female, presented with ovarian tumor, and we received the ovarian tumor for histological examination, histopathological examination. So this is the gross specimen, and the second one is the cut section of the specimen, and some of the microscopic pictures, microphoto pictures. Okay. Are the slides are clear? Huh? Lights could off check. So that light also. Okay, they have to write kada okati unchu. So this is another area. Okay. So the ovarian tumor with these features. What's the diagnosis? Okay, we'll move on to the third case. 40 years male, presented with mass lesion lung. 40 years male, presented with mass lesion lung. So these are the histological pictures, histopathology, microphotography. Diagnosis, please. Okay. So case 4, 65 years female with lump breast, 65 years. So this is the gross specimen, cut section of the gross specimen. And these are the microscopic pictures. So this is a scanner view of the lesion. And this is the lower magnification. And another higher magnification, closure view. So these are all the tumor cells in the higher magnification. So diagnosis, please. Okay. Case 5, thyroidectomy specimen for histopathological examination. So we have received thyroidectomy specimen for HPA. So one is the gross specimen and second one is the cut section of the tumor. And this is the scanner view. This is the scanner view of the tumor. Okay. And this is the lower magnification. And there are focal areas showing this type of picture. So the extensive areas of microscopy showed this picture. And this is another view of the same case. Diagnosis. Okay. Case 6. 18-year-old female presented with mass on the skull, size 22 into 18 into 2.5 centimeters, with deep, thick wrinkles spread across the whole of the skull. The wrinkles were about 2 centimeters in width and 1.5 centimeters in height with multiple nodules and focal ulceration of the skin. So this is the clinical history. This actually presented as a small lesion, small soybean-like lesion over the left side of the skull since birth. The skin and hair covering the lesion were normal. With the patient's growth, the mass enlarged gradually and covering skin became thick and wrinkled without other complicated symptoms. In the past 5 years before the admission, the lesion enlarged and covered most of the skull. The patient had normal consciousness and intelligence. So this is the gross specimen we have received. And second one is the cut section of the specimen. So these are the histological slides, histopathological slides. And this is the scanner view of the lesion. This is the scanner view of the lesion. And this is the tumor component in lower magnification. This is another field showing these type of findings. That is in the deep dermis. So these are the lesion findings in the deep dermis. So diagnosis, please. Okay. Case 7. 55-year-old female with lump in the breast for 3 months. On examination, 3 into 4 centimeters lump in the upper outer quadrant with skin induration and ulceration over the nipple. We received mastectomy specimen measuring 12 into 10 into 4 centimeters. On cut section, the tumor is irregular form, grayish white. Along with this, we have received the lymph nodes also. So these are some of the microscopic pictures of that. This is from the tumor proper. So wherever there is a grayish white area we have identified, we have taken number of pictures from that area. So this is one focus. So this is the higher magnification. That's the closure view of that. And this is the another area in the low power. And the same area in the higher magnification. And another area showing this picture. Diagnosis, please. Okay. So case 8. 38 years female with history of filariasis, right leg, and ulcer with satellite nodules over the shin of the right leg, biopsy from ulcer for histopathological examination. There's a known case of filariasis with ulcer on the leg. So the patient presented with ulcer and satellite nodules for that elephantiatic filariasis for a period of 2 months. And the lymph nodes were palpable in the right inguinal region, discrete, soft and non-tender, and all other investigations are normal. So this is the clinical picture of that. And these are the microscopic pictures, and this is the scanner view of the lesion. And this is from the tumor proper. That is from the lesion proper. From the edge of the ulcer, we have given the bits. So this is the higher magnification. Diagnosis, please. Case 9. Female 40 years presented with pain abdomen with mass attached to left mid-ureter. Mid-ureter. So this is the scanner view. The pointer shows the tumor proper. So these are the sections from the tumor. So this is another area. So this is the previous one, and this is the second picture. Diagnosis, please. Okay. So case 10, 32 years female, complaining of foul smelling discharge, cervix pap smear. So this is the only slide in this case. So pap smear. Diagnosis. Okay. Case 11, 48 years male, presented with erythematous brownish lesions with a smooth surface distributed mainly on the trunk. And on examination of lower limbs, decreased protective sensitivity in both feet was detected. So we have taken beads from the erythematous brownish lesion which is present on the trunk. Sorry. Okay. So something happened, I could not focus that. Okay, we'll go to the next one. 8 years female child with recurrent painful swelling over the dorsum of the nose since 5 years, distorting the nose with extension into the nasal cavity. 8 years female child with recurrent painful swelling over the dorsum of the nose since 5 years, distorting the nose with extension into the nasal cavity. So the patient actually presented with ill-defined violaceous plaque on the nose, small plaque on the nose only. So this is the clinical photograph, and we have been following this case for more than 6 to 7 years, and the patient has recurrent attacks of the lesion on that particular area, and apart from that she has also developed the lesion in the chin also. So in 2017, at the age of 3 years, initially presented a small plaque-like lesion over the dorsum of the nose, whereas in May 2018 it was excised and given the diagnosis as the hemangioma, and it was again recurred in 2009, and it again excised and diagnosed as the hemangioma, and in 2010, again the small swelling over the nose was excised with histopathological diagnosis of glomangiopericytoma. Okay. And in December 2010, a similar swelling over the chin of 6 into 4 centimeters was excised. The swelling over the chin did not recur after the surgery. So in the year 2011, she was referred to the plastic surgery department at a higher center with complaints of epistaxis, no airway obstruction for the management, and the debulking was done, and the defect was covered with the superiorly based nasolabial flap from the left side. So the swelling was again recurred after 3 months of surgery with the nasal bleeding. So the last surgery was done in year 2012. So these are all some of the pics. So this is a scanner view from the lesion nose. So this case we have been following meticulously for the last more than 7 or 8 years. So this is a scanner view, and this is the lower magnification. The lesion in the lower magnification. Yes. So this is another area. Okay. And one more focus. And another area. Diagnosis. So this is very interesting case. I will discuss in detail about this case afterwards. Okay. Okay. So case 13. 32-year-old male presented with hemoptysis and cough with expectorations in 6 months. CCT of the chest shows a large, well-demarcated, smooth surface lesion of 15 into 10 into 8 centimeters in the posterior aspect of the mid and lower zones of the left thoracic cavity, well confined by the costal pleural layer. The lesion showed a mixed irregular cystic necrotic areas and irregular enhancing solid areas. So these are all the CECT findings. So basically, patient presented with hemoptysis and cough with expectoration for 6 months duration. So this is the specimen we have received. This is the gross specimen we have received from the cardiothoracic department. And these are all the microscopy picture. So one is in the lower magnification, and the lower left it is in the higher magnification, and the remaining are in the lower magnification. So a clue to this is tumor cells are positive for vimentin, CD99, CD56, and BCL2. Pan-cytokeratin, EMA, SMA, chromogranin A, and CD34 were negative. So the tumor cells are positive for vimentin, CD99, CD56, and BCL2. Okay. Case 14. A 50-year-old male smoker presented with cough and expectoration. And this is the specimen from autopsy. So this is the gross specimen. And these are the microscopy pictures. This is another area showing typical finding. Diagnosis. So this is the last case. 42 years female with mass in the parotid region. So this is the low power view of the tumor. And this is another area. So this is one low power view, and this is another area. Diagnosis. Finished. Okay. Thank you. So all PGs please hand over the papers to Sri Lakshmi or Bharati, please. PGs, please hand over the papers. ఇది నేను నెక్స్ట్ ఆన్సర్స్ చెప్పాలి. Please hand over the papers. Bharati, shall I start now? Okay. So, coming to the in detail description and the diagnosis of the cases, okay? So the first case is 55 years female with 8 centimeters nodule on the scalp. And this is a gross appearance showing the nodular appearance. And the cut section shows both the predominant solid as well as the cystic areas are seen. And the tumor in the scanner view. And it's arising from the deep dermis only, no contact with the epidermis. And this picture shows cells arranged in the lobules in the deep dermis. The tumor is limited to the dermis and arranged in the lobules. And here you can see the circumscribed tumor with clear-cut clear cells as well as the eosinophilic cells. And the same in the higher magnification with clear cells and the eosinophilic cells. And some of the areas showing these tumors arranged in the tubular formations along with the presence of eosinophilic material within the lumen. And focal area showing the cystic areas with the cholesterol clefts. So the diagnosis is eccrine acrospiroma, which is a benign skin adnexal tumor, and you'll find both clear cells as well as the eosinophilic cells microscopically. And one of the important clues sometimes is if you see any lumen or acinar pattern with the secretions in the lumen, and along with if the location of the lesion is the scalp or the face and the neck area, always think of the adnexal tumor, okay? So coming to the second one, 20 years female with ovarian tumor. So this is a gross appearance, tumor with variegated appearance. And these are all the solid sheets of pleomorphic cells, which is commonly seen in which type of ovarian tumor or testicular tumor? Pleomorphic cells, almost appearing like that of the poorly differentiated carcinoma. Why so much? So poorly differentiated, almost it appears like that of poorly differentiated carcinoma. So usually it is one of the microscopic picture of embryonal carcinoma, okay? And there are focal areas of cystic areas are seen, and the pleomorphic cells with high mitotic activity. And this all of you can easily identify with the typical Schiller-Dovell bodies are seen, and there are hyaline globules are present. So whenever there's a typical lesion is present, you are supposed to search for another component, particularly in the ovarian tumors as well as in the testicular tumors. Most of the times there are mixed germ cell tumors. So the focal area showing the reticular pattern with the glomeruloid bodies also. And this is a mixed germ cell tumor, predominant yolk sac tumor with the focal area of the embryonal carcinoma. So if the embryonal carcinoma is a predominant, the prognosis is bad to the patient. So this is about the mixed germ cell tumor. Usually it is positive for the AFB. AFB is alpha fetoprotein, always invariable, it is positive in the yolk sac tumors. So moving on to the third slide, mass lesion in the lung. And these are the proliferating masses of the fungal hyphae called the fungal balls. All of you can easily diagnose with this COVID and everything. We are very well versed with that of the aspergillosis and all varieties of the fungus, and particularly that. So you can see here the fungal balls as well as the fruiting bodies are seen. And another area showing the septate hyphae with acute angle branching. So the diagnosis is nothing but aspergilloma. So the aspergilloma, it appears as two types. One is colonizing as well as in the invasive aspergillosis. So coming to the fourth one, 65 years female with lump breast. So this is the cut section of the mastectomy specimen. On cut section, it is circumscribed, lobulated, grayish brown mass. And this is a scanner view showing sheets of tumor cells with areas of hemorrhages. Extensive areas of hemorrhages are seen. And these are all the pleomorphic tumor cells with marked nuclear pleomorphism. And if you see in that high power, which I have focused, there is a brown pigment is present within the cytoplasm of these tumor cells. So we did the Fontana Massenstein for the malignant melanin pigment, it was positive. And HMB45 is strongly positive in this case, and it is diagnosed as malignant melanoma of the breast. So it may be primary or metastatic, and usually if the primary melanomas usually present as large masses under microscopy, there is no glandular tissue is seen amidst the tumor cells. So that is one of the hint for us to differentiate. And usually it's very difficult to differentiate the primary or metastatic lesion. So moving on to the fifth case, thyroidectomy specimen, and this is a gross specimen. We have received the lobectomy specimen, and the cut section showed the circumscribed grayish white nodule, and this is a scanner view showing adjacent normal thyroid along with the adjacent tumor, and this is a lower magnification of the tumor proper. Tumor cells are present along with abundant amyloid deposits. So here you can see that amyloid, extensive areas of amyloid, homogeneous eosinophilic amyloid material which is present within the tumor. And you can easily appreciate the plasmacytoid appearance of the tumor cells, and the nucleus shows stippled chromatin, which is very, very, very typical finding in case of medullary carcinoma of the thyroid. So plasmacytoid tumor cells with nucleus showing the stippled chromatin, and focal areas also showing the multinucleated giant cells, and some of the tumor cells are also spindle in nature. So this is medullary carcinoma of the thyroid. So it may be sporadic or hereditary. Most aggressive if it is associated with a MAN2B. So then moving on to the case 6, 18 years female with mass in the skull, and the patient presented since birth. See here, this is the clinical picture of that case. So almost the tumor is completely occupying the scalp area, and here and there you can see the ulcerations on the surface of this. So all these ulcerations are present. So the wrinkles are almost 2 centimeters in width and 1.5 centimeters in height. And this is the cut section of the tumor showing the which is grayish white. And these are the microscopic pictures showing the normal epidermis, and predominantly complete tumor it is in the dermis only. So it is a dermal lesion, and these are all the nests of round to polygonal nevus cells in the upper dermis. And here again in the left side, that is the tumor cells along with that foreign body giant cell reaction. And this right side you can easily appreciate the spindling of the cells, which is commonly seen during the maturation of the nevus, and particularly in the deep dermis. Okay. And this is a post-operative photograph of that patient. And the diagnosis is giant congenital melanocytic nevus. So because it is present on the scalp, we gave the report as giant congenital melanocytic nevus of the scalp. So there are 3 patterns may be recognized. One is the compound or intradermal, second one is the neural nevus, and third one is the blue nevus. So vast majority of the sporadic, but sometimes familial cases are also described. So the James William had classified the congenital melanocytic nevi into 3 types depending upon the size of the lesion. If it is a small size, less than 2 centimeters is the small size. Medium size is around 2 to 20 centimeters. Giant congenital melanocytic nevus, which is also known as the giant pigmented nevus, giant cerebelliform nevus, garment nevus, bathing trunk nevus, and the size is around more than 20 centimeters. So in our case, it is more than 20 centimeters lesion. And remember, if the size is more than 40 centimeters, usually there is increased risk of malignant transformation. So case 7. So 55 years female with a lump in the left breast. And this is the gross specimen. And only few streaks of grayish white tumor areas are present here. And these are all the sheets of round cells with abundant eosinophilic cytoplasm, and the nucleus appears as if it is uniform in all these tumor cells. So here this is a higher magnification for you to appreciate the large cells with abundant pale eosinophilic cytoplasm with uniform nuclei. And here and there you can see that here in this field, which I have focused there, in the lower magnification, if you see on the left side, there's a large cell with markedly hyperchromatic nucleus. And this you can easily appreciate. You cannot ignore these type of cells in the mastectomy specimen. It's a large cell with hyperchromatic nuclei and diffuse sheets of lymphocyte around these tumor cells. And these are all the nodules of histiocytic cells. There are nodules of histiocytic cells seen predominantly in that particular tumor area. And here also you can see the multiple nodules along with some of the papillary formations are also seen. And here you can appreciate the large cells with bizarre shaped tumor cells with hyperchromatic nuclei. There are 2 or 3 are seen. So these are all the few bizarre cells with hyperchromatic nuclei. And here also you can see the sheets of histiocytic type of cells. And here you can see the large histiocytic cell along with that of the tumor cell. And these are all the foreign body giant cells. And extensive areas of collagenization. Extensive areas of collagen is seen in the microscopically. And these all of you can easily identify. These are nothing but the cholesterol clefts along with the foreign body giant cells. And elastosis of the some of the areas are present. So this is described as elastosis of the ducts as the or blood vessels. And the lymph nodes invariably showed the, is it lymph node normal? So there are metastatic deposits are present in the case. So this is the post-operative area and with complete recovery of the patient. So this is, diagnosis is infiltrating duct carcinoma with the post-neoadjuvant therapy changes. Post-neoadjuvant therapy changes. All pathologists, we should know what are all the changes that are seen in a case of the neoadjuvant therapy. So nowadays, treatment of patients with systemic agents before definitive surgical removal of the carcinoma, it is known as neoadjuvant therapy. And it was originally used as a standard treatment mainly for the inflammatory and inoperable locally advanced cases only. But now increasing numbers of women with earlier stage operable breast cancers are now being treated with the neoadjuvant therapy before surgery. So with the advances in the image-guided core needle biopsy, sentinel lymph node biopsy, new breast imaging like MRI, there's increase in the ability to accurately classify and stage the carcinomas before surgical excision. So nowadays the trials are going on to give the neoadjuvant endocrine therapy as well as neoadjuvant targeted therapies also. So what are all the changes that are seen in the tumor proper as well as in the adjacent normal breast tissue? So in the tumor proper, there is a marked reduction in the tumor bulk as well as the cellularity of the tumor. And the reduction in the cytological ATP or tumor cells may appear bland or sometimes may appear hyperchromatic. And acquisition of foamy apocrine cytoplasm tumor cells almost mimic like that of the histiocytes. So in number of sections, we have find only those histiocytic aggregates of cells, occasional pleomorphic cells. So most of the times we won't get the information from the surgical faculty, whatever it may be, and we need to get the information whether the patient is given neoadjuvant therapy or not before the surgery. And changes also occurs in the normal breast. So the pathological examination of the excised tumor bed is the gold standard, and it is essential for identification of the groups of the lesion, whether it's the partial response, which is commonly seen in 60 to 70%, or pathological complete response, typically seen in 15 to 28% of the cases. So in our case, this is the partial response to that of the NAT. So the American Joint Committee on Cancer and International Union for Cancer Control of the Tumor, Metastasis and the Breast Cancer Staging, they use Y to designate the stage after the neoadjuvant therapy. And here in the clinical staging, we have to write it as YCTN. And for pathological staging, we need to write the YPTN or YPTNM. And whenever you are measuring the tumor area also, the tumor is measured as the largest single focus of the residual invasive tumor. Remember, we are not supposed to include the areas of fibrosis within the tumor bed. So that point you should remember. So that's about the case Sivam. So case 8, 38 years female with history of filariasis with ulcer on the leg. And this patient presented with the lesion of elephantiasis with a 2 months duration of the ulcer, and the lymph nodes are palpable. All investigations are normal. So these are the clinical picture, an ulcer measuring almost 12 into 10 centimeters with a depth of 2 centimeters, everted, friable margins, necrotic base, and black in color with satellite nodules. Multiple nodules are seen around the main mass. And this is the scanner view, and multiple dilated vascular channels you can see. Along with the vascular channels, the lymphatics are also present in the lower dermis. And these are the sections from the tumor proper, and this is the description of this particular area. It is nothing but anastomosing vascular channels lined by atypical endothelial cells and spindle-shaped pleomorphic cells. Then the diagnosis is anastomosing vascular channels lined by atypical endothelial cells along with the spindle cells. What is the diagnosis? Anastomotic vascular channels with atypical endothelial cells and with marked pleomorphic cells. Okay. So this is another area showing the solid sheets of pleomorphic tumor cells with the prominent nucleoli. And these are sections from the lymph node show the tumor deposits within the lymph node. And the possibilities what we were considered as one is angiosarcoma, malignant melanoma, poorly differentiated carcinoma. And we did all the IHC studies, HMB45 and cytokeratin negative, and CD31 is focal positivity. Then the diagnosis is, now you should tell. So the diagnosis is angiosarcoma in long-standing case of filariasis. So then moving on to the case 9. Female 40 years with mass attached to the left mid-ureter. So this is the ureter. You can easily identify the ureter on the left side and the tumor proper in the wall of the ureter. And is a lower power. You can easily see the nests of tumor cells, and you should appreciate the delicate vasculature. So nests of tumor cells along with the delicate vasculature, and the tumor cells are arranged in gel ball pattern with uniform, round, oval to polygonal cells, and surrounding the delicate vasculature. The diagnosis is, so everything I have told, like all features I have described. So we did that IHC markers also, diffuse chromogranin A positivity in the tumor cells, and the sustentacular cells showed the S100 positivity. So that then diagnosis is paraganglioma, and paraganglioma of the ureter is very, very rare. So the differential diagnosis, it may be malignant melanoma, granular cell tumor, large cell neuroendocrine carcinoma. You need to do the IHC markers for differentiation from other tumors. So like in the large cell neuroendocrine carcinoma, cytokeratin positive, granular cell tumor, it's strong diffuse positivity for S100 protein. So then case 10, 32 years female with pap smear, and now you can easily identify. So they are nothing but trophozoites of Trichomonas vaginalis. Always you have to remember that. So this pointer shows the trophozoites here. This is one. And here also you can see 2 or 3 with small flagella are present, but they are not clear cut. So these are the trophozoites of Trichomonas vaginalis. So whenever these pap smear is given, you need to report it as whether it is a conventional smear or LBC, and NILM with presence of the Trichomonas vaginalis. And in this, another important feature to be remembered is 3-dimensional clusters of polymass. If you see that, you have to search for the Trichomonas. So like which are known as the polyballs. So next case 11. So this is erythematous brownish lesion, and which is present on the trunk. Here also, so I could not focus the histopathology figure, why I don't know. And for this, we have done the Phytopharraco stain. Now you can easily diagnose this. And Phytopharraco shows the presence of lepra bacilli. And the diagnosis is the histoid Hansen's disease. And why you have to diagnose and you have to remember this variant is, it is an aggressive form of lepromatous leprosy, and it's a variant of leprosy with highly transmissible variant, and even though it is very rare, you should be in a position to diagnose this. So usually it appears as spindle cells, tightly packed spindle cells, and along with this, you need to do that differential diagnosis. All spindle cell tumors, like benign fibrous histiocytoma, all varieties of spindle cell tumors. If you do the Phyt Ferraco, if it is positive, you can easily diagnose these cases. Yes. So this is case 12, which is interesting, and we have been following for more than 8 years. So I described everything and the recurrent lesion, and this is the ill-defined plaque-like lesion on the nose, and this is a scanner view of the lesion, and this is the lower magnification. The tumor has a lobular architecture. You can easily appreciate the lobular nature of the tumor with proliferation of ill-formed vascular channels. Wherever you see there are vascular channels are present. So the proliferation, it is infiltrative in nature and with extension of tumor into the deep soft tissues. Here you can appreciate all these nodular lesions and they are infiltrating into the deep soft tissues, which is an important criteria here. And this is another lower power view, and you can see the sheets of well-formed capillaries, or ill-formed capillaries which are arranged in the nodular pattern. So this is another area showing proliferation of ill-formed vasculature with spindle cells, remember, without any atypia. There are no mitotic figures, no atypia. All tumor cell appear alike and with ill-defined vasculature and the nodular appearance. So this is the higher magnification. See here, after the recurrent surgeries, so this is the fate of the patient. Almost it caused the complete erosion of the nose, and with you can easily see the almost erosion up to the bone itself. Okay. And the differential diagnosis we thought of, one is hemangioma. It may be tufted hemangioma, or spindle cell hemangioendothelioma, Kaposi sarcoma, or angiosarcoma. So the hemangiomas usually appears as nodules are red in color, and juvenile and cellular hemangiomas, they lack spindle cells. So that's one important point by which you can easily differentiate with the routine hemangioma. Tufted hemangioma, it does not show the infiltrative nature of the tumor, which is seen here. Then spindle cell hemangioendothelioma, usually it appears as large cavernous spaces, thrombosis, and the calcospherules, that is calcifications are present in spindle cell hemangioendothelioma. Whereas Kaposi sarcoma, it is ruled out with the presence of large nodules, broad fibrosis with scanty inflammatory cells, and deep extension to the soft tissues, which is not seen in the Kaposi sarcoma. And angiosarcoma, as you already have seen that case, there is marked pleomorphism with anastomosing vasculature that is lacking in this particular case. So we did number of IHC studies, almost more than 15 IHC markers we had done with the help of Dr. Arjun Rao from USA. And the tumors, but we thought we have been following this case for more than 6 or 7 years. We need to give the correct diagnosis to the patient. For that reason, we took special interest and we have done all IHC markers. So like in IHC markers, positivity of the lesional cells with the factor 8, CD31, CD34, and positive for the new vascular marker FLE1. So that is the characteristic IHC marker here. So the muscle markers MSA and SMA they stained only smooth muscle in the vessel wall, but were negative in the tumor cells. And the desmin is also negative. And GLUT1 and HHV8, they are both negative in this case, confirming that the lesion is not congenital hemangioma or Kaposi sarcoma, in which HHV8 should be positive. So these are all the IHC pictures, and this is the factor 8 and CD31 diffuse positivity, CD34 diffuse positivity, FLE1 diffuse positivity. And this is HHF35, GLUT1 and HHV8 and desmin all are negative. And the diagnosis is multifocal cutaneous Kaposiform hemangioendothelioma. So the patient has a lesion on the nose as well as in the chin. Chin lesion has subsided, but there is marked recurrences in the nose lesion. So the diagnosis is multifocal cutaneous Kaposiform hemangioendothelioma. So these are vascular tumors of childhood that can occur in the deep areas such as the retroperitoneum as well as in the superficial areas. And it's a locally aggressive, non-metastasizing vascular tumor. Remember, locally aggressive, non-metastasizing. So characteristically, it involves the multiple tissue planes and destructive osseous changes are seen. And most of the cases, almost 50% of the cases, these tumor cells, the tumors are associated with that of the Kasabach-Merritt syndrome with lower platelet count. And luckily in this patient, in all visits we have done the hemogram and the platelet count was almost within normal limits only. And after debulking was done and the defect was covered with a superiorly based nasolabial flap from the left side. So this is the clinical picture after the major plastic surgery, and this is from the anterior view. And in the last year she came to our department during the pandemic time with the mask, and we could not identify her. And she is now doing well and completely healed, and there are no recurrences from that last surgery. Okay. So I gratefully acknowledge Dr. Arjun Rao, Director of Residency Program, Wisconsin, USA, for providing IHC images for this case. And for the next case also, he has given the IHC study report. So next, moving on to the case 13, and male patient present with hemoptysis and cough with expectoration. And this is the gross specimen we received. And the left pneumonectomy specimen and cut section show 12 into 8 centimeter circumscribed tumor, whitish yellow in color and soft in consistency and compressing the adjacent lung parenchyma. There are focal areas of hemorrhages and necrosis, and focal cystic areas are also seen. And these are all, most of the field showed the spindle-shaped tumor cells which are arranged in short fascicles and sheets with oval vesicular nuclei. There are areas of necrosis. That is the only finding we have observed in all the sections. So we got that IHC report, like tumor cells are positive for vimentin, as I already described during that questioning, like CD99, 56, and BCL2 are positive. And we could get this study also, and this patient showed the typical translocation of X18, and which is usually seen in the it's a very important point, translocation, X18 translocation. This is a fish which is seen in synovial sarcoma. So this is a case of primary pulmonary monophasic synovial sarcoma. So the primary pulmonary monophasic synovial sarcomas are extremely rare, and along with that, monophasic fibrous synovial sarcomas are most common subtype of the synovial sarcomas. And the diagnosis of monophasic synovial sarcoma in unusual sites of the lung is a diagnostic challenge, and often it is misdiagnosed. And the definite diagnosis required IHC and the fish. So typical translocation. Okay. So then case 14, 50 years male smoker, typical history smoker, 50 years. So this is the autopsy specimen, pneumonectomy specimen, and cut section showed the white tan, soft, friable tumor. Diagnosis is, okay, densely packed tumor cells with ill-defined cell borders, scanty cytoplasm, small round cells, round to spindle cells with elongated nuclei, and finely granular nuclear chromatin with inconspicuous nucleoli. Nuclear molding is present, mitotic figures are seen, individual cell necrosis is present, and this typical HFRD effect is seen, which is nothing but the basophilic staining of the vascular walls due to the encrustation of DNA from the necrotic tumor cells, which is seen in which type of tumor of the lung? Yes, small cell carcinoma. And this is a typical finding which is seen not only in the small cell carcinoma, in high malignant tumors, pleomorphic tumors, you can see this HFRD effect. As far as the lung is concerned, it is seen in the small cell carcinomas. And this is a highly malignant tumor, and there is no known pre-invasive phase or carcinoma in situ to the small cell carcinoma, and it's usually associated with the paraneoplastic syndromes, which we'll teach to the undergraduate students. And most of the time it is in the cigarette smokers only less than 1% occurs in the non-smokers. Okay, so now moving on to the last case, 42 years female with mass in the parotid region, and these cystic areas are present, papillary areas are seen, and which are lined by the oncocytic epithelial cells and the lymphoid stroma, And within the lymphoid stroma, you can see the follicular centers also. The epithelial component is formed of the inner columnar, outer polygonal cells, polygonal to the cuboidal cells. Diagnosis is, yes. So Warthin's tumor, it is also known as cystadenoma, lymphomatosum papilliferum. And remember, this is also common in the males and the smokers, and usually occurs in the 6th and 7th decade. And it's the most common benign salivary gland tumor, and found most of the times it is seen in the multicentricity, and the bilateral presence is most common with that of the Warthin's tumor. And remember, it is not only seen in the parotid gland, sometimes this tumor is also seen in the periparotid lymph nodes also. And grossly it appears as a lobulated brown mass, typical multicystic appearance, and with fluid filled spaces filled with a dark brown fluid, which is typically, it's almost like that of the motor oil appearance. And it shows the prominent lymphoid tissue along with the germinal centers, and the surface of the lymphoid tissues are lined by the bilayered cells. Thank you very much. Okay, you can take the platform.
Thank you so much, ma'am. So did you all enjoy yourself? So how many did you get right? 5? Good. So I think you have learned a lot from that slide seminar, and we'll have the results soon. We have corrected your papers. And with that, we come to the end of a very, very exceptional day, where we have learned from the best of the best and thoroughly enjoyed learning from all these people. And I hope you enjoyed as much as we enjoyed putting it together for you. And as I sign off, I would like to hand the mic over to our organizing secretary, Dr. Sharma sir, for the valedictory function. But before I do that, I have a very pleasant work more to do. I would like to felicitate my own HOD, and I would like to call our dear principal sir to please give a memento and a certificate to Bhagyalakshmi ma'am, please.
Thank you, sir. Usually mothers should not be gifted.
Yes, that's what.
That is thing. But somehow, as she told, so remember, but that's like in Mother's Day, like any occasion.
Okay, Mother's Day. Okay.
So this, let's say this mother of the department of HOD.
Okay, sir.
Madam,
Thank you.
please
Thank
come
you
this
very
side, and let it be better one. Okay.
Thank you, sir.
Congratulations for this organizing.
Thank you so much, everyone. I will say goodbye, and God bless you, and Jai Hind. Thank you.
So very good evening, everyone. I already see people leaving. Why don't you please stay back for 5 minutes? So I promise you, we're going to have the shortest ever valedictory function in the world. We are going to set it. We are going to set it. So I call all the dignitaries to run onto the stage. So that was colloquial anyway. So it was really a soulful session. Our hearts were filled with knowledge and lungs have become clear, sir. Thank you very much. All the three esteemed speakers, we felt like quite energetic even till the end of the day. We don't feel it's a strenuous session. That itself is a indication for all of us. I could see the smiles on the faces of all the audience present over here. And I hope the same, it's same with all the online audience also. Those of you who are seen there, thank you all for being with us. So to close this ceremony and for the prize distribution and appreciation of all those who have been present here, who have helped us to make this event a successful one, we are going to have this valedictory function. I first invite our principal, Dr. Radha Madhav Tripathi sir, to come over onto the dais and occupy his. Then I invite our medical superintendent, Dr. A. Krishnamurthy Shastri sir, to come over onto the dais. And now I request our head of the department, Dr. A. Bhagilakshmi madam, to come over onto the stage, please. And the Secretary, Indian Association of Pathology and Microbiology, AP chapter, Dr. E. Kiran Kumar, who happens to be the head of the Department of Pathology at Gayatri Vidya Parishad Medical College, our neighboring medical college. Friendly neighborhood. Okay, so are we all through? Ready on prizes, student volunteers? Okay. So, as we have already given our pathology closing marks, now we would like to have our principal's closing remarks of the whole of the event, and then we'll propose the prize distribution and then the vote of thanks. So, principal sir.
Thank you, Professor Sharma. He announced that this should be the shortest time to get the Guinness Book of Record. So I congratulate all the partners, stakeholders of this CME for 8 hours journey, and very successful one. I think this is one of the best CME. This is my observation. And the participation was very good. The speakers, they delivered excellent speech, and discussion was very nice. At the end of that, Professor Bhagyalakshmi also gave some quiz, and it's very good from all the aspects. This was a very successful thing, and as usual, the tail of the ceremony, only tails will be there, only you can count the number within fingers. At the busiest hours will be only in the lunch hour. As usual, everything normal as per the CMER conference. So again, you have enjoyed the whole of the day without any cultural activities. That is there a deficiency what I marked. Otherwise, everything, thank you all. And thank you again, and we wish that such type of CMER conference can again be organized by the same department under the leadership of Professor Bhagyalakshmi Garu, if possible. State conference you can hold. If Dr. Kiran gives the permission, then the same venue or in the better way also you can organize. Thank you all.
Thank you for your encouraging words, sir. Thank you very much. So, CV Lakshmi madam, మీరు ఎక్కడున్నారు? వెళ్ళిపోయారా? నాకు ఇందా నుంచి అదే భయం వేస్తాను. Okay, so we would like to have audience opinion, one audience opinion. Not from my medical college, of course. They'll say everything is good. AMC, మీకు ప్రైజ్ వచ్చినా ఇవ్వాలి మీరు చెప్పబోతే. You can say from there, no problem.
Good evening, respected professors and my dear friends. I am first year PG from MIMS Vijayanagaram. Actually, I am a student of Bhagyalakshmi Madam in AMC in my undergraduation. This is my first CME, and I am proud that I have attended this under ma'am's guidance. The lectures are all very good, they are very informative and a lot inspiring for
Pradeep sir, you are hearing now?
My name is Samira, sir. lectures are very inspiring, and for a new first year PG like me, they have created much interest on the subject, and I'm very pleasure to be here, and it's my honor to speak like this in front of many reputed pathologists and my dear professors. Thank you.
Thank you very
for
much,
giving this
Doctor.
opportunity.
Wish you all the best. Okay. Anyone from AMC? Your time starts now. 1, 2, 3. Someone come, be fast. I promised the fastest ever valedictory function. Shortest one, yeah.
Shortest feedback.
Say ABC and close.
Respected everyone, my name is Harichandan. I am from AMC second year. Actually, I am here just because of our Bhagyalakshmi madam only. Initially, I am not at all interested in pathology. After coming to pathology, I started studying just because of her madam. I have nothing more to say. That's I want to say.
Shortest ever, very good. Thank you. So, before we propose a vote of thanks, we have, first thing is that we appreciate the undergraduate students who have participated, who took an active part in helping us in organizing this event. So, I'd like to name all those student volunteers. So, I'd like our principal, sir, for inculcating the discipline in these undergraduate students to hand over the certificates of appreciation to the student volunteers. Jayateja. Tejasri.
Right? The girl in the evening hours. During my evening work, I meet not in other places and don't meet her. Okay.
Sai Dakshita. Tell your other friends to collect their certificates from Madam, Bharti Madam later on. Okay? Fine. Quiz prize is ready, yeah?
Only one.
Quiz is Madam and you, sir. Madam, quiz results are out. So, sir will give the certificate and Madam will give away the prize. So, the third prize goes to Andhra Medical College, Dr. Harichandan. The second prize goes to NRI Institute of Medical Sciences, Dr. Jansi M. Tane namalakapotundi. Idamavata.
No.
She is not believing herself.
No, I don't.
Shall we give the photo
See,
prize or not?
That is things. Before giving prize to our college, I should think twice.
Yeah.
Huh? The audience should give privilege.
Think twice and give, sir. Think twice and give.
If no complaint, definitely we have to give it. Huh?
No conflict, sir.
No one knows the cases, everything.
And first prize goes to Andhra Medical College, Dr. Sai Ranjani.
I want to interrupt. I know I said goodbye, but since ma'am and sir are here, I think we should honor our organizing secretary who has worked so very, very, very hard, made all of us work double as well. So I request ma'am and sir, and I think both the dignitaries. Ma'am, please.
How do you feel about Professor Sharma? Looking like a doctor or politician? Political pathologist. Political pathologist.
Thank you so much, sirs and ma'am.
Thank you very much for all the love, sir. And now I propose the vote of thanks before we disperse. First of all, the first and foremost thanks is to IAPM AP chapter for giving us the permission, for giving us this opportunity. The next immediate thing is that our management, especially our patrons, Dr. G. Venkatratnam, our medical director garu, and Sri DJ Bharat Reddy, our CEO of ANES, they passed the message to our principal and Dr. Radhamadhav Tripathi, our Lord Krishna, and our superintendent, Dr. Krishnamurti Sastri garu. They have immediately said, you should do and you have to do. And so our madam, Dr. A. Bhagyalakshmi garu, she pushed it on to us, and then she said, yes, we are doing. That's how we are here. And as an organizing secretary, what I have to say is, you have all organized me, and so I am the organizing secretary. So we have a team of pathologists. We have a team in our department. You all know the most popular Vandana. then Dr. Sri Lakshmi, my senior when I was doing my MD, Dr. S. Sri Lakshmi. Then where is Anand? Where is Anand?
They should all come here. Come here for a photograph.
Yeah, please, all of you, come here.
Please come. All
Yes,
of the
yes.
whole department, including PGs, if they are.
I am calling each one of them, sir. I am calling each one of them. Anand is not? Anand Pilvaya. Okay. So next, Dr. Praveen, Dr. Bharati, Assistant Professor, Dr. Harika, Assistant Professor, and Senior Resident, and our Blood Bank in charge, Dr. Amruta, and Senior Postgraduates, Dr. Veronica, Dr. Sravanti, and again Dr. Sravanti, and then Dr. Divya. Come over. Then the first year postgraduates, our official photographer Sandhya. You can't come up, you have to take the photographs. Come. Then Dr. Sushma and our proud prize winner Jhansi. Tomorrow lunch. And Dr. Aliveni, she won't eat. Yes, madam, sure. So, in proposing the vote of thanks, the next important thing is the information technology team, who have made it possible for this event to go on here and also to go on live in similar fashion with no complaints. We have been following right since morning. There is never one single complaint. Everybody is saying the transmission is good. Thank you all, IT team. మీ గణనాయకుడు G. Subramanyam garu and Subramanyam garu and Pavan. And then comes the business development team, the branding team. Mr. Sai Kiran, Balraju, whom we call as Tod Dongalu. They are always, they move together always. And their head, Priyarha. And I thank all the participants who have come here from various places, who are present here, made it more than 100 physical and more than 400 online, totally making this a 508 participation. If we had made 33 more, we would have equal to the parliament number, as sir said. And the last event of the day is a snap with our esteemed speakers. All our department is ready, sir. All the 3 speakers, please come over. Let's have a snap. Thank you all. Thank you very much. And one thing is regarding the certificates. The last thing that is, the first thing that is required for all of us, of course, but the last thing that has to happen is to give over the certificates of participation, delegate certificates. Please come over. The delegate, this is for online, sir. Please wait, everybody. These certificates have to be signed by the IAPM, and then they have to be signed at the Andhra Pradesh Medical Council at Vijayawada. So it will take 3 weeks or maybe a little more also. Please bear with us. Once we get all those certificates back, we'll post a soft copy in the WhatsApp group. After that, we'll try to send them by post. Okay? Thank you.